this final panel, and that has been the need of the hour. And it is AI and public health in India, ethics, evaluation, and scaling. As we move forward, I would like to acknowledge that we were successful in getting the best panel on board, an interministerial coordination that we had expected, like a convergence, and our international counterparts. So just to introduce you, I'm thanking you all for being here on a Sunday morning. I think yesterday I had a flurry of calls when they realized it was a Sunday morning, 9 a.m. But I thank you all for making it for this panel, because this has been a show of strength and a soft launch for our institute. That is a new institute, that is the National Institute of Digital.
ये नहीं चाहिए A very good morning, esteemed guests, dignitaries, and my dear colleagues. A very warm welcome to this pivotal session on transforming urban health policy, a call to action for sustainable, equitable, and healthy cities. I'm Dr. Anushri, and I'm delighted to welcome you all to this conversation on behalf of Health System Transformation Platforms. Before we begin, I would like to briefly introduce the organizing institute behind this session, HSTP. Formally registered as the Forum for Health System Design and Transformation under the Section 8 and incubated by the Tata Trust, we are a non-profit organization dedicated to generating and applying evidence to inform and support health policy and systems reform in India. The organization works closely with several state governments, including Karnataka, Odisha, Madhya Pradesh, and Meghalaya across a wide range of thematic areas such as the urban health, health financing, human resources for health, non-communicable diseases, and health insurance. Among its recent initiatives, HSTP is leading the Samagra Mother and Child Project in Mysuru with the support from the Infosys Foundation and is also conducting in-depth research to strengthen urban primary healthcare in Mysuru, Bhopal, and Bhubaneswar, which is backed by Gates Foundation. Notably, HSTP has played a key role in conceptualizing the Healthy City Action Plan for Bhopal, the first of its kind initiative to address the urban health challenges. In Odisha, HSTP continues to provide strategic and technical support to their government flagship programs. The organization is also working to build up the capacity across the health workforce, rolling out competency-based trainings for pharmacists, lab technicians, and CHOs. We are also developing leadership programs for senior health officials as in collaboration with IIM Calcutta. As cities continue to grow, the urgency to reimagine how we deliver healthcare in urban spaces grows with it. With this, we come to the agenda of today's session, from governance to financing, from workforce development to community engagement. This session is an opportunity to reflect, share, and act upon the future of urban primary healthcare. We are so privileged to have with us a panel of eminent speakers and thought leaders who bring wide range of experiences and ideas to this discussion. To stir this thought and conversation, I would like to invite our Honorable Chair for the session, Sushil Vimal Sir, to please have the stage. Sushil Vimal Sir serves as a Deputy Commissioner to the National Urban Health Mission, NUHM, with the Ministry of Health and Family Welfare. He mainly focuses on collaborative efforts to integrate various national health programs within the NUHM framework. I would now request our moderator for the session, Sudha Chandrasekhar ma'am, Advisor HSTP, to take her place on the stage. Ma'am brings 25 years of comprehensive experience to national, state, and global levels across the medical, research, and administrative sector. She also serves as the advisor to the Health System Transformation Platform. We welcome you, ma'am and sir, and I would like to hand over to ma'am now to lead the session now. Thank you, everyone.
Good morning, everyone. It's a Sunday morning, and I understand that we had a few minutes of delay in starting the session, but we'll ensure that the deliberations are not limited. So I would now like to request Rajiv Sadanandan sir to come on to the dais. He has been the former Additional Chief Secretary Health Kerala and also former CEO of HSTP, and he has led many national programs both in the ministry and at the state, and also served as advisor to the Chief Minister of Kerala during the COVID time, and also acted as a commissioner for the Lancet Global Health Commission, especially focusing on financing primary care. So we welcome you, sir. Now I would like to request Dr. Santosh Mathew, sir, to join us on the stage. He leads the portfolio on social and public finance policy in India for the Gates Foundation. He has held top leadership positions as Additional Chief Secretary for Bihar and also the chairperson of the National Council for Teacher Education. He has also served as a Joint Secretary at the Ministry of Rural Development, Government of India, and acted as the country director for Leadership for Environment Development Program in India. We welcome you, sir. I'd like to call upon Srinivas sir from Tata Trust. He has been one of our guiding lights since the HSTP has been initiated from the Tata Trust, and he is a healthcare management professional with over 25 years of experience, held various positions including in Satya Sai Hospital for Emergency Management, LV Prasad Institute and Reliance Foundation. His expertise is marked by leadership in terms of diverse healthcares and managing complex public-private sector initiatives with government bodies. So current focus is on leveraging technology to build scalable models for primary care and preventive healthcare delivery at the Tata Trust. We welcome you, sir. We have amongst us Dr. Ashima Bhatnagar, ma'am. She's the Deputy Secretary for Ministry of Health and Family Welfare and has been actively involved in shaping policies under the National Urban Health Mission and also fostering collaborations to improve the primary healthcare in the urban settings, which is so relevant in the current setting. So, and she has also significantly contributed to architecture many national health initiatives, including the Indian Public Health Standards IPHS 2022 and also the Pradhan Mantri Ayushman Bharat Infrastructure Mission. We welcome you, ma'am. I would like to now request Dr. K. Madan Gopal sir, advisor, NSHRC, and he serves as the Public Health Administrator with the Ministry of Health and Family Welfare and leads crucial initiatives concerning the IPHS standards and establishment of the public health management cadres and governance reforms. He has played a significant role in shaping the flagship national health initiatives, including the Ayushman Bharat PMJY, the earlier RSBY, the State Health Index, and the National Digital Health Mission. So we look forward to listening a lot on these from you, sir. I would like to welcome Air Commodore Ranjan Kumar Chowdhury, sir, advisor with the National Health Resource Center. He serves as the advisor mainly for the healthcare technology at the NSHRC, actively involved in strengthening key initiatives such as Pradhan Mantri Dialysis Program, free diagnostic drugs and diagnostic service initiatives, biomedical equipment maintenance, and ensuring compliance with the AERB guidelines in public health facilities. He has been the recipient of the Presidential Award for Vishisht Seva Medal in 2016, recognizing his exceptional devotion to duty within the health sector. We are proud to have you, sir. Thank you. Now I'd like to request Professor Anil Kaul, sir. He is from Indian Institute of Public Health, a physician, a scientist, a public health professional with over 35 years of dedicated experience in the fields of infectious diseases and women health. Most recently, he has served as the clinical professor and program director for the global health at Oklahoma State University. He has successfully established high complexity infectious disease laboratory at the Oklahoma State University, significantly enhancing the institution's capabilities in infectious disease research and diagnostics. So thank you, sir, for joining us today. With this background, looking at how urban health is being shaped up with huge urbanizations, so it's not just about the infrastructure gaps that we are looking at, but also we need to ensure that governance, intersectoral coordination, financing, all these initiatives needs to be well oiled out so that we can solve many of the issues that are coming up due to rapid urbanizations. And I'm sure this session would lead to that kind of a rich deliberations and bring in not only the challenges, but also some of the solutions, some of the models that have been tried out, experiences from various initiatives, and what can be done to scale it up at the national level. So we do have panelists who can actually see which could be something of interest that could be taken forward. So in that sense, we are looking forward for this deliberation. And as a start, I would request our Chair Vimal sir to deliver the opening remarks, and set the context for the deliberations. Thank
Good
you.
morning, all. Namaskar. First of all, I am honored to welcome you all to this important session on transforming urban health policy, a call to action for sustainable, equitable, and healthy cities. This is organized by Health System Transformation Platform at the World Health Summit 2025. As we know that urbanization is rapidly increasing, and now it is around 32%, 34% urban population, and in the coming years, like 2002, 2050, we are going to be half, means 50% of population will be urban population. So it's going to be very challenging, and we have to make policies according to these changes in urbanization. Urbanization brings, one side we can say it brings the prosperity, it brings the job opportunities, it brings the good healthy living conditions, but on the other side, if you talk about, it also brings the slum population, it also brings the overcrowding, it brings communicable diseases. So non-communicable diseases also around, we can say 34% population which is residing in urban areas, 61% is suffering from, or we can say having the morbidity of NCDs like hypertension, diabetes, common cancers. So they are the dual burden actually. On the one side, there are the cases of obesities, NCDs, and the other side, we can say there are the pneumonias in children, there are the infectious diseases, malnutrition, tuberculosis, and these are the basically dual burden in urban area. This is a peculiar condition. So we have to make policies according to these conditions only. And we can say also that now we have to rethink, or we have to revisit or replan our national urban policies. Like in terms of digitization, we have to involve digital platform to tackle these problems. We have to equity is more important in urban areas especially, because there the population which is not access, which is having not the access to the structural health system, like they have the access to quacks or the unorganized sector, but we have to make plans so that they can have the access as well as affordability to the structured or the organized medical health services in the urban areas. So these are the basically challenges. With this context, I just request you all to please think or plan or give the suggestions at this platform so that we can have the new innovations, we can involve the digitization, we can have the intersectoral convergence also, because health is a multidimensional subject, not only this is the illness or the hospitals, but it is also involved the women and child development, urban development, and water sanitation. So we have to think about the intersectoral convergence also. So with this contest, we have our moderator, Dr. Sudha Chandrasekhar. I would request ma'am to please continue the session. Thank you.
Thank you, sir, for setting the context. And as we move ahead, I think we all heard of a lot of smart city projects and healthy city projects. So there is a need to look at how these could converge, and these principles could be much more conversed to create an equitable and sustainable and a resilient, especially looking at the newer issues of pandemic and those kind of issues and climate change issues. So these are certain things which can be actually converged with these kind of projects. So I request Rajeev Sadanandan sir to give insight into these issues and what could be done to address these.
We have a fairly large panel, so I'll confine myself to just setting the background. The aspects of urban life which influences health are actually related to the characteristic of a city. Cities are places of wealth creation, innovation. Actually, cities are very good places because otherwise smart people like us wouldn't be living in a city, isn't it? So which means that there's something good about the city. But the problem is that because cities are places of wealth creation, the inequity is also very high. This is a tradition, it's nothing new. It's been happening, if you read the old literature of the British or the US industrialization, it has always happened there. Because it is a place of wealth creation, there is a rich who set up their factories, their other units over there, and the rich don't stay in slums, or they set up areas of very good characteristics. But their workers have to stay somewhere, And the workers can't be put up in these places because they're too expensive, and they can't afford it also. So what, right from the beginning, cities had always grown with the rich, the affluent staying in a certain part, the non-affluent staying in another part. Even today, that is a characteristic that we see. The problem in urban health is not that it is urban, but the inequity that characterizes these places. Now, we talk about planning for health in urban areas. Now, it doesn't work that way, because health is both the recipient and an actor in urban health. Many of the characteristics of the city, as I mentioned before, the iniquitous condition led to extremely poor conditions in the past also, and most of urban planning actually grew from addressing these concerns. There are lots of different types of urban planning that had happened in the past. You had the garden cities, in which people tried to create open spaces around cities, and then came the automobile. A lot of characteristics of current cities are around these automobile-oriented places today. So one of the problems in urban health is that when urban plans are developed, as I mentioned, when the impact is on health, health is never a part of that planning. If you look at the smart city projects today, you'll find that very little component of that actually addresses health directly, and also the characteristics in which urban areas can impact health, that's also not being addressed. So, as the chair mentioned, by 2050, about more than 50% of our population is going to be living in cities. Most of that group is going to happen not in the metros, but what are called as the subaltern cities, which is the cities around urban areas, and the transitioning cities. That is, cities villages that are going to transition into cities in the future. I think that's a great opportunity for people who work in urban health. This is a time when urban health should get involved not in planning for health, but also in planning the cities, so that the aspects that influence health are taken care of. Things like green spaces, things like walkability, etc. But we also need to remember that there are political factors that drive decisions that influence health. Let me give an illustration. We all talk about green open spaces, and all of us agree that this is something that needs to be improved. But imagine that an urban government has a vacant plot of land, and when they're planning for it, if the demand of the affluent is asking for a parking lot or a shopping complex, it's anybody's guess as to who will get it. But even then, if this vacant plot is around an area settled by the urban population, that can develop into an urban park. But then the affluent population who are in the decision-making role wouldn't want that to be made open to everybody, because then they will have crimes and so on. So what will they do? They will bring in maybe an entry fee. So, and even people even say that if you see the way the paths are structured, that also reflects the desire of the affluent to latch on to these facilities. So one of the things that is normally pointed out is they will not create a bench, because in the bench you have to sit together. They will create chairs. And then either it remains a part of an elite club, in which it means that all the good things will happen there, or if it becomes a mixed use, what will happen is the political patronage for that will move out. Then resources get constrained, the swings, the maintenance, everything goes down. Soon it will become an area of another part of the slum. So this is what I'm trying to say is the characteristics that influence health. To understand that, we have to move beyond health. We have to move into not only urban planning, but also the dimensions under which urban planning happens, and find ways of addressing inequity. I leave it to the rest of the panel to say how that inequity can be addressed and how the health, which as I mentioned is impacted, but it also has the opportunity to ameliorate some of the conditions of this impact can work. So that will be part of how urban health response, urban health, not a healthcare response. And that, I guess, will be taken care of by the other panelists going forward. Thank you, sir.
Thank you, sir, for bringing in another dimension to the health discussion. As moving on from what sir left, so there are some of the examples. So I would request Dr. Srinivas sir, because Tata Trust has played a key role in also advancing urban health across multiple cities. It could be Nagpur, Mysore, Bhopal, and other experiences. So if you can say, what were the innovations from those projects or initiatives that have influenced the service delivery or the governance in urban health?
Thank you, Dr. Sudha, and good morning, everyone. Privileged to be here and share some of our experiences from Tata Trust. We've been basically supporting a lot of initiatives on the ground, and urban health is definitely a focus. When the Smart City project was announced about a decade ago, we thought a couple of these we should take up health because that's what the team works on. We had extensive engagement with the Nagpur city administration to start with between 2017 and 20. And I would not get into the overall determinants of health. What we were very clear was on the facilities, the urban primary health centers. I mean, of course, the health in a city, like Dr. Rajiv said, multiple factors, sanitation, clean drinking water, housing. We didn't get into the determinants of the health part of it. We got into the care delivery and how do we improve the public health system in improving the footfall. And after 3 years of engagement, we were glad to have actually demonstrated a model whereby 25 urban primary health centers could actually get more than 250% higher footfall at the end of 3 years. So that was possible because we took an integrated view and of course worked closely with the city administration. The idea was to what is already existing within the system, what can philanthropy capital do? And that's where we could, what in the normal course of doing the routine healthcare delivery, in addition to that, what the government does, we had our PMU set up there and did the gap analysis to understand what can be contextually specific solution to Nagpur city, and identified the gaps, discussed with the governments, and most of the infrastructure related upgradations were taken up by the government. But what we brought to the table was the process knowledge, understanding how it can be streamlined, and why patients were basically not utilizing the service when it was already there. And one simple thing was just improving the ambience of the place, ensured that the doctor stayed more than 6 hours. Otherwise, he was there going only for 2 hours. The moment the doctor stayed for 6 hours, the footfall increased. Added to that, of course, was the courteous way in which the patients were received. Of course, we had the advantage of the Taj Hospitality Group volunteering and developing the soft skills of the nurses and the staff. That was just 3 days workshop, but tremendous change in the way patients perceived how they were being received. Subsequently, then the supply chain. How do we ensure that for a city of 25 lakhs, which has the average footfall in these 25 urban health centers was something around 7,500 a day. So for that, what would be required is, most of these are like either the chronic diseases or which required continuous drugs and supplies and diagnostics. So we ensured we had a central laboratory and the central supply chain that was integrated on an IT platform. And some modicum of EMR was also tried. I won't say we succeeded too much, but there was electronic health records that were maintained at the UPHC level. What we failed was in integrating it with the medical colleges, but our studies at the end of 3 years showed that there was a little lesser pressure on the city medical colleges at the end of it, which meant that people were using the OPDs, the UPHCs more than what. So we tried to replicate that in Raipur, but Raipur had a few other requirements in addition to just what I have just described. And of course, the HSTP team also worked in Bhopal and Mysuru. What we found was that it requires some customization depending upon the city needs. So Raipur was actually, while it was an urban, it was also being, the UPHCs were also a little bigger than the regular configurations that you would have. And so they were adding a lot more focus to the mother and child health in those places and requested additional things. And of course, Mysuru and Bhopal both are having their own unique characteristics. And I think when we say health and healthcare delivery, we need to take a holistic view. And within these care delivery, the components about the infrastructure, the motivations of people, the competency of the people on the ground, supply chain, on a IT platform. I think all these can be configured a little more diligently to get much more optimal outcomes than they exist. Thank you.
Thank you, sir. Just also wanted to add on, especially with the Tata Trust, I think the DANC model, I think that was also tried out in Kolar. A rural model, but that is something that is also scalable for urban setting, is something can be looked into as a model.
So, yeah, we, again in Telangana and in Kolar, we try to use, with the help of our TCS friends, we designed a centralized system whereby we were able to, it was more care coordination, I would imagine, that a lot of patients from multiple UPHCs could actually be, seen in the respective medical colleges on a prior appointment basis. That sort of streamlined, but I wouldn't really talk too much about it because I don't think we succeeded in handing over properly or in
or
that.
Expanding it anywhere else.
Or for that to sustain after we moved out. So that's where I would say when it lasted, it was good. But once the exit happened, I don't think we created enough structures over there. So it still continues, Kolar continues still in a rural setting, helping out with the involvement of TCS. But the Telangana government, where we networked with almost 30-40 urban PHCs into the 3 major hospitals, I don't think it's working the way it was designed.
Sure,
so there are failures, yes.
Yeah, but that is also a process failure, not the approach failure. I think that is also could be looked into on how the processes could be streamlined and what good points from that experience could be taken up. So definitely that is.
So again, when this is the dilemma all the time, the funding agencies like us, like we have, as to when we are there and we are supporting an initiative, it works very well. The moment either scale up happens with larger funding from other agencies or governments, I don't think we can implement all the elements, and not even scale up. Even the same model probably collapses after some time. So we would, we have a lot of lessons that we can share afterwards. Thank you so much.
Just to add also, sir, because you said in the Nagpur, the digitization you initiated, so just I wanted to put to the forum that in Mysuru, we have done the ABDM compliant infrastructure in 2 UPHCs. That will be the first in the state that has actually started doing those linkages. So in that way, you know, the digital landscape also needs to be connected to the UPHCs and the primary healthcare at a much more stronger level. So we are hoping that we could scale up those initiatives. Now moving on to Madan sir. Just giving you a heads up so that. So mainly you have been involved across the years in terms of the evolution of the NUHM program also. And you've seen what things worked, what hasn't worked, and what are the critical points we can work on, and what are the current initiatives or the urban health frameworks that are under consideration. So if you can highlight those points and share it in the forums.
Okay, thank you. First, thank you very much, HSTP, for getting me here. Having worked in the policy space at Niti Aayog and now walking the talk at NSHRC, I echo the sentiments which we used to work together with Rajiv. That means that's the paradigm we have to address in the urban things. So far, we have been focusing on service provisioning in the urban sector. That's the whole challenge. That means right from 80s, if you look at the health posts which were created in the Indian population projects, we started from the health projects to address the issues of the vulnerable population. And it was all focused on service delivery provisioning. And whatever models which we talk about in the urban space, it talks about the service delivery provisions only. With the Smart City mission, which was launched in 2015, I think some serious thought process was started. That means we should be talking about health now. That means it is for the economic growth of the people. Cities are known for economic welfare and economic growth. And if you look at the composition of the people in the city now, we have been always talking historically that more than 90% of the people are in the unorganized sector. But if you talk about the demographics in the city, people come to the city now, the gig worker is a major chunk which is there in the cities. Having said this thing, we have to understand that we have to move from service provisioning to the health as a total aspect in all the planning process. Unless and until we talk about health in totality, we will be only restricting ourselves and creating systems for the vulnerable population, and we will make a system which is vulnerable. That's one thing. One of the major watershed which has happened is we have started thinking about the urban population. When the NRHM program and the RCH1, RCH2 and other programs evolved, it focused on the rural population because at that time, the rural population was 80%. Now it is around 32% urban population is there. In the coming years, it will be 35% by 2030. And the number will go on. As we move towards development, a lot of economic activities happens. As Rajiv ji has already mentioned that economic activities, the prosperity and other things, the people move to the city sites and this. Having said this, you see that how the government is also aligning its priorities. After NRHM, we thought that there is an increasing need for addressing the urban health issues. But health issues were only restricted for service provisioning. As a result, what happened? We started this National Urban Health Mission. We tried to replicate what has worked in the urban areas, rural areas, and we tried to replicate in the urban areas. Same model was replicated. We had the urban sub-health center, the urban BSCs, urban CSCs. That model was replicated. But afterwards, this urban CSCs and other thing, they were rechristened as the arm centers, that Ayushman Arogya Mandir. That's a different thing. Still, that model is there. And we do have, my other colleague would be telling about the statistics and other things, how many numbers have evolved, what is the number of urban arms, urban PSCs which are there. That's one model which has evolved. But exclusively it is focusing on the vulnerable population. If you create a scheme which is meant for vulnerable population, the scheme would be very, very vulnerable because you have to factor, as Rajiv ji has mentioned, that's a very crucial thing. And even Srinivas ji has also mentioned about that. The crucial thing is the chair. You just take the example of chair and the bench. If you are able to crack this issue, I think we would be able to see and make it a more inclusive kind of thing so that it is equitable for everybody. That's a very paradigm which is there. Smart city mission is there in all the aspects. Health needs to be talked about, even for a traffic intersection, because noise, air pollution, everything is impacting your urban life, and it is going to be there. If you talk about the urban pollution, air pollution, right across the Trans-Gangetic Plain, it's not the only one city which you have to talk about. You have to talk about whole Trans-Gangetic Plain. If you go to Varanasi also, if you go to Calcutta also, and any cities there, they would be having AQI more than 300 at a period of time. One time here something happens, if you look at the effect of that thing, that happens across all these things. You have to always factor this thing because they are going to affect the outcome of the health outcomes and the morbidity of the urban population. So social determinants are very important. Service provisioning, lot of models are there, but when we are evolving these urban structures, one of the important things which has happened, the involvement of the Arogya Samiti, MAS were there. But this has shown that the trust which is between, trust which has to be built between the system and the people, these committees are usually coming in way. And if we are having a ward level committees, that improves the trust further. Because if you look at the example from Pune in the Maharashtra, Pune in Maharashtra as well as Mumbai areas, wherever the ward level committees are there, the trust between the system and it has happened. That's one thing. If you talk about the segment of the population, urban segment, the urban mission is catering to a segment of the population. Other segment of the population has been catered by PMJ program or government sponsored schemes. And a small segment is catered by the public sector population. We have to see that how we Uberize all these people and bring and make a scheme which caters to all the population. That's a challenge, it's work in progress. We can't say that which model will evolve, which model will serve all the purpose. Because it's a very complex and dynamic things in the urban health is very complex and dynamic. It's not that one single model will fit for all the things. But most of the time, what has happened in the country is we have been focusing on service delivery provisioners only. And as a result, we have tried to build in the infrastructure to try to say that I'm doing this, I'm doing this, I'm doing this. But we have to address the other portions also. See that how we make a cohesive kind of thing. Involve the health department and the other department. Because water sanitation, as urbanization happens, water sanitation would be a challenge. Compounded with this air pollution and other things. We see that how we address all these things besides providing services. So things are evolving as we are in the process of formulating a new framework addressing all these issues. I think let's see that how it evolves. It's still work is in progress. We can't say that one prescription will fit for everything. Thank you.
Taking it forward, as Sir was saying, it has to be beyond service delivery. I'd like to bring in Santosh, sir. Mainly looking at what would be the patient perspectives, quality, satisfaction, and also picking up from what Srinivas sir said about care coordination. What has been the Gates Foundation or your experience on doing those kind of initiatives? Maybe it could be in UP, Kerala, wherever you're working. So how do you think those are also critical elements to add into the health system and policy?
Thank you. So let me start by sharing what actually happened to me. A few weeks ago, a state secretary of health took me to the largest hospital in the state headquarters. We reached by around 8:30 in the morning, and we saw very orderly, well-managed queues of people who were waiting to take tokens for consulting. Very impressed. Obviously, the place was overflowing. I mean, I'm just reminded what my esteemed colleague Rajiv Sanandan said while we were standing outside. The largest primary healthcare facility in Delhi is nothing other than the All India Institute of Medical Sciences. Similar thing happening in this particular state capital. Very orderly. So the health secretary asked one of the people who was standing number 3 in this queue, is at what time did you come to stand in the queue? He said 1 a.m. in the morning. And he said, Madam, this is my second attempt. So she asked, for whom are you come for? She said, my mother. So then I stepped in and asked, why did you, I mean, this by the way was a line for neuroconsult. They only have 60 tokens and therefore you miss the 60, you then have to take another shot at it. So I asked, how did you decide you wanted a neuroconsult for your mother? He said, we consulted and our neighbor suggested that neuro is the best. So obviously the question was, what does your neighbor do? Do anybody want to take a guess? He's not a dentist, he's a mason. Now between masons, ambulance drivers and security guards, our health system is producing 400% inflation in the number of footfalls in our OPDs. Just think about this. 400% inflation in the number of people who are standing in front of our OPDs. So what do doctors say? What can we do? 1 minute per patient, 2 minutes. I have actually been there to All India Institute of Medical Sciences. I was in those days, what was I? I don't remember. I was principal secretary in Bihar. I had fallen ill. They thought I had cancer. So I referral and I didn't speak to anybody else. I thought All India Institute will be okay. So I got about 1.5 minutes with that doctor in front after standing for some 2 hours in a queue. The point that I'm making is that our health system is actually in shambles. There is a study by Harvard University of one state in India, and they studied 5 conditions: asthma, childhood diarrhea, preeclampsia, heart attack, and tuberculosis. They found that the average rate at which people were getting proper treatments, that is correct diagnosis and treatments, was an average of 2.15%. Sudha, you are aware of that paper. You cited it in also in... So what are we talking about here? This is the negative side. Now let me come to the positive side. I think in India we have the unique chance of being the first country in the world to actually solve for this. And the way to do this, according to me, is to use the building blocks of ABDM. The problem is we still do not have an imagination on how to solve for it. Building blocks are there, but I don't think we have even an imagination of how to solve for this. Now, therefore, I am now going to talk about an imagination. By the way, I have talked of this imagination with various professors in the top and leading universities in the world. I have even said that, listen, I can even fund you to be able to describe this imagination. They said, we can never write this, because where is the evidence? Our colleagues will destroy us because we cannot write anything that is not based on evidence. So I used to tell them, listen, yaar, if John F. Kennedy told NASA that where is the evidence that a human being can be sent to the moon, then we would never have had a moon landing. So we are today stuck with a situation where we are looking for evidence that does not exist. We have a problem and the experts are refusing to indulge in an exercise in imagination. Because I'm not a doctor, I'm a quack, I'm not a public health professional, I'm an economist who did politics all my life in the Indian Administrative Service. Therefore, I can venture and actually talk to you about a new imagination. What is this imagination? So, if you go to the website of NHA, they have something called the ABDM Partners. And there is something called PHR, Personal Health Record Applications. There are over 12 to 13. Believe me, you know what is one of them? Paytm. Paytm is a PHR app, by the way. Empaneled, ABDM compliant, M3. So I'm imagining a new world where the PHR apps are actually competing with each other. And I don't have to imagine, it's happening today. You can go up there, Eka Care, one of the best in the market, is actually there. I'd urge you to go and see what all they have done, what are the new technologies that they have brought. I'm imagining a world where these PHR apps are actually competing with each other for acquisition of subscribers. And what are they fighting on? They're fighting on the quality of that interface. What all analytics they're able to provide. And most of these PHR apps have got one thing which has got hospital appointment but it doesn't work. Why? Because we have not made available the APIs through which they can give appointments. Now think of 1980s Indian Railways. The Rakesh Mohan Committee report advocated that we need a disintermediation between the railways that run the trains and provide the catering and the digital organization that will provide those services. So what happened as a consequence of the implementation of the Rakesh Mohan Committee report? We no longer had to go to the train station to book our ticket. Then they did something else. They provided these APIs again. I don't know why I'm taking Paytm again, because Paytm is not a place where you look for health. Paytm is not a place where you look for a train ticket. But Make My Trip, Paytm are all the people today who are actually offering you the ticket. That same Bhopal Delhi Shatabdi Express, bogie C1, seat number 30, 10 people are selling that one seat today. Imagine if the IRCTC happened to healthcare and we could actually make available all these appointments. Now, what am I talking of? Appointment for chemotherapy, appointment for antenatal checkup, appointment for immunization, appointment for medicine pickup. You'll be stunned. What am I doing? Medicine pickup appointment. Yes, I'm talking about that. According to me, the fundamental problem that somebody like me, who's a trained economist and a practicing politician, I'm saying politician with in inverted commas, the fundamental problem is that we have a scheduling problem. We have a coordination problem. What was the problem during COVID? ICU beds were here, intensivists were here, oxygen was here, and patient was here. People died. When we brought them together, less people started dying. So if you can actually leverage the power of PHR apps, make available appointment slots, and significant task shifting happens. What is that? These PHR apps should be, only those should be given these appointment slots who have got a clinically validated adaptive question engine that has the capability to capture the case history, put them together, give you the longitudinal record, put them in an electronic health record, and make it available to the facility. So when the consult happens or any service delivery is to happen, we are not subjecting our clinicians to the beauty of typing on an electronic health record. Bana karke, you're actually having the clinical history. You go up there today, you can see, we now have the technologies by which the clinician can just have a conversation with the patient. It's not transcription, ladies and gentlemen. It is structured, FHIR-compliant data that is able to produce. And with a click of a button, you are actually able to even get the full prescription there. These technologies exist, but they're all in silos. Eka Care is doing something here, DINC is doing something there, ambulance is doing something. You know how many call centers we have today, which don't lead to anything. So what I'm arguing today is that we need a new imagination, which is today, India is the only country where we have these registries, these interoperability standards, this mobile phone penetration, and post-COVID, the willingness of a significant part of our population to do the jugaad required to solve their life's problems. I was struck what Madan Gopalji said. If you actually have something for, what is the word, sir, you use? Vulnerable population or? Vulnerable. So he said, if you have something for the vulnerable population, it will become vulnerable. Thank you, sir, for saying that. The rich, the powerful, everybody can actually, and the poor and the vulnerable can go through this PHR system if you have a care coordination call center at the back end. So the people on the wrong side of the digital divide will actually phone and say, "Beta, mujhe sar dard ho raha hai." But people who are sitting in benches in the classic colonies of New Delhi, they will open their mobile phone app and go through the triaging engine. Thank you.
That was well imagined, and I think that is something, a lot of thoughts for everyone who's working in urban health to see how that could be taken up. And I'm sure parts have already, I think, been supported, especially from the call center side and from the care coordination side. There are examples, I think in Gorakhpur, sir, in one of the place, they are doing this appointment systems, follow-up things. So I think there's a need to link many of these initiatives, and that is the reason that I think today we have people from different stakeholders speaking, so that where is the connection and where is the gap and where is the weakest link, how do we plug that? So thank you for all those wonderful thoughts. Taking a clue from you on technology, I move to Ranjan sir. So the technologies, one is the digital technology, and also we need to have many interventions and initiatives and specific healthcare technologies which will be needed to be included to lessen the burden at different levels and improve the outcomes and ensure that the newer initiatives are part of the healthcare delivery also. So in your perspective, these healthcare technology assessments, how can they help to make these technologies available to the people and also sustain and scale up these initiatives?
So thank you, Dr. Sudha. This is a very interesting question. You know, the global focus, as you all know, is on healthcare, environmental sustainability and moving towards a low carbon and a resilient healthcare system. Now, where does this HTA fit in? HTA, has been very long since criticized for actually not doing its job in the technology management domain. What I mean is HTA doesn't do a life cycle analysis. Might be there's a shortage of skilled specialists who can undertake life cycle analysis, right from selection of the raw materials, manufacturing, production, and then distribution network, supply chain network, and then its condemnation and the disposal. There's the whole entire life cycle. So where does the HTA fits? So HTA can fit in undertaking, assessment of the environmental impacts or the outcome of the technologies which are existing. In fact, we have not done that thinking at all. The existing technology itself, we don't do a life cycle analysis. And in environmental sustainability, it's very important that you develop standards, procurement standards. You develop standards for the manufacturers. You develop, licensing and other things. What will be the standards for that? You can also develop, in the financial part, the subsidies which can be given for the, you can say the behavioral incentives for the people to adopt this thing. Because, there are a lot of things which we often overlook. You must be aware of this MDIs, the meter dose inhalers. They are very big source of, environmental, they have the CFCs and all. And then you have anesthetic gases. So name it any product, we have never done a, energy audit also of that product. We at NHSRC, along with other, we think about developing a standard guidelines for, energy efficient medical devices. Okay, what is the impact of this on the environment? That should be studied, which is not done right now. We have challenges with us a lot with estimation of, the technologies, but thank God, in the future we are coming up with like drone technology, which is a low carbon footprint. We are trying to promote and advocate drone technology for, hard to reach areas in the hilly terrains, for diagnostic sample collections, for giving rescue medicines, complementing the existing supply chain systems. And the second one is the telemedicine and the teleconsult, which is also very important. Thereby you are, reducing the carbon footprint of the movement of the people from place A to place B. So this is very important. This technology is helping. And in the ABDM, much has been said by sir, my previous speaker. But we have a technology there, the scan and share. You must be aware of that QR code. You can scan and then the registration tokens can be generated. Believe me, around 2 lakh, over 2 lakh registration tokens are being done every year. They have, selected 133 model hospitals, health facilities, And these scan and share technology is helping to reduce the waiting time for. Previously, it was in hours. Right now, it's within half an hour or something. You can get a registration token. So this is a good sign. For the digital side, they have also worked out the ABDM as a eShushruth Lite, which is a very compact software tailor-made for small healthcare organizations. So, I do agree that we all are having small things in silos and all it requires to patch up, and that's what the ABDM, if at all it is done properly in the future days coming, it will be a game changer. Linking up so many records already, I think over 71 crore ABHA IDs have been developed and 35 crore health records have been linked. I can say with confidence because I am handling the dialysis part, the Pradhan Mantri National Dialysis Program is an ABHA line listed portal, which has integrated all the dialysis centers. And today, a dialysis patient can move around in the country and can take dialysis. That's called One Nation, One Dialysis. And you can have a greater visibility of the, dialysis patients, how many of them are, because it's line listed, review is easy, you can monitor them. So the digital revolution is there. It has to be sustained because overnight you can't achieve everything. You have to give some time. And I'm sure the smart city, which is more a data centric, this requires to be integrated with the healthy city. Healthier city framework is different. As you all know, it is WHO's framework of 6 Ps, people, place, participation, the prosperity piece. And in this, the people and the place and the participation. The place is somewhat there, the environmental monitoring and all that. But people and participation, this is lacking. This is a very great divide. Technologies will help us in integrating the participation and the people. I think I'll stop here, Dr. Sudhir. Thank you.
Thank you, sir. And as you said, there are many pieces for the urban health system. I'd like to bring in Dr. Anil Kaul, sir. Mainly looking at, because collaboration and partnerships are very key, and coming from the academia side, I would like to have your thoughts on how academia, civil society, and even the private sector can contribute to, advancing the urban health systems.
Thank you. Thank you for having me. I think before I start talking about academics, I think I have a little different take on what we have been discussing. I think we are more focusing on the treatment, the tertiary side of it. I come from a public health perspective, and I think even as a clinician, I'm trained to treat one patient at a time, but as a public health professional, I think my job is to prevent a patient from becoming a patient. Unfortunately, we are not focusing too much on prevention. I think there is a problem in urban cities, particularly in crowded environments. There is a dual burden. There is infectious disease and also there is a non-communicable disease burden. I think as a public health infectious disease person, I think my biggest challenge is many of these crowded places are the breeding grounds for emerging infections. And a lot of traffic is going back and forth urban and rural areas, and I think we have to be very aware of what is in the pipeline, what is in the bacterial or microbial world, how these emerging infections are breeding grounds in the urban setting. So I think that is one thing which I'm worried about. The second thing is rapid urbanization is also creating what I call food deserts. We have McDonald's and all those fast food restaurants. Incidentally, I have been living in the US for the last 35 years, so I'm literally new to the Indian environment, but it is little discerning that I see the Western foods, fast food. Nothing against anybody. Everybody can enjoy whatever they want to eat. But the thing is, it is creating a culture of malnutrition. It is creating a culture of non-communicable diseases. I think that is what is worrying. I think we don't have to copy what West is doing. There are some things which are very helpful in the urban setting. One thing which is interesting is that we go through this nutritional, I call it transformation. We go from eating frugal diets, rich in or low carb diets, and then suddenly we move into high carb diets and we become obese. And I think we have to focus on multiple things. And in partnerships, I think we have to work across fields. I think in public health, somebody asked me the other day, what is architecture got to do with public health? I said, everything. When we are designing urban areas, the architects help us build these green buildings so that affects the environment. When we are designing a city or a town, we have to keep in mind green spaces. We have to keep in mind walking areas, cycling areas. So all those things, that's where it's all important. Somebody mentioned about road traffic accidents. We have a huge burden in India on road traffic accidents. Every day we read about it. I think in urban areas, there are many urban areas. We don't have proper sidewalks. So I think it's a multiple levels we have to cooperate with each other. Now talking a little bit about academics, I think it is very difficult to untrain my healthcare providers into learning new skills or prevention or everything else. So I think what we are doing is we are trying to get into the medical schools and public health schools and sort of bring it at a student level, at an undergraduate level, at a graduate level, how we can change the healthcare system at a ground level. So creating awareness. Noise pollution is a huge issue. Just because we have newer technologies in hearing aid and all that stuff doesn't mean that we should allow noise pollution to be there. So I think those are the things which we have to focus on. Again, environment, everybody has talked about environment. I think air pollution is a huge issue. I think the recent data shows that people live 9 to 10 years less in some of the cities which have high AQI. So I think we have to work across disciplines, interdisciplinary, all those approaches have to be taken into consideration for making healthy cities. I think I'll just leave it like that.
Thank you, sir. Ma'am, Ashima ma'am, you've been hearing various kind of initiatives that are being taken, and I just want to ask you, are you also having islands of excellence within different states under your program? If so, if you can describe that, and also wherein the states have a huge NUHM kind of a separate allocation, financial allocation, and we also, based on the analysis that we look at, NUHM funding is mostly underutilized by the states. So what are the reasons or the challenges? Because funding is, if you say maybe, what are the issues around that for urban health could also be explained, ma'am.
Thank you. So to answer the second part of your question first, related to the funding part. NUHM used to be a separate pool under NHM for funding, but since 22-23 cycle, we have brought it under one pool. So the funding for entire NHM is through one pool. So you have the utilization for rural as well as urban health systems. Plus you have to see the larger gambit of things. After COVID, once we realized that we don't have one type of vulnerable population, everyone is vulnerable. Be it because of health profile, or because of socioeconomic status, or because of geographical location, or because they're prone to environmental hazards, everyone became vulnerable. So that funding landscape changed completely. We got in 15th Finance Commission, which granted funds directly to ULBs, to all these local bodies. And then we also had Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, where the infrastructure for these health units, be it UPHCs, be it something called Urban Ayushman Arogya Mandirs, which are basically similar to a sub-center at the urban level. So all this funding mechanism also came up. So in NUHM per se, the program part was focused on, and all the infrastructure part, the diagnostics part, they were all supported through 15th Finance Commission and PM Abhim. So we have not reduced on the funding, and we have not gone under, low on the utilization part. We have just expanded the scope of things. And now even urban local bodies are, they are directly financing financing their health sector. We have charitable hospitals. We have a lot of things that are coming in the program, so that scope is there. Coming to the best practices, as I said, we have, if you'll see, NUHM is a very newer program compared to other programs. We are just 1 decade old, and in that also the standardization of institutional setup has slowly evolved. So if we look at states and urban local bodies, they are cropping their own best practices with time, and they're evolving slowly and steadily. We have different models. In some states where the powers have been delegated to local bodies under 74th Amendment, the urban local bodies are directly implementing health. For example, the 7 metro cities and states like Maharashtra, Gujarat, West Bengal, where these local bodies are taking care of everything, be it the clinic, the infrastructure of the clinic, the human resource, the outreach activities also. And then we have mixed model where we have both urban local bodies also there, and the health department also there. So the local bodies are giving us the land, or they are looking part at the sanitation area, or somewhere they are providing the HR. And the health department is looking at the operationalization of the facility as such. And in the remaining 25 states or something, we have the, the NUHM program implemented entirely through health department. Now, in all this model, in all this mixed model, they are doing several initiatives, starting from something very basic as having a flexible timing. Because most of the population catered includes people, especially in the urban cities, where a lot of speakers previous to me have also said that the whole fabric of city is such that it's very different from rural setup. So people do not have time to go to the doctor, or they'll be missing out on their daily wages, or they'll be missing out on their work if they don't go. So flexible timings are being provided. We have Odisha, where we have 3 hours in the morning and 3 hours in the evening. We have Maharashtra, where we have evening clinics available. Chhattisgarh is there, where evening clinics are available. Chhattisgarh is also doing a 12-hour OPD, so that people can go at any time. So they have specialists there. Then the other thing is, as Santosh sir earlier said, that people are directly going to for neuro consultation because some neighbor suggested that. So we understand that the urban population has all these options available. They will go to private, they will go to AIIMS, they will go to all these tertiary centers. So the specialists are being made available on call in a lot of states. We have something called polyclinics that are being set up, and these polyclinics are providing specialist services. We can some states are having them on fixed day basis, like Ayushmati clinics in Mysore. They have different days for different services. We have whole day full polyclinics also. We have Amma clinics in Odisha. So these are polyclinics that are available. Then there are other examples of, ward Kalyan Samitis where you have where you have convergence at the ward levels. So the ward Kalyan Samitis in, again, Odisha and Andhra Pradesh, we have ward secretariats. So they are bringing in people from all departments, all the stakeholders, be it ICDS, be it women and child, be it sanitation, public health engineering, and health, of course. They are all coming together at the ward level, and then they are implementing the services. Then we have Mahila Arogya Samitis, which is community empowerment, which is a way of reaching out to the public through community, and to motivate this Samiti, Mahila Arogya Samiti, we have grading of mass available, where you have every quarter they score themselves on certain criteria, and whichever is the highest rated mass, they are incentivized. So they keep themselves motivated also. There are so many different examples of in different states. We have now that health as not only health, but you also need to, there are a lot of other things involved. So under smart cities, under climate change adaptation plans, we have cities like Ahmedabad, which are developing heat related illnesses plan, and they are mapping their facilities as per the climate change, including the climate change plan as well. So these are some examples. Of course, there's a lot that still needs to be done, but in these, as you said, these islands of excellence that we have, where we can see a lot of best practices being done. And while sitting here and listening to Sir, another thing that has come up to my mind is we can get NPCI on board for implementing Bharat Bill payment system for hospitals. So they can have their appointments on these platforms like Paytm and PhonePe and everything. So these are examples, these are collaborations that we can get in touch with. We can have more examples from the field. Yeah, thank you.
Thank you, ma'am. And considering the time that we have, and we have an audience who have come on a Sunday morning, I would like to open up to 2 questions to any of the panelists, and I will avoid my questions so that we can have any interactions. So the floor is open for any questions. Yes, we can have it very crisp, no comments, very directed questions. Please introduce yourself and the question to which panelist, yeah, or if it's open to all panelists. You can take it.
Yeah, first of all, thank you so much for your nice interactive section. I'm myself, Dr. Rajiv. I am from the Khushi Baby as a state program manager and working with the Department of Health of Rajasthan.
Please, yeah.
So I am sharing the real example in the urban health. Okay, so
questions for the panelists.
So I am setting the context just for in 30 seconds. My area is nearby the one PSC. So this area is not covered under this PSC. So I want to avail the services like ANC services. Asha and M told to me, you can avail the services for the ANC, but I am, Asha told to me, we are not providing the any portion for the pregnant women because your catchment area is to another linked with another PSC. So how to resolve this issues to achieve the healthy city goal? And next question.
Only one question. Okay. I'll take from others. We can take the 2 questions and then I'll allow the panelists to answer. Yep.
morning. I'm Sama Mahalati from the Foundation of People-Centric Health Systems. I'm working there as a fellow. I'm a recent public health graduate, and I'm also learning in this process of learning. So I understand that we are all in this learning process of strengthening our urban health systems, and therefore we might have a lot of questions for which we're looking answers for. And one of the questions, if I might put to the panelist, it's open for any of the panelists, is that do we have any experience or thoughts on how we could involve the youth within these urban settings in strengthening our health systems? We know that community engagement is a very integral part of strengthening a health system. And can we think of ideas, or do we have some thoughts, or do we have some experiences how these youth within these communities, within the very local communities who are available, they have the time, they have the energy, they have the enthusiasm. And luckily, given the demography of our country, we have a lot of youth in this country. Can we use their capacities, tap their potentials to bridge this gap between community engagement and our health systems? Will it be more effective and efficient for our health systems? That is a question I have. Thank you.
Thank you. And would you want to respond?
Yeah, I think I'll hazard a guess to that. See, mapping administrative boundaries to service areas of hospitals, of primary health centers is a major problem. So normally what we do is that even if you're from next ward, you come in and avail services here. But when Poshan Abhiyan is dedicated food that is there, it becomes a problem. So that's a micro mapping that has to be done, always tricky because you are living next to an institution, but your ward is over there, which is about 2 kilometers away. So that's a major problem, which currently I work with my village, with my PHC. That's a problem that we are also facing, how to do this mapping part. Now, community involvement, all documents we say community involvement is an essential component of public health, of primary healthcare. Something personally I'm not able to crack. We've been looking at organizations, and in each areas. For example, the neighborhood groups. One of the most promising in my work has been the neighborhood groups. Youth sports clubs, for example, would be a good area where we can bring them in to promote physical exercises, not for the youth, but for our catchment population, which is your NCD patients, or even to promote healthy aging. What I've seen is that thin line that divides the health institutions from the community, it's very difficult to break it. And at a personal level, I'm trying to do that now. But what we have now decided is that we'll work with existing systems. For example, the NRLM, you are aware of the NULM. So work with the neighborhood groups. We're even talking to the Pensioners Association to see if we can work on healthy aging. So the trick is, what the strategy is, identify existing institutions and put it into their agenda. For example, in Scotland, in order to promote physical exercise to control heart diseases, they hired the local football club if they could do it. So those systems are being tried in places, which I'm also personally trying to do. It's a difficult thing to do, but you're right, that is the way to go in involving the community.
Just to add to Dr. Rajiv's suggestion, it's not directly to do with health provisioning or improving the health, but we had a initiative in Hyderabad where the IT professionals all contributed 8 to 10 hours each, almost 200 of them. They created the basic health information systems now, which has been incorporated in about 35 government hospitals of AP and Telangana. It was all totally voluntary work, and it was inspired by the youngsters seeing the conditions and how information technology can actually bring down the waiting times and all. So I guess people need not be doctors, people need not get into every aspect of health provisioning, but one piece of system strengthening. This is one example which we had. Of course, we also got a little involved later on in
If I may add, I just feel that it is a way of helping them to contribute more for the well-being of their community.
inspiration has to come from within, you know. There's, I don't think.
A lot of them have that inspiration. They do. Everybody wants to serve their communities, especially the youth, right?
You can also look up the Yuva Spandana program that's also picking up, wherein again the youth-based initiatives. So have a look at it. So that is also something that we are also working with for adolescents, using the youth to help out and reach out to the community and link them to the various services that is needed.
It's an excellent approach. If we do that, it
Yeah.
will help us a lot.
Sure. Thank you. Any other panelists want to add in?
Just one thing, because she has raised a very pertinent question. And if you look at the trust building between the system and the community, this kind of association has to be roped in. The youth has to be roped in so that the system trust between the system and the community increases. And mechanisms are there. You see the example of COVID, when the vaccination was a problem. And these are the youth groups which have helped the community connected with the system, and you see how the vaccination hesitancy which was there initially, we have been able to overcome that thing. And many examples are there. If you go to the TB program in Mumbai slums, the use of the wards, they are contributing and helping the system in bringing the patient, connecting them, and seeing that the affected person gets full treatment. Examples are there in HIV, examples are there in communicable disease. You name it, they are there, but we need to structure it and make a cohesive kind of effort to bring in more of these people in a very structured way.
Thanks to everyone. I think the other question I'll ask you to take off a stage. Thanks to all the panelists, and I would now request our chair to give the closing remarks and also the way forward from whatever all the panelists and the audience have shared.
Thank you, ma'am. Thank you so much. It was a great discussion on the points. Sincerely thank to all panelists and the speakers. Several points and themes emerged today is basically the systematic reforms of urban health governance, the one point which came out with the discussion. Then prioritizing the equity in the service delivery, the second point. And environmental health, that is also been discussed and is very important aspect of public health, environmental protection, and primary care. The sir has focused on the primary care. If we focus on primary care, that could lead to delay in the secondary care, or it will abort the secondary care. So we should focus on primary care. Then data-driven decision making, that is most important. And finally, the inclusive governance. So these are the points which came out of the discussion, and the way forward is basically we should have the incorporation of digitization in urban health, or as such in the health. Then bringing the equity in the public health. All should have deserve the same health delivery system. Poor should not get the poor services. They should also have right to get the good services. And we can say the most important is intersectoral convergence, because health is not in toto, or you can stand alone, but it is the part of environmental health, water and sanitation and all. So these are the takeaways I think we should focus on, and we'll keep on working on these issues. Thank you so much, ma'am.
Thank you, sir. And I would now ask our MC to take it forward.
Well, a big thank you to all the distinguished panelists for sharing such insightful and action-oriented perspectives. As we move from dialogue to delivery, it gives me a great pleasure now to arrive at a moment of great significance in today's session, a milestone that represents months of collaboration, research, and dedication to strengthen India's urban primary healthcare delivery system. We at HSTP are proud to launch a module for yielding sustainable upliftment in RMN-CHA upshots through urban self-help groups, a comprehensive facilitator guide developed to strengthen community-led health promotion to the powerful networks of the self-help groups, that is the SHGs. By focusing on collective learning and shared responsibilities within families, this guide aims to catalyze sustainable behavior change, and improve health and well-being of urban communities. To begin this, may I please invite Dr. Rajiv Sadanandan, former CEO HSTP, and Dr. Sudha Chandrasekhar, advisor HSTP, to jointly hand over the SHG manual to Dr. Sushil Vimal, Deputy Commissioner, the Ministry of Health and Family Welfare, for its formal release. I would also like to invite Dr. Prasad, Team Lead Mysuru Project, to jointly collaborate because he has been a driving force in these efforts. Please, sir. Thank you so much, everyone. I would also request Dr. Sudha ma'am to please hand over the token of appreciation to our chair. And would also request ma'am to please hand over the token of appreciations, not in any sequence, to our distinguished panel of speakers, Mr. Rajiv Sadanand sir, Santosh Matthew sir, HSD Srinivas sir, Ashima Bhatnagar ma'am, K. Madan Gopal sir, Ranjan Kumar Chaudhary sir, and Anil K. Kaul sir. It was indeed a pleasure having you all. We would just request you for a group photograph. He's here. He's here. Yeah. Team HSTP also please gather here for a group photograph. And thank you so much for being a wonderful audience.
You're both team HSTP and thank you. Thank you, sir.
No, but thank you for raising this. You are absolutely right. Well, we are creating business palaces, and it's happening in front of our eyes. So I checked you out immediately, and I noticed that you studied in Madras Medical College. Which year were you there? So Robert Joseph Thomas? Actually, 1 year. What about his wife? Rajini So Robert and I studied in school together in Yale. And I was in dermatology. So I graduated in 1801. Dentistry was prior or
What happened? So that's me. Don't worry, I'll be standing anyway. So it doesn't make a difference. Okay? Sorry? Yes, everybody on the panel is coming. So we seem to have one too many chairs. Can you remove some of them? Yeah, sure. Yeah, so that there are as many as we can. No, this was Anju, the previous one. Yeah, now it's fine. एक minute, yeah, let me switch off the microphone.
podium. You don't. Okay. We don't need this for.
Ah, it should be a young person.
Yeah, yeah.
And if you did want to do jazz,
No, but I thought we could still have this just. I think you should, because if this is supposed to be a surprise, you should give me the.
how do I do that? Do you have the newspaper? Wait, over there. Yeah, please stop. So Anshu, you then sit there.
I'm going to be
Wait for people to turn up. We'll start in time. She and Salma together, wherever they go. Hi Sanjay, lovely to meet you. We went to meet about a couple of days ago. I was there for a conference in Kathmandu, but I had to rush out for something. You doing well? I'm very well, thank you. Exhausted. Yeah. Is this your last? No, I've got one at 3 o'clock. I'm heading back today. It's been lovely to have you. Especially Levi and wonderful partner. Good. We can work with you. Helen, you there? Do you want me to come to all right. For that, I learned that from Australia. Then, part of Bhutan. Yeah, my part is Bhutan. We will start in the next couple of minutes. Thank you. How are you? Yeah? You traveling? Oh, yeah. When do you head back? Today. Say hello. Hello. I'm Sanjay. I'm
Hi, Sanjay.
Reset Resource.
Nice to see you. I saw you on the stage the other night. Yeah.
Oh, right.
schedules could also absolutely. And maybe we can reschedule. Drill us this a lot of protocol and reviews and this and that. So it takes a lot. But it won't be a problem.
If I could please request colleagues at the back to take their seats, we will start now. Thank you. Well, good morning, everyone, and welcome to the last day of the conference, but most importantly to what I hope will be a very exciting conversation. My name is Rajat Khosla, and I work as the Director for the Partnership for Maternal, Newborn and Child Health, and it is my great pleasure to welcome you for this dialogue along with WHO Southeast Asia Regional Office, UNICEF, C3 and YP on adolescents and young people. Colleagues, adolescent well-being is not a standalone issue. It is one that is deeply interconnected with a variety of other issues such as education, mental health, gender equity, nutrition, digital safety, and so much more. As we look at 2030, we recognize that adolescence is a pivotal time, a period for growth, challenge, and opportunity. However, it is time to recognize the potential of young people and what they can do to shape not only their future, but also of the societies. But it is also a time of extreme vulnerability and inequality, violence and exclusion, and so much more. Our mission is clear that we must work together to ensure that every adolescent, regardless of their background or circumstance, has access to tools, services, and information to make the most of their potential. And young people are not just beneficiaries for these systems. They are drivers for change. Adolescent and youth engagement is just not a nice buzzword to have. It is an essential. The passion, creativity, and resilience shown by young people today is a clear evidence of the role that they play in society. In these uncertain times, we need to continue to building platforms where youth can lead, collaborate, and innovate. To discuss this and much more, we have a very vibrant panel of experts and global leaders to share their reflections. Before we set on to the panel and our different speakers, I would like to invite my colleague, Anshu Mohan, who is the Senior Strategic Advisor for the Partnership for Maternal, Newborn and Child Health, to come and provide the framing remarks. Anshu, over to you.
Thank you, Rajat. In full disclosure, I got to know about this just about 30 minutes ago, so I've just been put there. But that's my supervisor, you know, put you on the spot. But he's a good one, he's a good egg. So, and today I will have him commit to continuing to focus on adolescent well-being as we move forward. So before I go on to the context and the framing remarks, I do want to take a beat. And I do want to acknowledge that I have an extreme privilege of speaking to 1.9 billion young people from across the world. I channel their views, I channel their energy, and I bring them into the room. Some of them are here. I see my colleagues here. But most of them, of course, can't be. So I am very cognizant of that privilege as we move. So just a little bit of background. You know, when we started this work, the campaign about 6 odd years ago was called 1.8 billion. As a marker for the population group that we are going to be working with. But lo and behold, 6 years later, we're 1.9. Mea culpa. We got the number wrong, but I have to confess, we got many, many things right. And we are going to discuss these things as we go along. But the change in the number is actually the strongest argument that we have for investing in adolescents. It's the fastest growing population group. If you don't focus on adolescents, you don't get results. And this is data. This is just not a rallying cry for advocacy and action. This is numbers speaking. Numbers says that the demographic dividend window closes in 2025. We are drawing the line under it. If you don't act now, you stand to lose. When I say you, I mean all of us in the room. The future generation, the future of this world, especially in this extremely divisive context. I do have to again bring the discussion back to the region, which is home to about 360 million adolescents, comprising about 20% of the population that reside in the region. Very complex, very diverse, very rich. Much progress has been made in addressing adolescent health and well-being, but various challenges persist, which we all know. I feel like, looking at the audience, I feel like I'm talking to the congregation. I mean, it's the church. But various challenges persist and have been compounded in an increasingly polarized environment. You know, there's the global pushback on crucial issues such as SRHR, the anti-rights movement, which are significant barriers to progress, rising inequalities in health, education, social protection. And all of this is compounded by larger challenges, the climate change, job security, food security. So adolescent well-being doesn't happen in isolation. Just to give you a little snippet of where we are on adolescent well-being, and most of you are familiar, so forgive me, but we need to reiterate these figures to make sure that the message goes home, especially in these times when you don't have the money and adolescents fall between the cracks. Adolescents are everybody's babies, yet nobody's baby. Because education rests with education, health will not do beyond health, wash will do wash, and then you don't have a comprehensive set of services. So we need to bring that together. So just a little snippet, and bear with me on this. You know this well. 1 million adolescents die annually, mostly from preventable causes. Mental health conditions account for 16% of the global burden of disease. At least 1 in 7 adolescents globally now suffers from mental disorder, anxiety, and depression being the top. Anemia among adolescent girls remains prevalent at the levels that are similar to 2010. So literally when we are talking about progress, we are almost a decade and a half behind. Sexually transmitted infections, including syphilis, genital herpes that commonly occur among youth are on the rise. If left untreated, they have lifelong consequences. Globally, 1 in 5 girls is formally married or an informal union before reaching the age of 18. So when we look at child marriage or informal unions, what are the drivers? It's no single driver. It's a complex environment of societal norms of various things. So never, never look at a young person as standalone, homogeneous group. 12 million adolescent girls are married before the age of 18. Every 3 seconds, an adolescent girl gets married, limiting her options, challenging her life decisions. She is unable to reach her full potential. Just remember, every 3 seconds, I have not even uttered 3 words in those 3 seconds. Finally, my last point, while school enrollment worldwide has increased, in 2022, 70% of 10-year-olds were unable to understand simple text. So I introduced you to the term learning poverty. There is an increasing learning poverty, even though the numbers have increased. One thing I want to leave you with is, while collectively we look at these individual and isolated problems, we collectively stand to lose about $4.1 trillion annually if we don't get our act together, right? However, I mean, I appreciate I've been all gloom and doom this morning, but not all is lost. We have done a substantial amount of work over the last decade, especially in the last 5 years. There are tools, there are guidelines that have been done collectively with academia, research agencies, UNH6, PMNCH, but most of all with young people as co-leaders, co-drivers. Big shout out to you there, my friend, who have been a part of this movement. So we have the AHA 2.0, we have the Adolescent Wellbeing Investment Case, and I'm quoting the figures from the Adolescent Wellbeing Investment Case, and you'll get a bigger snapshot as we move forward. So all this is there, but what we need is movement on implementation and lived experience. But we did that also. We did lived experience, so you can't say that we were at fault. We reached out over the last 5 years to about 1.6 million young people in 90 countries. And my friend Aparajita on the panel has been a true partner on the crime here. And we asked those young people, what is it that you want for your well-being? You will not be surprised that top priorities, education, skills, employability, seen as #1 drivers of well-being. I will look to Sanjay to hear more on what we are doing on this. Then affordable, high-quality health services. Zoya is not there, but we hold her to account, and so is our RD from the WHO CRO on what is it that we are doing for health. Mental well-being and emotional resilience is the third thing that they asked for. Protection from harmful laws and practices, social protection, and crucially, the power and agency to participate in decisions that affect their lives. This is so central to them. I'm going to paraphrase a young non-binary person from Brazil who said, to improve my well-being, I want all. I want everything, and I want it now. I want security. I want good food. I want quality education, infrastructure, better roads, better transport, and free public health care. Now, a little bit of segue. I went to an all-girls boarding school where the highlight of my existence was cinema, one cinema trip every term, and then sweet bread for Sunday tea. So those were the highlights of my existence. I date myself when I share that anecdote. But the young people nowadays, they face the challenges that are so much more complex from a trip to cinema once every term time, right? We have to understand that they're not a homogeneous group. They need so much more, and we have to come together. So I have a list of dirty words which have become unsexy over a period of time. I encourage us to think about those words. And they all begin with C. We have used them and abused them. But these are central to achieving results. So convergence, those of you who have been veterans, and I see familiar faces here, there's convergence, there is commitment, there is combined accountability, there's common work plans. All dirty words, all unsexy words now, but they're very important. Rajat is looking at me, so I'm going to wind up very quickly. But this is a power-packed room. We have young people, we have champions, we have allies, all of us are here. And I have three things that I would like you to discuss. One is translate this momentum into real action, using a 360-degree cycle of evidence to policy, policy to action, action to accountability approach. You have everything you need. We just need to bring it together. Second, invest in early adolescents. Don't wait for them to be 10 to start thinking on an investment. This is a life course. We shouldn't look at maternal, child, newborn, SRHR in isolation. This is a continuum. So invest early in early adolescence and invest in adolescents. Build their capacity. Build their power to participate. These are the conversations that will lay the foundation for the post-2030 agenda. Third, recognize the cost of inaction. I was trying to be very gentle. This is early morning, so I introduced the figure of $4.1 trillion US. But the actual cost of inaction is $111 trillion US million dollars. If we don't act from now until 2050. So $111 trillion we stand to lose collectively. Now you're going to ask me, who is this woman? In this time, she's asking us for more investment when there is absolute lack of investment. So I go back to my list of dirty words, dirty, unsexy words. Common work plan, common accountability, joint up efforts. The more we converge, the more we reduce waste, duplication, and the more effective we are. And that's the whole nub of adolescent well-being. We need to bring it together. So before I'm thrown out by the moderator, thank you so much. Thank you.
Thank you for providing that scene setting, Anshu. And as you rightly demonstrated, a lot of potentials, but challenges remain. Costs of inactions, but also returns on investment as well. And welcome, Zoya. And before we launch into the panel, I would like to invite the youth advisor from Nepal, Urja, to share her story and reflection on how she has effected change. Uja, you can speak from there or here, whichever way you are comfortable. Yeah.
Thank you, Dr. Khosla. Good morning, our esteemed panelists and the audience. I am Urja. I have been working with youth-led organizations in Nepal, and I will be sharing some of my experiences as well as a little bit of country context on adolescent health from Nepal. So my work mostly focused on health of adolescent, and I started as a volunteer and a peer educator, and then went on to train other young people, monitor them, and then guide them in their advocacy journey. What I've noticed in this, I mean, I've been doing this for almost 6 years, which isn't a lot compared to, well, the audience and the panel I see, given that you've been doing this for a very long time. But I started as an adolescent, and I often get asked, what inspires you to do this? And honestly, I grew up in Kathmandu, which is the capital city of the country. I received probably one of the best education that people in Nepal can get, with access to services right around the corner. And still, when I attended one of the safe spaces regarding sexuality, I had nothing to say. I did not know about my body. I did not know about sexuality. And when I noticed that, I felt like, okay, if this is how I feel, and this is what my knowledge is about my health, I cannot imagine what is out there for all the rural people, all the other adolescents and young people in my country. So I think the answer is simple. We start because what's at stake is the health. And we're talking about the health of almost over 1.2 billion adolescents who are not just leaders of tomorrow, but also they're shaping our world today. And we at low and middle income countries especially, we have an immense opportunity for growth and development by investing in adolescent health and well-being. I also want to emphasize that today we have one of the most educated, most digitally connected and urbanized group of adolescents who hold immense potential. And in order to realize this potential, we need multi-sectoral collaboration for the investment and so, which our panelists will highlight again and again. But the most important thing here is bringing them and involving them and hearing their experiences. Now, I said that I've been a peer educator and I worked in Nepal. When I go out there, okay, this is something very recent. When I went there, and one of my other young person who is younger than me was giving a session on menstruation, and then she mentioned something like, okay, you know what? I would consider my boyfriend to be a green flag if he does not hesitate to bring me a pad. And all of the audience casually just nodded, and they were like, yeah, of course. Everybody understood the language. Everybody just felt like that was a very casual thing to say, just a normal conversation. And for me, that was very interesting and funny because I don't use words like green flag. I'm too old for that. And so that made me realize that, okay, even I feel like I'm not relevant anymore. So for us, the policies are being made by people much older, and I don't want to, I mean, I'm not saying that your experiences and all the things that you learned throughout these years that are not important and you're not important in the room, but you will have to come to us and ask younger people than me that what they want is changing, and they need innovative solutions. They need new things. You have to hear from them, and you cannot be like, we've been working on this forever and we know the problem. You know the problem, but do you know what works in today's context? So that is why it's very important to bring young people, and I also actually promised to share a little insight from Nepal. In this grim reality that we have today, where adolescents are facing new problems, we have emerging issues post-pandemic with climate change, digital advancement, conflict, everything going on. I was expecting more support and aid. I mean, everybody was, but surprisingly, the support is shrinking. So in this context, how do we stay afloat? How do we continue to do what we're doing? I think I would like to share some insights from the Adolescent Sexual and Reproductive Health and Rights Exemplus project, which was led by the African Institute for Development Policy. This project investigated some of the successful approaches to reduce adolescent fertility and promote ASRH in 5 positive outlier countries, including in Nepal. And despite all the challenges in Nepal, in the past 20 years, we have had many challenges from political unrest to a devastating earthquake. And despite that, we were able to reduce adolescent fertility, and I have to get this number right. So we reduced adolescent fertility rate from 2001 to 2020, from the year 2001 to 2022, from 110 to 71 births per 1,000 girls, which is a 35% reduction. And what worked? So what worked, what were the drivers, is that we have been able to address child marriage significantly. There were comprehensive approaches to address this, combining legal reforms with targeted social and behavioral initiatives, and this was identified as one of the key drivers for change. Likewise, we have over 1,300 adolescent-friendly health facilities right now in Nepal, and we also have comprehensive safe abortion service. We have legalized and expanded safe abortion care in Nepal, and there have been immense changes in the educational sector. Education for All Act and school sector reform particularly prioritized increasing enrollment rates and also making education free for the till the secondary level. So all these changes, in addition to including comprehensive sexuality education in our curriculum from grade 4 to 12, these were identified as some of the changes, some of the approaches that worked. And I know this has been going on for more than, I'm 24, and this has been going on for more than since I was born. So the approaches sound probably outdated, but we have to believe in research. And then if you want to know what else we can do, you have to reach out to young people again and ask them what they need and ask what works for them. So I will have to pause now.
Thank you.
So I will just say that I've been hearing from everybody in the past 2 years, I've been hearing their stories of change, the stories of persistence and resistance, and that has been very inspiring. And when I was really demotivated to do what I'm doing because of the global context right now, being here and being in this platform has inspired me, because I know that there is a whole community here and a room full of people who will back me on this issue. So thank you for being here, and I will pass the mic to
Thank you. Thank you for that, Urja. And really for an inspiration that you are and the work that you are doing. And thank you for also sharing the context from Nepal. Colleagues, as we launch into the panel, we do have a video which shares voices from young people from the region that we will play now. And as we cue that up, just to give you a little bit of an idea how we're going to run the rest of the session, we will go straight into the panel discussion. We'll have one round of questions with the panelists, and then actually have your interaction as well, and then come back to the second round of questions to the panelists as well. So if I could have the video now be played, please. Thank you.
Buka to atin ita niya lolos, ina ba ita setan desafio. Hanay sang ihe ita niya saung, ita hasoro barak problema barak ketebes adong sente será hasoro kona ba ranço livre, usa drogas, fumar biru, kontesi dana ba tambah ita sidau jovem ida sidau hatene onsa atau bukan nian rasik, adolescente ida sidau hatene onsa atau hatene nian rasik. Tamane maka foi impacto tebes kona ba onsa ni crescimento dan desenvolvimento hanay sa adolescente ida.
Kita tahu sendiri bahwa kebutuhan remaja itu unik. Saat mereka masuk remaja, mereka banyak mengalami perubahan-perubahan pada dirinya, termasuk mereka pubertas, dan mereka juga, kita harus memberikan informasi yang tidak boleh setengah-setengah atau tidak komprehensif. Remaja juga butuh tempat untuk privacy, butuh tempat untuk dihargai, butuh tempat untuk dilindungi dan bisa ngomong secara bebas apa masalah mereka gitu.
With the involvement of adolescents and youth into these health policies and these health services, as they are the future of Bhutan, as they are the future of the country, this would create a better aspect for them to be included and to be involved, as they have immense potential through the inclusivity. Adolescents and youth of Bhutan will have a better health policies, and the health services of Bhutan would be better with the involvement of adolescents and youth of Bhutan.
The biggest challenges that adolescents face in health systems, access services, and also access the information about these health services. Access to information is restricted about the health services, And even if they have the information, the access to health services, say sexual and reproductive health services, mental health services, there is so much of shame, so much of stigma and taboo in our societies that even if they have the information, it's very difficult for them to even go and claim those services. Adolescents end up suffering in silence and isolation.
If we include them into our policy making, or give their ideas as well, they could influence peer-to-peer. They have innovative ideas, they have user-friendly ideas, they have a lot to contribute.
In these times, what stops college students from availing mental health services is, firstly, I feel social stigma is a very strong barrier, as oftentimes we're afraid of what other people will say about us and how they will judge us if we share that we have issues regarding our mental health.
Adolescent health, invest now for a healthier future.
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 Thank you, WHO Sierra, for sharing that video. Helen, if I could come to you first. You heard these testimonies, you heard Urja speak. The challenges that the young people face today are enormous, and they just got magnified manyfold with the recent developments with aid cuts that Urja also alluded to. What can we do, and what role can partnerships play?
Well, thank you, Rajat, and thank you everyone for coming to the PMNCH event today on adolescence. Adolescent health and wellbeing has been a big focus for PMNCH, and we spent really 2023 pretty much dedicated to highlighting these neglected issues, because what I think we all appreciate is that there's been a lot of focus on the health of children at a younger age, the newborn, the infant, the under fives. Then the way we tend to forget about them until they become youth and over 18, and so there's been these neglected years. And I think the partnership of PMNCH was able to get a focus, working together. It's not just the work of a secretariat, it's all the partners came together around the Global Forum for Adolescence, which was not a single event, but a rolling year process in which a lot happened. Anne Shu referred to the chatbots and consultations, which involved 1.5 million young people. It was simply phenomenal. I remember as chair of the board when it was first said we want 1 million young people's voices. I thought, that's crazy. We've got 1.5. So, it was quite phenomenal. I want to thank also the government of India, which is just a tremendous and long-term partner of PMNCH. We had our board meeting here in the middle of 2023, and one of the feature events when we came was the government of India and PMNCH hosted, in the context of the G20 year for India, an adolescent forum. And it was simply incredible, the diversity of the young people who came, the voices, the views they expressed. I also remember we had almost an early daylight manifestation down in the main street of Old Delhi with FIA Foundation and Botnar, all our supporters, Government of India, and young people, really sort of trying to promote this idea of agency, voice, get involved. We can't, we need policies that are relevant, but you have to have voice and input to get that. So I think, for today's young people, the context is so different from when most of us in this room grew up, and we don't have a lot of adolescents among us today. I mean, when I was an adolescent, was anyone talking about climate change? Never heard of it. Was anyone talking about digital revolution or bullying on social media? It didn't exist. Was anyone talking about a pandemic? Only my grandmother who lived through it in 1918. It was another world. And then the thought of young people being instrumentalized by militias, this wasn't anywhere in our frame of reference, nor young people being instrumentalized by gangs, really. So the issues are a lot more complex, and they come on top of the desire of young people for education, the desire of young people for relevant health services, including mental health services. I know when we came to India, one of the issues identified was road safety. Young people said, we're not safe on the roads. You know, many of us are dying. We're trying to get to our university, our school, our work. It's not safe for us. So, you know, it really, I think, is so important to, A, understand the context, which is so different, but then what are young people saying about it, and what do they want of us? Now, just to conclude, because of this huge effort by the PMNCH partners, we've built up a lot of information. The framework on adolescent well-being has come out of all this activity, the action agenda, the 15 technical papers, the BMJ collection. I mean, there's plenty of evidence out there now. But, you know, global guidance, regional guidance, national guidance, all important, but make sure the voices of young people are in it. Otherwise, it won't strike a chord with the young people themselves. And they're ready to step up and lead, as we heard from Urja's contribution earlier. Thank you, Rajat.
Thank you for that, Helen. And really appreciate you making the point where you ended, that there is plenty of evidence, there is tools, so there really are no arguments for why we are not doing that. With that, I'll actually move to my two regional colleagues from WHO CRO and UNICEF in that order, and to really have your perspectives. Saima, you're not just the regional director. You are actually an expert on young people. You've worked with young people in your capacity in your previous life. So as you look at the region, what do you see? Where are the challenges, and also what can we do in this regard? Over to you.
Thank you so much. I mean, it is so exciting to be here and talking about this. And as you said, this is adolescents, youth have been my source of information, my resource, you know. And what has been the biggest challenge is that their voice really has not had the kind of space in the policy making, in the framework of programs. So what their needs are have gone unidentified for a very long time within health systems. And what's very exciting about being in this position as regional director now is that we're at that cusp of change, right? So last year at our regional committee meeting, we had a ministerial session, as we do at every regional committee meeting, and the topic was adolescence. And so we not only had 4 young people moderate the session, ministerial session, okay, 4 young people, 2 of them had disabilities. And it was probably the most energizing, lively, and informative session we've probably ever had. I don't think a regional committee meeting of WHO has ever been that exciting and fun. It was really fun. And it was designed by them. There was so much energy, but the right topics were incorporated. But they brought that pizzazz, or that youth would say riz. I'm getting better with the language. I have my 2 youngest teenagers try to help me update the language, and I'm very embarrassed when I used it. So, but you know, you've got to keep up with the language because they speak a whole different language. You know, their world is very different from the world that we grew up in. And as Helen mentioned, their realities are very, very challenging. We did not have these kind of challenges. They are well informed, they are outspoken, but the best part is that, you know, they envision solutions we can't even think of. So creating platforms and opportunities to engage their voice, engage and have that dialogue. We have in CRO the CRO Youth Council, we have the Southeast Asia Youth Health Asian Action Network. We are involving them in our different departments. We've launched a junior professionals program, and of course, it's not quite the same because they're already in their 20s, but bringing them in has already made such a big change from these very senior professions. You can see it in them, that they're thinking about things they didn't think of before. They are using language that is much more understandable, and actually looking at a health system point of view, that where are the barriers? Because you have to, before you come up with a solution, you have to understand where the barriers are. What is actually causing a lack of access to healthcare, access to information? You and I can't, predict that because we are in charge of our own lives. Adolescents are sort of, they're in charge of their own life in a way and yet not, right? So, that the trust, we really need to have the trust in them to be able to be decision makers. But the reality, of course, is that oftentimes they have access to information, a lot of information, and have made decisions that could be misinformation. So how do you help them build those skills so that they can decide on how to make the right decision for themselves, not preaching to them? Because that time is gone. I come from that generation where we were very well preached to and we were followers. This generation is not doing that at all. So we have to we realize that reality, that they cannot be preached to, they have to be engaged. So it is on us with our systems and setting up access to information in a way that will reach them, that will counter much of the misinformation, but also biologically and neurologically, it's such a critical point in time. Because early years, the brain is developing and we have a lot of neurological connections that are forming. Adolescence is again that same period in time, right? The entire frontal lobe, so your ability to plan, your ability to focus, ability to strategize, problem solve, all of that neurologically actually is developing in your adolescent years. You don't have those things before. So now what are they being exposed to now that may be impeding the best growth of the frontal lobe, right? So along with all of the other parts of the body, all of the other physiological changes, sexual identity, all of that information and everything that is going on with them, this is also happening in the brain. So if we want group of the next generations to have healthier lives, we have to ensure that we provide the right nutrients for them, they make the right choices, they are not exposed to things that are toxic, not just information, but also biologically toxic. So it's a complex situation, but we can't form the solutions without actually asking them and finding out from them.
Saima, and really for all that you and the team in CRO are doing, but also what I really like from your remarks is we often talk about meaningful adolescent and young people engagement. This shows us how we can operationalize it. And moving on to you, Sanjay, UNICEF is at the vanguard of work with young people, and you and your regional office, Rosa, has done some remarkable work when it comes to especially adolescent girls. Really looking forward to hearing your perspective on what can we do.
Thank you very much, Rajat, and wonderful to see all the friends and colleagues here. So I'll just, it's a hard act to follow both Urja and Saima, and then of course Anshu, who spoke before me, and Helen. But just a couple of contributions from our side. Firstly, picking up where Helen mentioned that we focused a lot on the early years, and that's still, of course, very important. And we've made business cases for early childhood development, and those of course still stand. However, what is important is that the benefits of those investments require ongoing investments into the later years. And so that theory of change that investing in the early years is important is correct, but it's in itself, it's insufficient. So I think that's important point to make. And this is adolescence is a second window of opportunity. I think that's a positive way to look at it. And certainly for me as regional director, and for us as UNICEF in our South Asia region, focus on adolescent girls is one of our 4 priorities. I think a number of the themes have been touched on. One of them is obviously the whole concept, particularly in South Asia, of valuing adolescent girls, valuing their opinions, and because it's a huge resource that the region sits on. If they're given the chance, adolescent girls are a huge power to drive change. And I've seen this for myself. I've been, of course, I'm also a resident of Kathmandu and Nepal, because that's where we have our South Asia regional office. And I've seen in Nepal a Rupantaran program that we do with UNFPA and others in very marginalized communities, working with adolescent girls, and how that really shifts the norms. I remember talking to some of the girls, and you know, they were explaining how one of the girls was explaining how she hadn't been to school, and so the obvious question from me as a kind of, you know, bureaucrat and professional in international development is, well, you know, now that you've been through the program, are you going to go back to school? And her answer is absolutely not. I'm not going to go back to school as a teenager with little kids, but I will make sure that all my siblings and all the children, you know, that I have, the families I interact with, that they will go to school. And it shows the kind of empowerment, not to give the answer that is expected, but also to be part of that decision making. And I think that's what we want to get to, is where you know, adolescent girls and adolescents, the boys, are empowered to drive the decision making in their, and this is what Urja was also talking about, to drive decision makings in their families, in their communities, in their schools, you know, where they can challenge their teachers, they can challenge their parents. And I think that's a huge mindset shift. And even for us, I mean, we do our bit around adolescent, you know, getting children's inputs into our programs. But of course, you know, we are the UN, we have our board of member states and all of that, and it's very difficult to really introduce, you know, not just beyond voice of children and adolescents, but actually getting their participation in our governance structures and driving, you know, our strategies and our programs. And I think that's where we would certainly like to get to. And it requires partnership. It requires all of us working together. So let me leave you with that for now, but thank you very much for this opportunity again.
Thank you for that, Sanjay, and really appreciate, you know, you said various things, but I think one of the things that I do want people to reflect and come back to as we go through the discussion is that these are not one-offs that we are talking about. We need continuous investment and to empower and enable young people, because they are not just recipients of services, they are active agents and leaders of change. And talking of boards, moving on to Government of India, esteemed board member for the PMNCH and also chair of our executive committee, Zoya, India has been at the forefront of work on adolescent and young people well-being agenda. As you look at it from moving on from regional perspective to country perspective of India, where do you see some of the challenges lie in terms of delivering on the framework that you have so passionately championed with the RKSK scheme, and what are the opportunities as well?
Thank you, hello. Yeah, thank you, Rajat, for that very interesting questions. I would just say that as a country, we do realize that adolescent and young people, the mental, social, and physical health is really very critical. India was supposed to be a very young country, but I don't think we'll remain young very longer. Because if you look at the predictive age group, we are progressing quite fast also. So we need to invest now, and the time has really come, and that is what we've been doing. But just to take a cue from what Helen mentioned is about road safety as an issue, and I am seeing Cynthia's also here. I mean, we had a session just before this about protecting young lives, in which we released guidelines about keeping children safe in schools by ensuring road safety, which was done in coordination with NIMHANS and UNICEF team. And that involved, I think, about 9 to 10 consultations over the last 1.5 years. So that is the kind of dedication which the government also has, and we are happy to work with partners to ensure that every child is safe, whether on way to school or on way back from school. Now, just about the emerging things, I would say emerging and persistent challenges, there's so much of cross-cutting, so much of, I think, overlap. We do have in India, for young people, we have the double burden of disease, we have undernutrition and overnutrition. Overnutrition now more and more, I think with the great ownership of the Honorable Prime Minister also, there's a huge campaign on looking at childhood obesity also. and adolescents. So that is something which is a persistent yet an emerging issue for us. Second is sexual reproductive health continues to be an issue. Despite a long-standing adolescent reproductive sexual health program, we still struggle with the taboo, the stigma, which was mentioned also by the young person here. That continues in India. Next thing which we are looking at is increased incidence of mental health. I would say it's not incidence, maybe it's a good thing that people are getting aware that you do need to address mental health. You do need to reach out for help, and where do you reach out for help? And that is where a challenge also comes for us, which is also a persistent challenge, is our own healthcare providers. How do we ensure that the young people feel comfortable talking to our adolescent-friendly health clinics? They have some kind of a non-judgmental assessment, discussion, and referral. So that is something which we are ensuring every year successively by building capacities. But yes, that I do believe is a challenge, because a lot of health providers have to, I would say, unpack their own thoughts and their own beliefs and then relearn something which is changing. And this adolescent is something which is having a challenging issues. Every year we have a new issue which we have to deal with, and that I think becomes very difficult with old people like us who are sitting in decision making. So yes, we do need to get back from young people what is it they want, how they want us to work better with them, make it more inclusive, make it more supportive. Another issue which we are also facing is digital. You mentioned about the digital intervention. It's a two-edged sword. All of us fully realize the young people do have access to a lot of information, but then they do have they are suffering at cyberbullying, trolling. Everything is happening. So how do we make digital spaces safer for these children? That is an issue, and that becomes an issue, I would say, that goes up into adulthood also. So how do we keep these young people safe during their interactions on digital media, so they're able to express their thoughts freely and they're not trolled and they're not vilified also for what they post on the social media. Next, I would say, which I think Helen also touched upon, is climate change. We never thought it's going to be a part of adolescent health, but it's important. What is the kind of country, what is the kind of environment we're leaving for these young people? And for that, we are continuously working with our partner ministries. How do we dovetail adolescent health interventions into climate change also? And last, I would say, our challenge which we face, of course, all of you know, is convergence. We have to work with our partners in the field, we have to work with our partner ministries, we have to work with the young people in the field, with our healthcare providers, so converging at various levels, whether it is at national, district, state, all of it remains a challenge. But I would say that push has come from the government also, that this partnership has to work. We have had so many combined reviews and meetings with our partner ministries, so I think that partnership is going to become stronger only by the day. And I think we would really reach there to reach adolescents where they are. And I think that's it from my side, and we'll see what happens. Yeah.
Thank you. No, thank you very much, Zoya, and very much appreciate you outlining those, variety of emerging old challenges taking different forms and shapes. But, importantly also what is required is an all-of-government approach and the leadership that Government of India is showing in terms of ensuring that all of that government approach is existing. We are moving to the last two speakers on the panel, and that was a way to give you a heads up. We'll be turning to you in the audience for your reflections, questions, comments, and then we will move to the second round of questions to the panelists as well. Aparajita, if I could come to you next, please, and you as a person, as a leader working at the intersection of gender, health, and rights, how do you think we can integrate adolescent issues in the broader development agenda, especially keeping in mind the marginalized and vulnerable groups?
Thank you, Rajat. I would like to actually take the opportunity to also acknowledge the programs that Dr. Zoya is leading. She talked only about the challenges because that was the question. But I think the School Health and Wellness Program and the RKSK program are programs which really warrants global replication, because those programs are showing results. Coming to the question, Rajat, I think I will also take off from where Anshu left off and talk about certain words which will help this larger integration, which is intersectional, break down silos, prioritize the most marginalized, empower young people as leaders, as partners. Now, Anju, you said these are what dirty words and whatever. I'm also adding to it, these are jargons. Often it sounds like jargons and platitudes. But the bottom line is that we have to make all of these jargons and platitudes a reality if we want to ensure that our young people are living their lives to their fullest potential. Again, Anshu, you talked about child marriage and data, and I want to take that example to talk about how intersectoral partnerships can work. You talked about 1 in 5 girls being married before 18 globally. You talked about, I think 1 marriage in 3 seconds. Just to add some more numbers to it, every year about 12 million girls are falling prey to early marriages, which works out to 33,000 girls every day. But what I want to add to this is there is also about 115 million men and boys in the world today who were married early. I think we often forget about boys, and my first peg for a better integrated approach is also the fact that we need to work with boys too. Now I want to again take an example of linking education and child marriage and women's health, adolescent health. So what happens when a girl is married early, right? So we know data tells us that if a girl drops out of school, her chances of getting married early is very high. And if she gets married early, she has no information or access to contraceptives. She has no negotiation or decision-making power, whether she wants to have children, not have children, how many to have, when to have. She will have unintended and multiple pregnancies, which will affect a country's MMR and IMR, etc. But I think she's not even skilled. If she drops out of school and gets married early, she's not skilled enough to make a transition to workforce. So what could be a solution which is not definitely coming from health? It could come from hardcore education. We know that there is evidence that if a girl finishes even just 12 years of education, her chances of adopting contraception, prevention of child marriage, in making her entry into the workforce goes up. So this is an example of how we can look at a more rounded adolescent well-being if you look at education too. My last point, Rajat, I think we, as an organization, C3 has been working in this space for last 38 years. I was just sitting and counting. While I agree with Helen and Saima that many things have changed, I also want to say that certain things have not changed. Our assessments, if you look at what we did in 87, 88, 89, and need assessment that we do now, is throwing up the same things, the school dropouts, the social norms, poverty leading to pressure on young people to go and earn, peer pressure, addiction. So some of those things really haven't changed. And I think we also need to keep them still on the agenda. But I think on a broader, if you want to work on an integrated way for young people, we have to look at life skills, mental health, emotional well-being. Many people have already spoken about it. I think what young people really need is their own capacities to negotiate better life choices. Who are we to make choices for them? But they need certain skills to make better life choices. I think skilling and workforce readiness is really important because the pressure to earn, pressure to join the job market is also really, really high, which then translates to mental health struggles. Saima, you talked about nutrition, and you talked about nutrition for growth development when they enter adolescence, but I'm going to go a few steps back and talk about early childhood development, because by the time a child is 10, they are already cognitively challenged because they haven't had proper nutrition in 0 to 6, 6 to 10. So I would also talk about that. But lastly, I think I would like to end by saying that I think we have models for delivery. And again, I want to go back to School Health and Wellness Program and RKSK because they have everything from adolescent well-being right down to road safety. I think we have to implement to the best of our capacity these programs. We have to evaluate and we have to replicate. Thank you, Rajat.
Thank you very much, Aparajita. And as the French say, plus ça change. As things change, they remain the same as well. Important point that you raised about male engagement, especially as we look at, as Zoya was talking about as well, issues in terms of the digital age and toxic masculinity that is being propagated on social media platforms, and how do we address issues around gender norms, masculinity, to address the issues that the young people are hankering information for. Sonal, you've been hearing for the last about 40 minutes all these wonderful leaders talk about the veracity of issues, their perspectives. All of them, I think, are roughly about 2 decades older than you, if not more. What do you make of it? Did they cover the challenges that you think? Sorry for aging people out, myself included. No, myself included.
Thank you, Rajat. I think I'm going to take you with that and just build on that aging issue and that segregation a little bit. But definitely, I resonate with everything that's been said before that we've been discussing since last 40 minutes. And I do agree saying that a lot of things have changed, but a lot of things have also not changed. And I want to dive deep into that. But before we do, can I please invite all of us into 1 minute reflective process, including my fellow panelists and audience. Please bear with me. Okay. I want to ask all of you and request everyone, how many of us remember how it felt to be 16 years old? Could you please show me your hands up. If you remember how it feels to be 16 years old, how it felt. Okay. Now please keep those hands up if you had a space, a safe space to talk about your bodies, your sexuality, without the fear of judgment or punishment. Please keep those hands up.
I know.
Okay.
I know conversation.
Please keep those hands up if you felt truly seen, truly heard, and truly empowered at that time. It's barely 3, 4, 5 in the room. Thank you, everyone. And that is the space where I want to begin speaking from. It lays a fertile ground for all of us to reevaluate our approaches when we talk about adolescent health and well-being. For those of you who are policymakers, donors, funders, teachers, educators, CSOs in this room today, it's a moment to think about how many processes and systems have we participated in which were co-created by young people, not as just consultants, but also as equal partners in these processes. A lot of the people before me, I think everyone has spoken about the statistics that are there, that are glaring, that are showing these gaps. While in March this year at YP Foundation, we were organizing a multi-stakeholder platform called Yuvani that celebrates youth leadership and centers young voices. We also undertook a process to review the progress made on SDGs and see where we are when it comes to implementing them. A youth leader from Bihar said that the only reason she's come to this space is because it's the first time in her life somebody has asked her, what do you want? What does she want? And that is why her presence in that process was there. When I was collecting data on, and I was looking at multitudes of data sets on adolescent and young people well-being, I do want to take a moment to say that we've made amazing strides in that regard. We now have a larger data set. We have had large sample size of adolescents and young people who have been spoken to, who have been consulted in these studies and researches. But what is missing is how many of these data sets and researches were anchored by adolescents and young people themselves. Were young people and adolescents at the center of creating monitoring parameters? Were young people and adolescents at the center of evaluating and drawing learnings from them? And that is something that I leave this room with. While Dr. Zoya was speaking about AFHCs, and it's a definitely right step in the right direction, it also presents us with an opportunity to evaluate how effectively is it even adolescent friendly, right? For a lot of times that we've gone to the ground and worked with adolescents, we've seen that some of these AFHCs are located in maternal hospitals, right, where it creates an immediate barrier to access, barrier of accessing by young men and boys, given the conservative social cultural setup that we are in today. While the clinical settings have also been reported to be triggering and isolating for people with gender diverse identities, people with diverse sexual orientations. We have stories and mapped data that says that. The language of the laws and policies also, while laws and policies have been made for adolescents, with adolescents, they remain incomprehensible to adolescents. It's not accessible. The language is very, very difficult, and it's gate-kept, which further excludes the inclusion of traditional social identities and other adolescents, right? If we look at sexual reproductive health rights and the strides that have been made in that regard, we do see an opportunity where we can do better. We have data on STIs, HIVs, use of contraceptives. we have data on even mental health issues like depression and anxiety faced by adolescents and young people. And while that is important and needed, do we take a moment to reflect on, do we have data or stories and mapped experiences of usage of contraceptives by trans masculine people with disabilities? We do not have that much data. We do not have those stories mapped. Do we have data on how many young people and adolescents in the region have been able to take choice-based decisions about their bodily autonomy? No. We do not have that kind of data, or even qualitative or quantitative. Our engagement has mostly been consultative and not co-created. Having said this, what young people, I think a part of my question was also to reflect on what young people can do to, call for more action and call for more investment, as we know that the cost of inaction is quite high, as mentioned by Anshu and as mentioned by my other fellow panelists. But what I also want to bring to this room is how oftentimes the burden, the onus of claiming these spaces, accessing these spaces is also put on young people and adolescents, right? When we know that today we haven't invested enough in building their capacities around values that they're absorbing, around the violence that they're facing in everyday lives, or around issues that they want to talk about, whether it is their bodies or whether it is about their sexuality. So how are we expecting them when we know that there's a clear disbalance of power which is not in their favor currently? So as much as there is progress that we've made in this regard, there's also remains a space where we can reevaluate some of the work that we've been doing and increase the space that is given to young people and adolescents at the table, because we deserve a seat at the table. We want to be at the table and not a fly on the wall, or not be told as, that, you're either wanting too much or you're wanting all the wrong things in the world. And with that, that's where I would want to.
That's lovely, Sonal. Thank you so much for sharing that. But you raise a variety of issues, and particularly appreciate the need for ensuring equity, inclusion in how we talk, and about the need for young people at the table. We'll come back to that. Colleagues, over to you. Questions, reflections. You will have to be very brief. There is a whole room of hands now gone up. We did not have the same. I would have to interrupt you if you go on a long speech. So try and keep it for 30 seconds or less so we can get more. Please, over to you.
Right, so 30 seconds or less. This is Saad Alam Khan. Little bit of background, work in the SRH youth space and all of that. I attended a session yesterday. Thank you so much for this panel. I attended a session yesterday, a panel on Global South Research Collaborative, where we were really talking about how the south of the world is communicating. And while the words are unsexy, but the question to the panel is, and I've worked a bit for a short time in the UN also, so I know when work plans are getting made, and it's really the question to the leaders from CRO and ROSA and PMNCH. One is, how do we strategically communicate about the findings of, say, the investment case? We're talking a lot about the private sector with the current resource scenario. How do we strategically communicate about the global south for this? Which is interesting enough for the private sector across the region to come about, one. Second, to CRO and ROSA from WHO and UNICEF, we need to address the elephant in the room, that while we have such great learnings coming in from this investment case, while we have such great learnings coming in, as Aparajita also said, from the SHWP program, what can we do in this region to really take those learnings into actions and into our work plans and consultative processes while we make the work plans? Because usually when we make the work plans, or could be my lack of knowledge in the UN, is when we make the work plan, we do a consultation with
That's other a very long
organizations.
30 seconds.
Sorry.
Thank you.
Sorry.
Thank you.
But I hope you get the
made.
point.
Point well made. Over to you, please.
Hello everyone, this is Sanjoli, and I'll keep it on 30 seconds. As a young person seeking meaningful youth engagement in adolescent health platforms, and like we heard about the ministerial declaration that came out of the CRO region, I'd love to hear from all of you, what are some common values in your experience which make these processes truly meaningful and impactful? Are there specific principles you believe should guide institutions and movements or initiatives ensuring that young voices are authentically included? When we keep talking about meaningful youth engagement, what are some guiding principles? Would love to hear from you all.
Absolutely.
Thank
Very
you.
important point. There's a lady at the back. Please go ahead. Somebody, microphone.
Thank you. So not as a young, not so young, but still working in the space of health and nutrition. So for the panelists, in the present landscape, gender and SRH have been given a major pushback, and but we do know that these are important for health and nutrition. So if the panelists have to, enlist key points in this gender and SRH space, what would be that?
Excellent. Over to you, sir.
Okay, thank you.
This seems to be the section with all the questions. Other people are sleeping or waiting for the coffee.
I'm Abdullah from Yemen, from WHO IMRO Youth Council. Actually, I want to say that IMRO Youth is not the leader of tomorrow. Just facing the largest crisis in the world, so they try to solve it. And they do, and trying to change the crisis to make solutions to our regions, and they cannot work alone. They need to integrate and participate with other, and I'm happy to hear that CIRO will launch the Youth Council nowadays. And WHO Youth Council IMRO, we work in 4 areas: that emergency, NCDs, One Health, and the last reproductive health. Thank you.
Thank you very much. We've got space for 2 more interventions. Please go ahead, and then the last one.
Hi, thanks for a wonderful panel. Just a reflection. I just wanted to say that talking to policymakers, there's a lot of emphasis on using social media and the internet to provide youth and access to services and information. But in actually talking to young people, there's a lot of constraints on how they use the internet and how the way predictive systems are set up on Instagram or YouTube allows other people to know what they're looking for. And within a family context or a patriarchal context, it's often we can't rely on these solutions, is what I wanted to say.
Thank you. Very helpful. And there was a last one right at the back.
So my question is, a quick observation, which is that around 30 years ago, I began working on HIV and AIDS and human rights. And in similar rooms 30 years ago, one heard very similar conversations. So my question really is, and I appreciate where Aparajita and others were coming from, that while we have succeeded in certain fronts, we're actually regurgitating a lot about what we should be doing. How do you embed change in government, for instance, so that tomorrow's bureaucrats, tomorrow's journalists, tomorrow's judges, tomorrow's, the entire ecosystem actually gets it as far as adolescent sexual health is concerned? So what is that one solution that you'd have to offer?
Thank you, Vivek. Welcome. Okay, back to the panel. Sanjay, I would like to start with you, if I can, please. A lot of conversation, reflections that we heard from our young colleagues as well about what does meaningful engagement actually mean. You have a lot of experience on different platforms on what that could entail. So could you share some reflections on how do we ensure the meaningfulness and how do we also ensure accountability for that? Over to you.
Thank you. Really, before I begin on that, I don't think anyone's got that perfectly, and I certainly wouldn't pretend that we at UNICEF have. I think it's as has been established here, it is absolutely critical, and the emphasis should be on meaningful and also I think I can't recall who said it, but it's about a seat at the table, not we've worked too long on kind of voice and amplifying voices and all of that. Actually, what I hear young people asking for is actually having the seat at the table and directly influencing decision making. What I can point to is a number of experiences in the region, including here in India, actually, where we and others have worked with the Ministry of Women and Child Development to really institutionalize some of the children's councils in some of the Gram Panchayat. So the government of India is trying to make that an institutionalized thing at local government level. And similarly, there are similar efforts in Sri Lanka and Nepal as well, and in Nepal actually, where several local governments are actually engaging girls' clubs in kind of local planning and budgeting processes. So this is, it sounds very mundane and so on, but this is really important because it is actually broad-based. It's not the kind of pinnacle. I mean, we all have seen the kind of things that happen, unfortunately, sometimes at the UN and elsewhere, where really impressive young people come and talk at these gatherings. But this is about broad-based participation at local governance levels. I think also important is that, and what we're trying to get right, and again, we also struggle with, is making sure that young people are part of informing our own programs. And I've been part of work on our climate advocacy, where we invite young people from across the region to tell us what we as UNICEF should be doing in terms, whether it's our programs, whether it's our advocacy and influencing, in terms of engaging or either helping them to, or ourselves engaging in dealing with the impacts of climate change on young people. But it's there aren't easy solutions to these things. But I think the bottom line is, as you said it yourself, Rajat, young people aren't just beneficiaries of services. They need to actually influence and be part of the decision-making process.
Thanks a lot, Sanjay. And really bringing home the point about the broad-based participation at all levels. And just to give you a very short example, for us at the partnership, it is integrated in everything we do now. We have under 30s on our board and in every structure through which we work. And just FYI, the AYC, or the Adolescent and Young People constituency for PMNCH, is the biggest constituency today that we are working with. So thank you to all young people holding us to account. Saima, what can WHO do to bridge this gap that we heard about from different participants in the conversation, and where do you think there are some opportunities to move forward?
I mean, certainly we've sort of just begun to recognize that the gap is there. And one of the ways, of course, when you talk about the UN system, when you talk about WHO, you're talking about a machinery that does not move fast and relies on people with a lot of life experience and work experience to come up, to take on the responsibility. So there isn't traditionally a lot of space, or hasn't been. Of course, our Director General has the Youth Council, we have the Regional Youth Council, but again, it's wonderful for them to have that space, but again, we're missing the adolescent years, right?
Yeah.
So one really good solution would be, which we had just sort of started, like I said, with the ministerial meeting, having youth run it, having the JPP professionals be part of different departments. This is not just happening in the regional office, but it's also something that in every country office. But imagine if every health topic that we have a workshop on, and we have a meeting on, that we have a session comprised of young people actually discussing it, learning about it, and discussing it, and giving us some solutions and ideas. Now, is it impossible to do? Not really. Is it going to take a lot of pushing to get it done? Yeah. But I think the moment you realize that there is value in experience from the field, and this is a health area, you don't, first of all, the acknowledgement that we don't know, right? We don't, the world today isn't what it was like for us at that age. It's very different. So we have to understand what language they speak. We have to understand what they are understanding of the world, and also acknowledging that they may have better solutions sometimes. They might find the solution that for problems that we don't know how to solve. So creating those opportunities. And the other thing is, adolescents are very, very vocal, and they use various platforms. So create some of those digital platform opportunities when you cannot physically have them, and listen to them and have greater dialogue. So
yeah. Thank you, Saima. Seat at every table, virtual or in person, and that's the way to go. Zoya, from a policymaker, government perspective, how do you think we can make our policies responsive to these veracity of emerging issues, threats, challenges that we heard about?
Okay, that is a challenging question also. So I think in the ministry we get thrilled by dealing with challenges. So I would say that how do we deal with challenges is actually to have the adolescent and young people on the table. And one of the way, I think a couple of ways which we do it is this: whenever we do a review of our programs, we try and do it in the regional fashion rather than national. And in the regional one, we always incorporate field studies in which we get hold of the peer educators. So because for us, they are our arms and legs, and they are the young people who we train, we support, and they have sessions among their own peer groups. So that is, I would say, being honest here, we don't reach all the adolescents out there, but we actually manage to reach the peer educators who interact with us, and they come back with us that these are the issues they face in the training. And that is why we have gone ahead. And with the support of a lot of our, I would say, our UN partners, WHO, our field partners, C3 is here, CINI, all of them, we have come together to recreate a peer educator module, which is being upgraded, and it has inputs from young people also. And we, in fact, we started and we have taken more than a year to work on it. So that, I think, is the commitment which government has, that we are recreating, we are updating, and we are improving on the materials which we use to talk to the peer educators by hopefully trying to learn their language, so that we are actually addressing the issues they are facing. Second, as Helen also mentioned initially, is about even during the G20, we had 5 regional consultations in which young people sat together and they voiced what were their concerns. And that was at the highest level. So that, I think, a commitment again from the government is we get them on the table. And again, I'm being honest here, we don't get everybody on the table, but then we do have representation. And that, we believe, is a very important step for us to have at least representation. Third, I would say, is also working with our other ministries. You know about the National Education Policy 2020, which looks at more investment and coordination to ensure health and well-being of young people in school, young children in school, so that they become healthy adults and have greater employment opportunities. So that is a vision of even the education policy. So I think the government is on the right track, and we believe whether it is the youth affair, whether it is sports, whether it is education, whether it is health, everybody has to have their own stake, their own bit to ensure that young people's health and well-being is critical, and they are, I think, put accountable also for all the interventions they're putting in place.
Wonderful. Thank you so much, Zoya, and really appreciate the learning model and approach that you talked about. Helen, if I could come to you next, do you think there is a disconnect between commitments and actions? That we are often floating in 2 different boats? How do we make it more seamless and merge together?
Well, 8 years at UNDP in New York and looking at member states sign on to grand declarations and aspirations and targets, and then when you came to count who'd done what, everyone headed for the hills, But of course there's a gap. Look, the rubber hits the road at the country level, and that's why I think it's so interesting what Zoya is saying about the practical ways in which you're endeavouring to reach out and do the consultation. And each country will do it in a way that suits their circumstances. In my country for years, we've had a youth ministry. And the job of the youth ministry, of course, is to keep the networks so that they can access. Now, you can also, I think, very important that the individual ministries have also got their networks. But if you have a sector ministry like a youth one, women's, we also have Māori affairs, Indigenous people, Pacific affairs, ethnic affairs. The idea is always to make sure that in the government system, there are people who are dedicated to hearing these voices and making sure they come into the policy setting. So, there's a lot of ways of doing it, and they're all good. And the issues that youth are raising don't fit neatly into one portfolio. So it can be hard to replicate the consultation across a number of different ministries. So that's why I think a youth sector ministry, and working with national and regional and local youth councils and so on, has a lot going for it.
Thank you. Thank you, Helen. Highest level of political commitment, the way to go. Aprajita, civil society is the one holding to account a lot of the actors that we have heard from. Where do you see we can go from here? And your views and final remarks now.
Can I disagree with your first statement? not true anymore. But I think I just want to, can I take a moment to respond to the question from the
Please.
end?
Yeah.
It's very hard to make systems work, and because we are dealing with very, very complex issues. But I think if we want to change, we have to be persistent. A program like RKSK or School Health and Wellness Program will take 10 years to smoothen out all the creases there, because it's well designed, but it's really, implementation is tough in a country like India or other countries too. So I think persistent, giving it time is important. In a country like India, if you don't embed in the system, it is not going to happen, right? So I think working with the system, how does it become, how is the system monitoring the program, budgets, all of that is really important, and I think measuring impact is really important. And I'll give you an example. We have been working with Government of Jharkhand since 2007 on a program called UDAN, in-school adolescent health. It has taken 15, 20 years to really make the program as perfect as can be, in a way. And then once it's embedded, it's recognized. Supreme Court, CGI recently, in a judgment on a child pornography case, actually quoted that program to say that this is a good practice which should be replicable. So I think getting it embedded in the system, whether it's a government program or something that you have tested, is really, really important. Now coming back to, like I said, role of civil society, don't have much to say about it, but I do want to talk about, we always feel like we have to do something for young people, but if you look at some of the movements that young people are leading, they did it themselves. The climate, against climate change, Greta Thunberg, did anybody go and give her a bilateral plan or whatever? Nothing. We didn't give her a project plan. It started organically. In India, in 2012, there was a very, very heinous rape, and that led to young people galvanizing, and it led to amendments in the Criminal Act of India, which led to fast-track courts, harsher penalties. Similarly, in India, in Delhi, we always say we can't breed, and it was only a movement led by students, the No Cracker movement, which made the Supreme Court pass judgment about not using crackers and all. So I think there's a lot of examples where young people are leading from the front. I think it was in Costa Rica where they have a youth council which is now embedded in the system. So I just wanted to make the point about, I think we also should not be very, very, that we have to do something for the young people. Young people need a little bit of maybe enablement, but they can do it. And lastly, I do want to kind of really talk about the What Young People Want campaign, because I think it did help around bring global consensus about what is needed to be done. And I think civil society, and now I'll try to respond to your question. I think civil society is, after all, a bridge. As long as we have a ear to the ground, we help in some last mile service delivery sometimes, in last mile accountability, and we bring in evidence about what works, I think then we would have served our purpose. Thank you.
Absolutely, absolutely. Sonal, that is a nice segue, and to come to you for very brief final reflections on any concrete recommendations that you would like to make for us to take this agenda forward.
Absolutely. I think I want to pick up from where Aparajita was talking about that young people are already leading, that there are evidences where enablement has proven that it yields results. I want to build on that and say that definitely young people need enablement, but they also need investments when it comes to investing in models. For example, we have evidence now that says that culturally contextual, rights-based, stigma-free, comprehensive sexuality education delivery models, implementation models, they work, especially when they're delivered by peers and they're led by peers. So the call is to invest in those models, upscaling them, replicating them across different contexts, so as to ensure that young people are not just participating in consulting, but they're also meaningfully engaging, making sense of what it means to lead some of these movements. There's also this call to action for saying that there's an urgent need in these challenging times to invest in youth-led organizations. See, organizing also comes at a cost. The resistance comes at a cost, and it spans and it affects well-being and overall health, while it also affects the quality of that resistance, the quality of that organizing. So the need is to invest in these youth-led organizations, youth-led spaces, whether it is through capacity building, whether it is through ensuring that the leadership is built, or whether it is through funding and donations.
And very important point to end with, Sonal, because what are we doing to invest in youth-led movements, civic space, which we know is constantly under threat in many societies, so that young people are able to do what they're required to do. So in the spirit of being led by young people and listening to young people, instead of me trying to summarize the session, I was actually going to ask Urja to do that for us and to conclude the proceedings. Urja, over to you.
Thank you. I mean, listening to everybody, it's really difficult to summarize all the conversations we had today here, but maybe I will end by saying a few things. Firstly, we complained a lot, I mean, in this session. We said there are many things that have not been done yet and many things yet to do. Definitely there are a lot of things yet to do. But I think I want to also thank everybody who has been contributing so far and showing this willingness to include young people and talking about this issue. Even having this session here at World Health Summit regional meeting and bringing us together and having this conversation. So I would like to thank all the efforts like Rupantaran programs like that are being conducted in India as well. But with that thanks, also I want to emphasize that it is not enough, honestly. I mean, everything is a little bleak right now, but we must not forget that we started for young people, so we have to continue and this has to go on. I just want to also emphasize that the inclusivity lens and the equity lens should also be brought in, and young people should be given spaces. Young people of all diversities should be given the spaces. And honestly, we talked about a seat at the table, but sometimes a seat at a table like this can be pretty intimidating for a young person. And for me, even knowing that Sonal is a part of this panel was pretty comforting. And also thank you to everybody who has been nodding constantly. That's also very encouraging. And I think small things like this make me hopeful that we will reach somewhere better. Thanks.
Thank you, thank you. Thank you, Urja. And thank you all very much for joining us this morning. Really speaks a lot for your commitment to adolescent and young people issues. Thank you, and have a lovely rest of the conference.
Good afternoon, everyone. If I can request everyone to be seated, we'd like to start our session on time. Good afternoon, everyone, and welcome to JPIGO's post-lunch session, Transforming Maternal and Neonatal Health, a regional approach to strengthening the quality of care. I'm really privileged and honored with the esteemed panel we've put together for this session. I'm going to call our panelists onto our panel. We'll start with Mr. Manoj Jalani, who is the Director for the Health Systems Development at WHO CRO. Sir. Thank you so much, sir. Dr. Jaideep Tank, who is the immediate past president of FOXC and the chair of YGAA committee at AOFOG. Thank you, sir. Dr. Devendra Khandayat, who's at the Gates Foundation. He's the country lead for the State Health Systems program. Dr. Aparajita Gogoi, who is the Executive Director for the Center for Catalyzing Change, C3. Thank you, ma'am. Dr. Hema Divakar, who's the National Convener for the Manyata FOXC program. And Dr. Ingrid Magnata, who's the JPIGO country head for the Philippines. We have one panelist who's joining us virtually from Nairobi. Dr. Ruth, have you been able to connect? Okay, so while we get her online, thank you so much to all our panelists, and I'm going to invite our moderator, Dr. Suranjan Prasad from JPIGO, who is the Senior Director for Strategy, Partnerships and Growth. Dr. Suranjan, over to you.
Good afternoon, everyone. Good afternoon. Good afternoon. Thank you very much for that. We were a little anxious. This is going to be post-lunch and this is going to be the last day, but you're definitely seeing a lot of us interested in this. Thank you so much for making it possible to be here. And we did, put together, we have Dr. Ruth also joining us from Kenya and a good panel here. So before we start, let's give a big hand to this panel, please. So just doing the mic checking. Dr. Ruth, are you able to hear us, and can you say a quick hello?
Hello to everyone in New Delhi. Thank you for the invitation to be on this panel. But I think I'm having a problem with my video.
Okay, Dr. Ruth, and we'll try to see how best we could resolve it. But thanks for being there, and we really look forward to hearing from you. I'll begin. So various Asian countries have definitely made significant strides towards achieving what we call the Sustainable Development Goal that's focused on maternal and neonatal health. One of the key reasons was, promoting facility-based birth. However, it's crucial to recognize that challenges still remain. Over 300,000 and 1.9 million newborns continue to die each year from preventable causes in Asia and the Pacific. So the emphasis that just having access alone is not enough. What we know today is that we need to provide quality, respectful, and safe care at the point of service. And this is critical for saving lives. In many low and middle income countries where health systems are often mixed, the private sector plays a major role, which could make up anywhere from 30 to 70% of institutional deliveries. And within this mixed health systems, we ask ourselves, how can high quality maternal and newborn care work. Though we acknowledge that quality is the key to ending preventable deaths and attaining universal health coverage, needless to say, this quality is varied across various health facilities. The belief that the public sector only needs quality and that markets can manage quality within the private sector may not be true. While public facilities may face resource limitations and have high patient volumes, the private facilities also face equally various challenges and operate under varied regulatory conditions that rarely mandate transparent quality reporting. This fragmentation leads to overlapping efforts, inefficient resource utilizations, and a wide disparities in health outcomes. Governments have taken initiatives in working towards a quality of care framework. In India, we have strong programming around labor room quality, where we have an initiative that incorporates standards, coaching, data audits across public facilities. In few states like Maharashtra, there has been a collaboration with FOXI called the Lakshya Manyata program that ensures implementation of similar standards both in the public and in the private sector. In the Philippines, the National Insurance Program called PhilHealth has established its own accreditation and maternity care packages which connect provider payments to compliance with evidence-based quality criteria. While a review, say, of Nepal, Pakistan, and Bangladesh shows that dedicated quality programs in the rapidly expanding private sector are still fragmented, generally limited to voluntary accreditation or donor-funded models, leaving large gaps in oversight, measurements, and continuous improvement. To make a meaningful progress, we've been working towards a collaborative regional strategy that involves bringing governments, professional societies, development partners, investors, payers, and frontline providers to accelerate this effort. And today's panel will be concentrating on what needs to be done and how it will be done. I just have one slide that I'd like to show, and Gaurav, if you can help put this slide up. Why does quality of care matter? While quality is a critical element for ensuring safe motherhood, I've actually mentioned this, the developing countries, do have a mixed health system. But there's a systemic effort that's required to bring things together. A strong governance seems to be important, a regulatory framework, a skilled workforce, which is a continuous process, and continuous monitoring or data gathering that helps in improving performance. But more importantly, effective financing that is required to take this forward. Thank you, Gaurav. You can now stop this presentation. I'd like to invite Mr. Manoj Jalani, who works for WHO CRO, but Sir has been part of the Indian health system for a long time and comes with large experience of leading one of the largest health programs in the world. Sir, looking forward to hear from you.
Good afternoon, colleagues. In fact, one of the scientific evidence is that people feel most sleepy around 2 o'clock to 3:30. Okay, so it's indeed challenging to be on the panel in this session post-lunch. Anyway, distinguished colleagues, partners, friends, it's indeed a privilege to join you today at this important gathering focused on transforming maternal and neonatal health, a regional approach to strengthening quality of care under Uniting for Quality. Now, we recently published the estimates on MMR and NMR and under 5 mortality, and our region, the WHO Southeast Asia region, has indeed made good strides in improving maternal and newborn outcomes. The MMR in India, which was around 400 in 2000, is down to 80. And similarly, there has been a much faster decline in NMR as well. Yet, despite all this progress, the figures on maternal mortality, newborn mortality remain unacceptably high in many parts of the world and in many parts of India. Now, I was looking at that report, and then what is the global best on MMR? And then there's Belarus and Norway and Sweden, which is less than 2. Okay. In India, it is 80. In Kerala, it is 19. It is Assam, it is 195. Now, if somebody asks what really is the key difference between the outcomes in developed countries and outcomes in Kerala, outcomes in other parts of the India, and basically one major key simple reason essentially is around quality of care. Okay, now more than any other area, in terms of improving health outcomes, so, you know, when I was there in the ministry now in WHO, you look at how do you, suppose you have to challenge of malnutrition and all that. That requires whole intersectoral effort, whole of society approach. But in case of improving maternal and newborn outcomes, major part, an important part is played by the health systems, and that is around quality of care in the healthcare delivery in our healthcare facilities. Okay. Now, we know more than ever before what it takes to prevent these deaths and improve maternal and newborn health outcomes. So the knowledge is there, the tools are there, and honestly, my own broader understanding is what continues to stand between the knowledge and outcomes is essentially implementation of that knowledge and tools that will indeed improve the maternal and newborn outcomes. It's also important to realize that without improving overall quality of care, it won't be possible to strengthen MNH, maternal and newborn health, in a siloed approach. So overall, we have to really work in terms of improving the overall quality of care within the health systems. Of course, I strongly believe that key entry point for that would be the maternal and newborn health. In terms of, so we had the Lancet Commission and then WHO and World Bank's quality of care, and each year, poor quality health systems are responsible for more than 8 million deaths globally in LMICs. It also translates into an annual economic welfare loss of $6 trillion. Okay. Poor quality of care, and not so much really the lack of access, is a larger contributor to preventable deaths, accounting for close to about 60% of that, and lack of access is only responsible for about 40% of preventable deaths, for deaths from conditions that can be treated. Clearly, the quality of care is not a luxury, it's a matter of life and death. Now, what defines a high quality health system? So I just borrow from the Lancet Global Commission, and which talks of a system which optimizes care in a given context by consistently delivering care that improves or maintains health, is trusted and valued by the population, and responds to the evolving needs of people over time. And at its heart, you can take as key values is people-centeredness, equity, resilience, efficiency, and lastly, learning and adaptation. And without really having quality, just improving access is wastage of resources. We really need effective coverage. Moving forward, what should be our regional approach? We are gathered together under Uniting for Quality. I think first we need to really invest in building a culture of quality, a culture of compassion, where every health worker, every health manager, every policy maker, community member understands and wants to provide the best possible care and wants to receive the best possible care. Of course, a lot of us here, we need to demonstrate, the leadership must demonstrate that in our conduct. And we need to really build this in our pre-service curriculum, in-service curriculum, and importantly, in terms of designing incentives that should really, try to advance quality of care. We've been sending groups of people to Sing Health in Singapore, and what impressed me, I'd seen an online presentation. Sing Health is that Singapore Health Services. This is about the owner is Ministry of Health, so they are the providers as well. It's not a private sector, but they really provide very, very high quality care and basically focused on averting, zero avertable deaths. Okay, so whatever deaths can be averted, they would like to make sure that all those deaths are prevented. And they have indeed, if you look at the data, they have indeed succeeded to a very large extent. I'll just give you a personal example. We're talking of quality, and I recall a few years back when I was in NHM, let me take you back. I'd gone to Nilofer Hospital in Hyderabad. I don't know, is there anyone from Hyderabad here? Okay, good. So that's maternity hospital there, public hospital. And the principal secretary there was quite enterprising and really looking to provide the best possible care. Okay. And we were there along with us, good set of colleagues who were really invested in improving maternal child health outcomes. And then we were going, now, talking of quality, so they built up the hospital. And then we said this, the labor room, and this is on the first floor or first or second floor. And then, the common question was, okay, where do the pregnant women come? Where is she brought by the vehicle? And then how does she go to the labor room and when she's in labor and all that? And then they said, okay, she'll go through this ramp and all. Now, I'm not a doctor, okay, I'm an engineer. I happen to be working in this sector. Now, if you're taking a ramp, okay, and it's going in an incline, and you have a pregnant woman, what's going to happen? The baby in the womb, it will be pressing against the chest, against the respiratory, this thing. Okay, now, this is more, again, it's an issue of quality, that are we really thinking of what really is needed from the patient's point of view? If you're taking her on an incline, I'm sure most of us may not really be thinking on those lines, but really it's not really advisable that you're taking a pregnant woman against an incline and the baby will then be moved towards the chest and pressing against the lungs. So it's then the principal secretary said, no, we will not do that. We will have this on the ground floor. The other experience was in terms of, I'm sharing more anecdotally because that's what relates. One of a senior bureaucrat, IAS officer, who worked in the health sector, no known name, said she delivered a baby on the ground while moving from one room to another. Okay, now this is the time to now go to the labor room. So we created the labor, delivery, and recovery all in one room, okay, so that the patient doesn't have to move. No. Now, I'm just saying that these are small things, but really add whole gamut of value to the patient. And that kind of thinking, comes from compassion, where you can empathize and then want to address the problem and try to come out with a solution. And I don't know if anyone thought about what really has gone in or this waste of resources, and we're not using the ramp, and we're now creating the labor room. And the entry also is from a different thing. The pregnant woman doesn't have to come. She comes straight to the triage. She doesn't go to the, raising tickets and all that, so that she's put on triage, and then you are able to address the patient as early as possible in the best possible manner. But these are some things that we need to do, and trying to build in that kind of culture, both, in terms of compassion as well as learning and quality. Another is in terms of learning from positive practices, both within, our country like India is so large, and there's huge laboratory. You have so many state governments, national government, you have private sector, huge private sector, and so much of learning is happening. What we need to do is identify good practices, enable sharing of practices, enable scale up of those practices, particularly in the government. It could be backed with government funding, but really helping create a culture of learning and facilitating this kind of learning. Third, in terms of defining quality, standardizing quality measures at scale, including the perceptions of the patient, and strengthening measurement for action. So it's not important just to collect the data, but also use the data for driving improvements, and evidence-driven action that way is really critical. Fourthly, in terms of building system-wide quality foundation, this is across health financing, human resources, models of service delivery, health information systems. Lastly, I was also, and it's something that used to trouble me, and we used to work closely with the states on that, is in terms of, measuring civil registration and vital statistics. It pains me that we still can't capture all the births and deaths. These are so visible events, such foundational events. So we certainly need CRVS, robust, complete, comprehensive, timely, and we also need good record of cause of deaths. And so why do we need to wait for population-based surveys? If we had comprehensive and complete CRVS, I will know what is my IMR today or under 5 mortality today, because we have captured all the births and all the deaths, and we will know what's working, what's not working. And equally important was in terms of undertaking audit of every adverse event, particularly maternal death, newborn deaths, etc., and really getting to the roots. Both the clinical audit as well as the social audit. I think some of the states like Tamil Nadu have done it systematically, and have seen a lot of improvements on this account, and I think that needs to be institutionalized. And last but not the least, we must ensure that quality improvement is really people-centered, respectful, responsive, and tailored to local needs. I know, some of these examples around birth companion, care companion, even now talking of maternal and newborn care units being together. I think these are some very good interventions, and we need to explore them. Lastly, I'll just conclude, spending scarce resources to expand services without ensuring quality is not only inefficient but unjust. A maternal death during childbirth, a newborn's life lost within the first days that is preventable, represents not only a health system failure but a moral failure. The good news is we know what to do, we have the tools, we have the knowledge, we have the successful examples to learn from. Only it's a matter of will, commitment, and action. Let's commit as a region to uniting for quality, to transform not just maternal newborn health, but the very systems in which mothers and babies entrust their lives. Because in the end, quality is not about systems or statistics, it's about people. It's about dignity, it's about saving lives. Every preventable death is one too many. Thank you.
Thank you, sir, for setting the tone for today's discussion. I think you laid out key principles, that are needed for quality of care. People's, being responsive, respectful, and tailored to, the needs. And you've also talked about the various components that need to be required for a good quality of care system. Before we begin our panel, I'll also like to invite Dr. Devendra Kantayat to come and give his perspectives on quality of care before we start the panel discussion. Dr. Devendra.
Thank you. I think first, I think post-lunch sessions are never easy, but I'm seeing the enthusiasm as well as activeness, and I think thank you, sir, for setting the tone. I will be quick in my remarks. I think quality is not afterthought, quality is in the center stage, quality is quintessential, quality is important for achieving outcomes, sustaining it, etc., etc. I think it's no debate. Everybody is on the same page. I think long time back people were questioning whether it is yes or no, etc., etc. We have passed that time now. I think to me, and there are several levers which are created, accreditation, committees, processes, and the way the whole quality is looked at, and that's great. But if you ask me, what is the question in the quality space right now? I do have a couple of thoughts. These are, so let's look from a lens of typical health system. There are three aspects of health system, all of us know. Finally, we want the system within which the quality sits. It should deliver better outcomes. If the mother, child, any patient comes to the system, that patient should be cured. Staying in the facility should not drain its pockets. And at the end of the day, the patient should be satisfied. So outcome, out of pocket, and the satisfaction. If by and large, if we address these three, we generally say that our system is by and large performing better. But when it comes to the quality of care discussion, suddenly then we take it as a quality of, and Dr. Jhalani beautifully highlighted several points, and that's why there may be many overlap between what he said and I am saying. How do you create the ecosystem for quality so that it doesn't remain on the fringes? It is not only limited to some accreditation, some certification, some meeting, some processes. So then, that's where I feel like we are not mixing health system levers with quality strongly the way we should mix. Let me take the example. If you want to prevent the deaths of the newborns or the mothers, the place is the labor room. If you want to save the newborn, majority of the newborns are going to die because of the asphyxia. But imagine if there is only going to be one nurse, which is nurse or nurse midwife, who is going to be there in the labor room, and she has to handle several things, whether she, at the time of crisis, at the time of the golden minute, whether she will be available to manage the newborn against asphyxia. And here the quality boils down to the HR availability, HR insufficiency. Let's take another example. We say, oh, provider time, doctor's time should be this much, X minute and Y minute. But if one provider has to see 200 patients, then expecting that he or she will deliver the quality and spend sufficient, again it boils down to the HR availability. And okay, many will say that HR availability is not going to be the panacea of everything. Of course, the intrinsic motivation is there. And I think recently I think Piramal Foundation is working in Bihar on developing some rituals around the intrinsic motivation, because finally numbers are there, but finally they should provide the compassionate care, as Dr. Jhalani has said. Same thing will go for supply also. My limited point is, finally quality will be closely linked with the trust of the people in the system. Trust of the people will be closely linked with the availability of the drugs and diagnostics. So how do we create a system? How do we have a system where supplies, drugs, diagnostic are available? I will give a small example. I was in Sri Lanka and I was chatting with some of the head of one of the tertiary care hospital there, private tertiary care hospital. And I was asking him, what is your biggest challenge? What is your biggest fear? He said, and I quote, he said, my biggest fear is increasing quality into the public sector. If you want to improve the quality, the important thing is how do you create the competition among the facilities, whether it is a public, whether it is a private, whether it is from anything, how do you create that competition? I think before I close, I just want to make one last point. Many times we are still thinking quality as an afterthought. Quality as, okay, I have done this, now I will focus on the quality, or simultaneously. In most of our elders, so for example, my mother daily wakes up, she does puja, she listens to some hymns, then she does there is a ritual. It is an autopilot mode ritual. She is 80-year-old, it's an autopilot mode. Unless and until we create the rituals amongst the provider, quality cannot be afterthought. It has to be in an autopilot mode. And for creating the autopilot mode, that should be the part of ritual. And there is enough literature that rituals helps in better outcomes. So how do we create that ritual? Lastly, there are two paths of making a change. And I always say that, let me summarize with this. There is one path of relentless incrementalism. I will continue to improve, relentless incrementalism. There is another path of transformation. Relentless incrementalism is a non-glamorous word, because we love innovations. We celebrate innovations. Relentless incrementalism is non-glamorous. And that's why many times we enter into the path of innovations. Of course, transformative paths are important, but unless and until relentless incrementalism is followed, quality of care and a quality word will be only in the margins. Thank you.
We're happy to have these two opening remarks while Jhalani sir talked about what needs to be constituted and the principles. Dr. Kandait stressed on the how to do it and what it takes to get a system to come in and to be put in place. In today's panel, we have Dr. Ruth with us from Kenya. And Dr. Ruth, I'm sure you can hear me, and I was wondering if your video the issue with your video has been solved?
Yes, I can hear you, but the video is still not working.
Okay. You probably also can't see us too, right? That's
No, I can see you. I can see you, but I can't activate my video on my side.
Okay.
Yeah.
Okay. I think we'll move ahead. Dr.
Okay.
Ruth, and thanks for being here. I know we would have liked for you to be here in person, but the issues with visas are something that we can't really, So we'll start with you, Dr. Ruth, from the room. You've heard about the overview statements on quality of care. Could you just provide us an overview of the landscape of quality of care in Kenya and any strategies and interventions that have proven effective in your context?
Okay, thank you so much. I'd like to agree with the previous speakers that quality for a long time has actually remained like an afterthought. So initially, people worked so hard to improve access, and that was thought to be the problem. But we have actually maybe 98% skilled birth attendants in Kenya, and over 60% of women actually accessing care in health facilities, but this has not translated so much in improving our indicators. So we've also realized that we're also having a problem with quality. So what do people access? So in Kenya, we are trying to really improve in terms of standardizing across the public and private sector. We have our ministry that gives us national guidelines, which even the most basic of facilities can adopt that. And then we also have other platforms like the maternal perinatal death surveillance and response platforms where people discuss the issues that are affecting their delivery. And then in Kenya, the health sector the health system is devolved. So we do have also counties which support the facilities within their regions. And I think we've also been struggling, just like what you speak about the countries in Asia, is that we also struggle in terms of collecting of the data, that not all points of data collection have actually been set up and not all of them are collecting data in the correct way. So sometimes you're unable to make proper decisions. And I think the other issue is we've actually been trying to also make sure any guidelines that are adopted in Kenya are purely based on evidence. So that has been kind of our experience, but I agree that quality sometimes has been in the periphery, and we need to find a way to integrate it into our daily work because it affects our outcomes eventually.
And thank you, Dr. Ruth, for talking about what's happening there in Kenya. And Dr. Hema, probably we've also we've been on this journey for a long time, and we can easily identify with what Dr. Ruth has been talking about Kenya, because somehow it seems to be that these problems are the same everywhere. But you've been on a large journey for quality of care in the last 6-7 years. Ma'am, would you want to reflect on that, both the landscape, today's thing, and what do we see in the future?
Thank you, Suranjan. Namaskar. I think the last decade has brought many insights into what the private sector offers, as how that's been one of the focus of the discussion and debates today. We have to place on records sincere thanks to our parent organization, FOXY, which is a group of 40,000 specialists. The champions and the master trainers are also from our end. The ones whom we are accrediting, the facilities are also owned by the members of our own community who are serving in the private sector. To us, and I'm sure that Jaideep Tank will agree with me, that any girl, any woman, whether it's private or public, the minimal evidence-based, non-negotiable care to save lives, it's a given. It must be offered. Even that is not happening adequately across all sectors. And before I move ahead with my response, if you see the tagline of this very summit, you say scaling the access. Yes, the access to institutional deliveries, we have come a long way. More than 70, 80, 90, 98% are delivering in the institutes. Then the equity, the reach between urban, rural. Yes, the technology has also helped. There are e-Sanjeevani programs and many others which have taken the route of point of care testing, and everything is happening. But where is the word quality on that tagline? Yes, the access is ensured, the equity also to a certain extent, but it has to be with the quality. And when we went into the private providers saying that Manyata is our flagship program and we are going to do this, that, and the other, The only question that private provider asks, what do we have to do? Do we have to change our infrastructure? Do we have to change our staffing? And we said, no, nothing. And therefore, the buy-in for this was very easy. And what did we actually do there? And as Jelani sir said, it's all about implementation. We found a variety of cadres of the staff, some of them who knew nothing about maternal care or labor room care or neonatal care. So they were obviously not doing anything, but just moving around in the center. The second, who knew something but were not confident and competent. The third, who knew but were not allowed to do because it's a private sector and the specialist wants to step in at every stage and, they say, no, it cannot be handled at the staff level. That much empowerment was not there for that staff, so to say. And the last, as one more example was mentioned, there are one or two in the center who know everything and who do everything well, but they have to be available at that time, otherwise nothing works. So this was the mix of things. So when we entered the segment, the reason that the program has stood the test of time last 10 years and we are geared up to scale it to much more is because they found the value in that. It was a team training. It was that everybody were confident and competent to do some basic 20 standards as per protocols. And overall, the work culture changed because they felt themselves responsible and responsive to the need of the hour and the self-dignity, self-confidence, whatever you call. That also scaled up. So this is the quality in a nutshell, what we speak, comes right across in an intangible way, if you may say, after this program has come into being. We have still a long way to go. There are gaps because the data documentation and the robustness of continuum of quality in the very centers that we have trained. Again, it's a repeated exercise that we have to do, and once is not enough, and doing it in a small segment is not enough. The last thing, Suranjan, I want to say is, why is it that they're already in the system, but they don't know what they're doing? This again brings our focus to the in-service and the pre-service training, which needs to be strengthened. So in our state, we are toying with the idea of finishing school for the 700 nursing schools that we have in the state of Karnataka, so that they do a 3-month course before their final 6 months is over. They already carry a Health Sector Skill Council certification so that they're empowered with the basic 20 standards that we are talking about, uniformly the same thing. And once they graduate out, then they are the most sought after human resources for the centers that we are talking about. And so I think that if we tie in the electives for the outgoing students in a manner that we ensure not only certification, but the competency and confidence, I think we would have done our job well. So that's my take on this.
No, thank you, Dr. Hema. I think it's been a long and passionate work. And passionate, why I want to say passionate is because, when it started, it was just a thought. It was just, okay, let's do something. But it actually only kept growing and growing because a lot of people wanted to understand what it was. Initially, everybody thought by just setting standards, everything will become all right. And then standards were set. But then it was like, okay, how do we make sure that these standards are followed? So we thought just by training people, it'll get better. But then we know that that was also not enough. Then we said, okay, why don't we do before pre-service? Why don't we do in-service? How often do we do? Do we want to actually bring in certification? Who will do the certification? What we saw was certifications were being done by some people who never even entered a labor room. So how do we bring in peers to do the certification? How is that possible across time, across geography in India? How do we make it effective? And what you were talking, ma'am, is much more like, how do we look at, bringing in all these various players together and coming together? I want to bring in, Philippines now. We have Dr. Ingrid with us. We were expecting Phil Health to come in here. And Dr. Ingrid, I want to ask you to reflect on, what is the quality of care ecosystem in the Philippines? And after you tell that, how does PhilHealth, a kind of an assurer for universal health care, by the Philippines government, how does it play a major role in ensuring quality of care?
Okay, thank you, Suranjin, for having me here. Actually, in the Philippines, the game changer is when the country issued a policy on institutional delivery sometime in 2008, and I was part of this journey. And this was before we have the project with World Bank, EU, and ADB, which is the project on Women's Health and Safe Motherhood program. And as an offshoot of that, the country really made a bold move to have this policy in place. And coming up with this policy, of course, would entail a lot of components such as capacity building. The country did a training on the frontline service providers nationwide. And then, of course, we look at the readiness of the local government unit. The country is in a decentralized healthcare system. And we look at through the Department of Health and supported by World Bank, they establish birthing facilities nationwide. And then the second game changer, as you're emphasizing now, is the financing component, wherein the country incentivized the facility-based delivery. So through the social health insurance, the facilities were accredited by the social health insurance for them to be able to access that cash payment, wherein each of the normal spontaneous delivery in this facility-based delivery at the primary health care level would be able to access reimbursement from social health insurance. And because of that, there were a lot of private birthing facilities somehow that you can see it operationalizing in the countryside. So not just in an urban area, but as well as even in the countryside. So with that, after like 10 years of project of that implementation, we're able to see a reduction in maternal mortality because perhaps of the, facility-based delivery with that competency building, not just from the primary healthcare level, but looking at the continuum of care. We look into the referral mechanism. But now we're looking at, there's a plateau now as far as maternal mortality reduction in the country. We're looking at the quality of care. That's where now the question on, we're having maternal mortality not at the primary healthcare level, but we're looking at maternal mortality now coming from the hospitals. So that's the challenge. So we need to now to look into what's the quality of care, what's the quality of services happening at the hospital. That's why with the discussion of with Manyata, we're looking at the participation of the POGs, which is very much into the quality of care as far as the service delivery in the hospitals. So we're looking at the quality of care in the context of quality improvement process, because we have the standards. Through the social health insurance accreditation process, all these standards are in place. And POGs and then the Department of Health are looking at it. But of course, in the context of quality improvement process, the country, POGs, DOH, the local government units, they all acknowledge that, yes, we need to improve on some certain areas. Now we're looking at the discussion on the clinical standards. Because we all know after the training, after that BMONG training, not all midwives are indeed using magnesium sulfate. So that the hospitals are receiving those women with who are eclamptic and pre-eclamptic, so they weren't able to manage them. So that's where now the discussion to look into the quality improvement, and then in the context of the universal health coverage, healthcare providers network. So we need to look into the big picture of looking at the capacities of all the facilities within the certain area, say from primary level and then up to the referral. So we can look into that again, not just the primary healthcare level, but overall in the context of health system strengthening at all levels.
No, thank you. Thanks, Ingrid, for sharing with us, the landscape and what's happening in Philippines. I'd like to go to Aparajita. Aparajita, represents the White Ribbon Alliance here, and both Mr. Jalani and Dr. Kandait, talked about the importance of being technically right. Quality means being technically right. That is, having standards, that take care of safety and, are evidence-based. The second thing, you talked about is being efficient. That is, being cost-effective in whatever we do. And the third, you talked about providing satisfactory care. And a lot of times, as clinicians, we go in with a very biomedical approach of largely looking at just clinical standards. Or if I hand it over to a manager, they largely look at it from a facility standards point of view. And so we are stuck between these two different points of view. And sometimes we lose out on the clients or the people's point of view. Aparajita, could you talk a little bit more about, how would you bring in this client feedback or citizens' feedback, and how can we make that an integral part of the quality of care package?
Thank you, Suranjan, for that very easy question. I think when you talk of truly integrating stakeholder feedback into QOC, there's two parts to it. One is the collection part. And I think collecting feedback is still slightly simpler because you have technology, etc., which is going to help you. And if I talk in the context of India today, we have multiple mechanisms at play right now. Government of India has Mera Aspatal, which is based on SMS and outbound calls, where women can give the feedback, families can give the feedback. Under Government of India's program, flagship program, Suman, there is a grievance redressal mechanism, which has both a helpline number, help desk, and the most important thing there is time-bound response is required. If a family or a woman puts in a feedback and action has to be taken, it has to be taken within a specified period. So I think those are the two biggest systems in the public system in India today. In the private system, a lot of innovations are going on. I know that MSD of Mothers supports Together for Health platform where women can give feedback anonymously after they give birth. And I think there is the eSathi platform also working in Assam, which helps women provide feedback. So that's one kind of feedback. And there is a second kind of a feedback, which is C2B, consumer to business directly. Dr. Thank Practo, where consumers give feedback directly to the providers. And I guess it also makes an impact on the business of the provider. Or you go to Make My Trip, restaurant reviews, hotel reviews. So those are feedback mechanisms where they don't require any intermediary. If I don't get feedback, good feedback, it's harming my business. So I better act on that feedback. I better incorporate that feedback. So there's a multiple of ways of collecting feedback. But I think what is really important is how are we incorporating it into improvement of quality of care. My submission is that I think it's really important to hear directly from women. And the What Women Want campaign, which was done by White Ribbon, is an example of how feedback can be collected, curated, and action can be taken on that. But I think what we've also realized is that if you want women to give feedback, it has to be very easy to use, it has to be accessible, it has to be simple. Chatbots are very, very popular today. But when you tell me that you're introducing a chatbot to collect feedback from women who with very low literacy level, with very low agency to give any kind of feedback, then I feel that maybe that system is not going to work. So my first submission is that hear directly from women, but make it simple, accessible, easy. My second one is that there should not be any reprisal if I give feedback. I think a lot of time, whether it's in a hospital or it's an ASHA talking about a health system, or me as I don't want to give feedback to my supervisor because maybe, they'll cut my whatever, increase. So I think somehow we have to figure out a way that if I give feedback, there should not be any reprisals. Next time I go to the facility, the doctor should not tell me, you had told me this, so I'm not going to give you proper service. Third submission, and very important, is there must be redressal. I think a lot of us are tired of giving feedback because then we see nothing happens. You keep writing, you keep providing feedback, but that doesn't no action is taken. So I think redressal is really important. And I know that Government of India, in our public system, we have Rogi Kalyan Samiti, etc. We have the QOC circles, which is mandated to act on the feedback. Private sector, what they do on the feedback, I'll leave it to Dr. Tang to talk about because he's coming after me, as in the panel. The last thing, Suranjan, is sorry. The last thing I want to talk about is, Suranjan, why can't we have an integrated feedback for both private and public system? A lot of you who have taken flights, you would hear them announcing that there is a service called Air Seva, which is by the Director General of Civil Aviation. And whether you're DGCA, whether you're flying by Indigo or SpiceJet or whatever, you can provide a feedback. So can we have an Air Seva kind of a way where we can kind of consolidate feedback both from the public and the private service? Thank you.
No, thanks, Aprijita. I think you talked largely on, on how do we channelize voices, and I think that's very important. And maybe in the next round, I'll also, we'll want a little bit more on what exactly do we want to also be specifying and talking about. But Dr. Tang, I'll not immediately ask you to respond to Aparijita because I have another question for you. And but you're free to respond if you want. So when we've been looking at how do we bring in quality, we were talking about somebody holding this, right? And so if I ask a political science student, they will say that the government has to hold it. The government is the regulator. The government is the one that has to assure services, and that's a textbook case for many things, be it the TRAI, the IRDAI, and the multiple regulators. But what we also saw is there's so much of pros and cons for a government system. The other system which is followed in developed countries and what's happening in Philippines is when a universal healthcare program kicks in and private sector comes in. So then you have this universal healthcare program, like here you have the PhilHealth, or maybe one day the PMJY could become such kind of a program where you have universal healthcare coming into country, could play that role. And that's what's happening in the developed country where the insurers, do this. But the third most important thing that we've been trying here is through professional associations and professional associations like Self-Care. When I was looking at the regulatory market, the Press Council of India is a true understanding of how the advertisement councils are done by what they call the industry, and set norms and set standards to take it forward. Can you reflect on this, and why do we believe that the route that we are taking on professional associations seems to be something that holds promise?
Thank you, Suranjan. First of all, thank you, Jhpiego. I think Jhpiego is probably Foxy's oldest partner in the development sector, and I have a very special relationship with Jhpiego because Jhpiego was introduced to Foxy by my father. So it's been an old partnership, and in a way you could say that Jhpiego is now institutionalized within Foxy. So whenever Jhpiego brings a proposal, it is more or less a given that Foxy is going to participate in it. So thank you very much to everyone who's been part of this journey. And I must acknowledge Dr. Hema Divakar here. She is the one who actually started the journey of quality of care in Foxy. And as you can see, she continues to lead it with great passion. About professional societies, and particularly about AOFOG and the role that AOFOG is playing. For those of who may not know, AOFOG is the Asia-Oceania Federation of Obstetrics and Gynecology. It's a federation which is a regional federation and brings around 27 countries together. And when we were thinking of how to expand the ambit of quality of care, we thought AOFOG would be perhaps the most appropriate organization to do it with. There have been a lot of lessons that we have learned along the way, and I think one of the most important lessons that we have learned is perhaps derived from what Albert Einstein says, or the quote is at least attributed to him. I'm not sure he said it. Frankly, Confucius and Albert Einstein seem to have said so many things that I don't know when they had time to work, that they just seem to be. So apparently he said that insanity, the definition of insanity is doing the same thing again and again and expecting different results. And I think the one big lesson that we are learning now is that quality is local. And you can't really apply, you can certainly apply some lessons across countries, but you certainly cannot impose, or you certainly cannot say that because this worked in one country, it will work in the other country. I think this is perhaps one of the most important things that we are learning. The other important thing that we are learning about quality is that we think that we have a good definition of quality, but as you go along implementing quality, you realize that perhaps we are lacking in understanding quality in terms of perceptions and needs. Different people in different resource settings have different perceptions and also different needs for quality. I think we really haven't spoken about this enough. We also have not probably contextualized quality within different kind of resource settings, and these resource settings could be, as has been said, human resource settings. It could be infrastructure resource settings, and I think we need to therefore recontextualize or reframe the conversation around quality, taking all this into account rather than saying that these are our standards, this is quality, and this should work across everything. We also have very clearly now realized that when you start talking about quality or implementing a program for quality, it's a mistake to assume that there was no quality to begin with. I think this was a learning from Manyata also. A lot of times, because the quality of care that is provided is not articulated adequately, the impression that comes across is that there is a lack of quality. And I think, again, this contextualization of how implementing programs around quality of care is quite crucial. It's also important, I think, and we are now understanding what are the incentives, particularly in the private sector, for providers to adopt quality of care. I think this is a very important lesson from Manyata and also from the other countries whom we are working with now. And I think it's a clear realization that you need to incentivize the delivery of quality of care. It's not simply enough to say that quality of care is important. You need to provide quality of care, because that would mean you're depending on, in a way, the altruism of the entire system. It's not the altruism of the provider or an altruism of the human resource. It's an altruism of the entire system to look at quality as an end to itself. And we know very well that what works best is not altruism in the long term, it's always incentivization. Now, this incentivization, unfortunately, particularly in the private sector, has been taken to mean revenue. But I will say this, again, as someone who's worked in the private sector for over 3 decades now, that the private sector, while looking at revenue, it exists for profit. It's not an elephant in the room anymore, everyone knows that. But at the same time, everyone who runs a private sector nursing home, hospital, OPD, is essentially an entrepreneur. And for an entrepreneur, while revenue generation is important, risk mitigation is equally important. So when you want to incentivize providers to provide quality of care, even if you're not generating revenue, if you could incentivize by some risk mitigation or some way in which the administration of quality becomes easier, which leads me to the second point and feedback. It's high time we ask ourselves the questions, what are we doing for the providers to make them deliver quality of care easier? Are we taking the provider point of view adequately into consideration before we design a program. I'll give you an example, and Suranjin, stop me because I can go on. I'll give you an example. I believe that there was a survey for quality of care in one of the countries in Africa. Now, there was this labor room which had around 20 beds. And the entire labor room, which used to see something like maybe 20 or 30 births, had 2 shifts. And in each shift, there was 1 doctor and 1 nurse looking after 20 to 30 births a day. There were curtains initially in the labor room. And what used to happen was that women were actually giving birth because the curtains were closed and there was nobody to go and check on each woman. It's not possible when you have 10 women in labor for 2 people to manage those births. Women were actually giving birth, and the providers were realizing after she gave birth, or were realizing it when she was crowning or something. So what the providers decided was that let's remove the curtains, okay, so that we can see what is happening, which seemed to be a rational decision. But when the women were asked about privacy, they obviously said that no, we don't have privacy, and therefore quality of care was not optimum because there was no privacy. So they said, all right, this facility is very poor in terms of quality of care, but it was never contextualized to why the curtains were removed and why there was no privacy. So again, this is just an example of how we need to look at quality through a much finer or a much more nuanced lens. How we need to incentivize providers and even the entire healthcare ecosystem to provide quality of care. And finally, I'll just talk about feedback a little, Aparajita, because this is something which I have been thinking about for a long time. In fact, in between in Manyata, we had thought that we would encourage feedback and put it up on the Foxy website and so on and so forth. We didn't do it ultimately, but I'll tell you something about feedback coming from the private sector, and I think Practo was mentioned. What is to say that a tech company which hosts feedback will not charge you for pumping up the feedback, which is good for doctors who subscribe to that company, and pumping down the good feedback and pumping up the bad feedback for doctors who don't subscribe. Feedback sounds very simple, but it's actually very complex. Okay, so many things can happen with feedback which impact a private provider. Google reviews, for example. I have never looked at my own Google reviews, honestly, because I'm not really into that whole thing. But I think if you are looking at feedback, and you gave the example of, I think, Yelp or something, where, you know, restaurants, etc., get feedback, but restaurants respond. Doctors are not supposed to respond, or the healthcare system is not supposed to respond, saying that we would give away information which is medically sensitive, right? So I had developed a website. It's not live yet. It's called hcpsafe.com. And I developed a website where doctors could give feedback on patients. And this exists in the West already. Your share of copay, okay, when you are a patient in the West for NCDs and chronic diseases, your share of copay in certain health system depends on how compliant you are with the treatment. And that is actually a very, very massive form of feedback, because if you are not compliant, your share of copay increases and you have to spend out of pocket. So I developed a website, and I had taken this to 2 or 3 lawyers. I'd taken it to 2 ethicists, and we had tried to find a way in which, so this website was not to give patient feedback saying I didn't like this patient. It was to report abusive behavior. Because, and this happened during COVID, when all the incidents of, doctor bashing were at their highest. For example, I don't even like the term COVID warrior for doctors, because warriors by definition are expendable. Why would you want to call yourself a warrior and say that you are expendable? So anyway, just to give you something about feedback. 1, feedback can be manipulated. 2, if there is feedback, then there has to be an equal opportunity for doctors to respond. And 3, we have never considered taking feedback from doctors on patients. And I think it's high time that we start considering that.
No, thanks for raising, quite a number of issues here.
And Suranjan, the point that Jaideep mentioned, that one shoe doesn't fit all, not only across the countries, but within our own countries also we've had that rich experience. The zones which are within the country, even Foxy-led zones, the entire exercise has to be tweaked a little differently in different zones. So it has to be a novel recipe for that region, and what works there may not necessarily work elsewhere.
Exactly. Dr. Tang touched on many things. One is the fact that he's actively thinking of seeing how best, quality of care can be seeded in multiple countries across Asia and Oceania. He also talked about that as quality improves, we're suddenly seeing there's so many facets of quality that need to be touched upon, and each of them, require multiple things. And he also talked about financing, which we realize as we go, is equally important. And as we talking about an ecosystem approach for quality, we see that that's very important. And this whole thing on dialogue, whether the dialogue is productive, the dialogue is constructive, or is it just for thing? And we've seen this across multiple, areas. Like today, maybe our Olas will just never allow any interactions. They just have a drop-down menu and, just says, okay, you do A, B, C, D. But how do we create constructive conversations that can move forward is something I guess we still have to understand, crack, and move forward on. I have one more round of questions to the panel, but I was thinking I'll open this up to the audience in between, just to get a whole interaction. And I know there's been a lot of, thought-provoking statements that have come out. So probably we can take 2-3 questions if they are, and then if there's time, I'll move on to the second round of questions I have. So let's do one thing. If somebody's got a mic, we have Avinash there who's got one question. Anybody else? You got a question there. Second, third, yes, good here. So three questions. If somebody can get a mic, or Avinash, if you can just quickly come here till the mic starts, and we can begin. Yeah, Avinash, come here.
Hi, I am Mohammad Anzala, and I am a program associate for Seeking Modern Applications for Real Transformation. Since I get to work with the community very closely, and I get to visit health facilities, there often happens that community raise the issue that we don't trust the government system because we don't believe that quality is up to the mark. So with the burden of the population burden that we have on the health system, what I want to understand is public-private partnership is very crucial. So there is this question of just a second. To enhance quality of care in public health facilities, what driving forces can be leveraged to attract well-informed and privileged individuals to utilize these facilities? And how can the potential burden associated with this shift can be effectively mitigated?
Thank you. I think we'll take all 3 questions and then we will open it out. Would you want to go next?
Hi, I'm Ankur. So, the question I have is particularly the discussion around feedback, intrigued me. So, how does feedback work in systems where there is asymmetry of information? A restaurant, a person who eats the food is probably some expert on eating, right? At least, on flavors. But there is gross asymmetry of information in particularly indoor service delivery, in childbirth, what a client knows and what happens at the back end. So we need feedback, but what of this feedback is going to be meaningful to improve something? So any thoughts on that? how could we use it considering they know very little or they know very different from what the provider knows?
Okay, thanks. Avinash?
Hello, I'm Avinash from Japaigo. So, we have seen that it's the science which almost always dies first before the death of a newborn or a mother. And it's sometimes very sad to see the death of science where actually it is born and nurtured, and that is medical colleges. And medical colleges, in be it private medical college or government medical college, the quality of practices is almost always, at par, means it's not very good, to be very frank. So what exactly should be done to improve the quality of services in medical college, considering they are almost always outside the purview of national programs, their review mechanisms and all those things?
Okay, we have Dr. Sunita here, and then we will get.
I just have a comment to supplement what Jaydeep said regarding the quality parameters. We barely consider what is it that the providers ask for, what is it that is their need, as we call, to make them efficient. So provider efficiency, do we have a list? There is a list, of course, but do we really provide them? Do we really take care of it? How, in what conditions do they work? What are their skills? Have their skills been updated? So that's also an important part of the holistic quality of care mechanism under the health system.
Sure, thanks. I'll ask Dr. Kandayat and Jalani sir to see if you can start answering first on the PPP and also maybe on generally on quality of care. And then I think Aprajita would like to come in, and anybody else from the, sure. You want to go ahead? No, I think left on that one.
Yeah. Let me just clarify that I'm no more with the government, so I really am not in a position to speak on behalf of the government. Now, in terms of, so the first question was, how do you create well-paying people wanting to go to the public health facilities? Am I correct to understand that? Yeah. So basically, I mean, anyone who can exercise choice will like to go to a place where he or she can get the services, the best possible service at the best possible price. Okay, you look at the price, you look at the service, and then you take a call. Now, like Tata Memorial Hospital, they very good at providing good quality cancer treatment. And a lot of people would want to go to Tata Memorial Hospital. And they have created a mechanism for, so the same doctors, everything else is same, and they're very competent doctors, and but then they have provided certain kind of facilities which the well-paying people would want to see, and they are able to charge them at a price through which they are able to cross-subsidize. They are able to cross-subsidize the patients with not paying capacity, and also able to incentivize the providers. Okay, so that could be a model that one could possibly explore. Even for AIIMS and all, I recall previously there used to be a lot of rush that please get me a room in AIIMS. Okay, so there are private rooms. They cost a bit, but people still would want to have themselves treated there. So yes, we need to, but I mean, it's still few and far between. We need to make sure that firstly the clinical care, secondly in terms of the experience, and then broadly even the general, ambience and infrastructure. It's all in terms of hierarchy. So you want to go to the best doctor first, because you want to make sure that the health outcome, even if he's not so polite, you want to make sure that the health outcome is great. next you would want is that, okay, I mean, the conduct and experience is good, and then you can also see that, okay, if you are in a good room and other ambience is good. So, I mean, I'm just saying these are possible examples, but it's important when you look at Nordic countries or some of the other countries, what you feel is that there's not this kind of hierarchy. So there is something for poor people, go to the Sarkari ones, and then there is something with paying capacity, and then they can go to Max or Apollos and all that. And countries with health systems where they're really genuinely equitable, where everyone has access to similar kind of facilities, the quality overall would improve, okay. So one of the things that is always said is that if the public health facilities were indeed used by people who could hold people to account, then the quality would improve. If the bureaucrats' children were to go to government schools, probably this quality of schooling, if they were to go to the same hospitals, the quality of care in the hospitals would improve. That's one. There was another thing around your experience. I mean, I'm really not expert in terms of, so there are things that, clinical aspects of it where there's an information asymmetry, okay. The doctor shouldn't have given oxytocin and they gave oxytocin and on. I mean, those things are okay. In terms of your experience, okay, how was your experience in the hospital? I mean, the doctor hardly spent 2 minutes with me. They didn't even explain what the procedure was, what are the implications. There was no, I mean, you're not even engaging with the patient. So obviously patient is certainly, just as you can have a taste, I can certainly get a good sense of my experience with the provider. I'm not talking about the information asymmetry in terms of the treatment, this thing, but there are aspects on which you can certainly get a sense from the patient. And you would like to see that at least, I mean, I'm just giving you some example, like we would try to collect feedback from, we had 500-seater call center, and we would call the pregnant women for their ANC and ask them, how's their experience about ANC? And they would say, they're happy with the ANC. And then you start drilling deep, and then you realize it's a very shoddy quality of ANC, the blood pressure has not been taken, blood sugar has not been measured, hemoglobin has not been, I mean, so you, the amount of time that you would expect, etc., etc. So, I mean, of course, one would like to create mechanisms to create more health literacy, but importantly is we should be able to get a sense from feedback, and importantly, as Aparajita pointed out, how do we act on that feedback? So, particularly in the public sector, I can give you my own one personal example of mine. I was a district magistrate, and then we had started this. That was long, I mean, quite 30 years back, kind of a thing. And then I said, okay, we will have every patient before being discharged, they will have to provide a feedback, and we'll have, it will go in a box. There'll be a NGO who would collect all the feedback and then prepare a department-wise summary of what the feedback was. And then, so they started coming in and they provided some feedback. Many of them, I mean, satisfactory. Some improvements came in as a result, that the toilets were not good enough, lighting, servicing, etc. And then I said, now, based on the feedback, we are going to make this a part of your annual appraisal, okay? So, I mean, patients is what we are for, and what they think of our services is what matters the most to us. So, based on their rating of the services in different departments, if you're keeping me happy, I write you an excellent ACR, rather than that, let them decide how you should be rated. And that had some important, some feedback. And when we introduced Mera Aspatal, I did try to communicate to the directors of different institutions that please try to factor in the feedback from Mera Aspatal to go into the appraisals of the institution. I mean, that's one way to really give a voice, genuine voice, to the people who should be. And lastly, I don't know, I mean, sorry, I forgot the, was it?
About medical colleges.
Medical colleges quality. Yeah, I'm really happy that you raised this issue, because the source, I mean, should really, I mean, the pre-service thing where they must really imbibe the right values, and really, I mean, that's when you see the role models, and if you see a very committed and passionate professor providing very high quality clinical care, compassionate care, interacting with the patient in a very certain way, I'm sure this would rub in with this thing. But government medical colleges do participate in national programs. I mean, that much I can tell you. But I agree with you that mostly our own general assessment and a lot of anecdotal experience points out that we are really not, I mean, our institutions of training really are not great role models, and that's just rather unfortunate. But it's all within in-house, not a critique, but it's more constructive criticism. Yeah, thank you.
Yeah, we've just got 2-3 minutes for responses. After that, we'll have to give at least 3 minutes to Dr. Janani to.
Okay, two quick responses. One is again the question of what do providers want. When we entered into Manyata, we didn't ask the providers what they want, but at the end of the program and even till today, they have come up with very, very positive feedback that they are now relieved that the staff is doing what they're supposed to do, and then even before they reach the center from their home, everything is kept ready and the immediate early detection and emergency action is taken. So in that sense, the provider feedback that what we've got out of our program is excellent. And then public-private partnership, I think there's a lot of scope. You can't fix everything during pregnancy. There's a lot of role for preventive care and wellness, and if the public-private partnership happens with the private providers on many government schemes that are already existing for integrated health and wellness, we can definitely step into the contraception, the anemia care, and the vaccinations, for example. So they're all kind of properly prepared before they enter into any facility, public or private. So that baseline work, if we are given an opportunity, I think we would be quite happy to, because it's structured. It is like into bracket no risk, because this is all that you're expected to do and you do it right. Many things cannot be very fluctuant and can go wrong there. So I think that's a huge scope for a life course approach on prevention.
So I just want to respond to the feedback question again and information asymmetry. And I think it's vital to realize that most patient feedback comes from how they feel, not how they've been treated. By treated, I mean in medical terms, right? It's not about the efficacy of the medical treatment that has been delivered to them, but it's rather about how they have felt with interactions, or how they have been, sort of treated in a more, in the softer term of the word. And that's why I think this feedback cannot be equated to the quality of care in terms of medical treatment. Most certainly quality of care includes the softer aspects of care. There's absolutely no denying that. But at the same time, the feedback has to be looked at with that lens. And that's the information asymmetry that you were talking about. I've had patients who have told me that, I shouldn't have had an IV in me, right? And this is a very common thing, right? If anyone goes into labor now, that person gets an IV, okay? Why does that person get an IV? That person gets an IV because if an emergency happens in obstetrics, and emergencies, believe it or not, happen in obstetrics, okay? Everything cannot be predicted. When that emergency happens, there's typically not enough people to support in terms of putting in an IV, and it's simple logic that if you put in an IV in a hemodynamically stable patient, it's much easier to access the IV than to put it in a patient who's collapsed. You won't be able to access only the IV, and there's not enough resource to do a cut down or put in a jugular line or something of that sort. Now, this is something which everyone says should not be done. Right? When patients come in labor, there should not be an IV patients. So that's fine. I sort of agree with that. But I would still, in my practice, I put a vein floor. I don't put them on the drip. So they are free to move around, but I would certainly put in a vein floor because I don't want to be caught on the wrong foot. We don't take into account the medico-legal consequences of doing something and not doing something when we talk policy. Okay? If you have looked at the medico-legal data, obstetricians are the most sued specialty across countries, all right? And you have to take this into account when you talk about quality, when you talk about infrastructure. Medical colleges, for example, I think they do a fantastic job. given the constraints that they work in. When I was a resident in our antenatal OPD, we used to have around 220 patients whom we had to see in around 2.5 to 3 hours. And we had to finish in 3 hours, because if we didn't finish in 3 hours, then the staff that would be left behind would have to be paid overtime. And the administrator in our hospital did not want to pay overtime. So I had to see so many patients in that time. It's not as if I didn't want to spend time with patients. It's not as if I didn't want to chat with them and understand their life. But there was simply no time and no space to do it. So I think when you say that quality of care is not good here, the feedback is not good there, it's not as simple a matter as we make it out to be.
Yeah.
Okay, we need to look at it in a much, much more deeper way.
Thank you. So, Dr. Tang, absolutely agree with you that consumer to business feedback can be gamed, whether it is Practo or TripAdvisor. Also, that Airbnb, interestingly, has what you're talking about. So they also mark the consumer. So if you have gone and broken bottles in Airbnbs, nobody else is going to give you the house. So agree on that. But I also wanted to talk about, say, how is Suman or Mera Aspatal different? Is that once a complaint or a feedback comes in, there is a process. And I think that is what is going to solve the issue of what Dr. Tang was talking about. So it is not like we have given feedback and whatever feedback it is, nothing is happening or people take it at face value. But I think the fact that Suman has a mechanism where you lodge a complaint, it goes to certain places, they try to solve it at that level. If it doesn't get solved, it goes to somewhere else. So I think there's a process which is really, really important. Your question about information asymmetry, I think both Dr. Jalani and Dr. Tang has spoken about it. But I do want to talk about the fact that we have to invest in educating women also, or educating patients. We are not telling them to understand every injection, every surgery, but basic things, about their entitlements, about their rights, pain management, when do you really need C-section, which is a life-saving thing, why do you need birth companions? So that's one part of it. I think we cannot get away by not investing in patients or women. And the last thing is, yes, we cannot expect patients to give feedback on procedures, but definitely whether you were treated with respect or not. How long did you have to wait for, right? Did you feel that there was confidentiality there? Or did you get discriminated because of a certain race or caste or age or literacy? I think there are many, many parameters on which even women who are not literate can provide feedback. Thank you.
Thanks. And we've got just one more thing. Dr. Ruth is online. Dr. Ruth, we've just finished one round. Any quick responses you have? We are at times say two take-home messages that you have taken from this discussion.
Has been a very, very interesting discussion. I think for me, I've just realized quality has to be a very continuous process and very intentional. And we have to think of all the stakeholders, it's the patients, the providers, the government. We have to get feedback from everyone. And I just wanted to comment that, like for us as health workers, when we are providing the care, you find that our challenges in terms of being able to deliver a service that a patient will like is because maybe we don't have our skills updated. We need to have quality medications. We need to have quality equipment so that we may be able to have eventually good quality outcomes. So I wanted to just comment about obstetrics and litigation. Interestingly enough, you find that most cases that are taken to the medical board, like here in Kenya, is because a patient felt like they were never explained to anything. So the communication between the providers and the patients has to be really, really improved, because then that way patients feel like they're part of the process and then don't feel like they're having a very bad experience. So I think we need to institutionalize the provision of quality care, and it has to start from the national level and even be able to trickle down back to, down up to the level of the facility. So those would be my take-home messages. Thank you so much for inviting me to participate in this panel.
Thank you, Dr. Ruth. We have now Mr. Jalani, so I'd like you to give your closing remarks, and after this.
Thanks. I got to go to another session immediately after this. So I think I really don't need to sum it up. But, I mean, everyone has presented very eloquently. So essentially, some of the things are, I mean, we need to build culture of quality, which should be front and center, intentional, and not an afterthought. Two, quality standards, context is important. Thirdly, I mean, patient experience is critical to quality. I think, and lastly, need for more public, private, and learning and collaboration is critical to enhance quality. I think these are the key messages one could capture. Thank you so much.
Thank you so much, sir. Thank you to all our panelists for coming in here and for sharing your insights, and we really look forward to moving forward, uniting for quality. Thanks.
have Dr. Indrabhushan. So just good afternoon, everyone. I know it's, may I request all the panelists to please take their seats on the stage? So we have a really illustrious panel today, and they bring a range of experience here. And of course, we've had 3 days of this World Health Summit, where many of the issues that have been discussed, and I've heard some keywords that have come up regardless of the type of sessions, really, whether they were technical sessions or they were sessions talking about diplomacy. Some things have come up repeatedly, and hopefully we can find some place to put them in, if you will, and also make it more participatory and have those of you who are clearly interested in the topic and in this room, thank you for joining. If we can have an opportunity for you to engage in a deeper discussion on some of the things that have already come up. Things like partnerships, integration, governance, capacities, resources, sustainability. Hopefully all of that in this session on strengthening regional institutions and collaborations for advancing health in Asia. Once again, thank you all for coming here to this session, which is jointly organized by the Center for Social and Economic Progress here in Delhi with the Asian Development Bank. And we're really, at this Regional World Health Summit, focusing on our region here, the South Asia and Southeast Asian region. We've heard quite a bit at this conference and actually outside as well about how global institutions are in crisis, how our financing for health has been, we've faced some difficult situations. There are the weakening of global cooperation mechanisms and multilateral systems. And in this context, there is, as people here in this region, a need to deliberate on how countries in our region can respond to these global and regional pressures, and also to examine some policy roadmaps, to develop some processes of cooperation to help sustain and strengthen some of these health institutions, both at the global level, regional level, and really also at the national level. And it's really important because, of course, South Asia and Southeast Asia is home to 1/4 of the world's population. We're also countries that are facing a range of common challenges. We know about the economic and the geopolitical ones. There are also large demographic shifts. there's a large and growing population of the elderly, rising burden of non-communicable diseases, and of course this climate change that is exacerbating many of these health challenges. And all of this in a context of countries which have variable state capacity, a very diverse region, and different levels of maturity of health systems as well as institutions. So we're here in this context, the Center for Social and Economic Progress posited that there is a need for regional integration and collaboration that perhaps offers one pathway for managing this era of polycrisis, as some have said, while ensuring improved health and equitable outcomes for people in our region. And this is the hypothesis that led to the development of the Asian Collective for Health Systems, or TACS, as we call it. And we gathered here with this very esteemed panel, as well as with all of the audience here, to gain some insights on what this can look like in practice. So I invite all of you to raise questions and bring your thoughts and opinions and bring it to a panel here. And with that, I'll begin by inviting our Right Honorable Helen Clark, who's here, who's of course the former Prime Minister of New Zealand and a well-known champion of global health and sustainable development, and go to her for some initial reflections based on her global experience on what it might mean for the Global South more generally, but especially for the countries in this region. Over to you.
Greetings, everyone. I feel with almost as many panelists as audience, so maybe we should be in a big round circle. But I've really enjoyed this World Health Summit because, coming from New Zealand, you're seeing the international news mediated through BBC and CNN and the rest of it, and you'd almost get the impression that the entire world's talking about Trump. And you come here, and people are getting on with it. India's a country on the move. There's many countries on the move in Asia, and I think it's been really exciting to come and just, feel the ambience and feel the direction and purpose that's in Asia around the global health issues. And it's been fantastic to see so many young people from the universities here as well. So, it's obvious, but I'll say it, that the multilateral system is in crisis with what's happening with funding, whether you're talking the UN in New York, WHO in Geneva, will Gavi be replenished? What about the Global Fund? What's happening at UNAIDS? I mean, UNFPA's lost a ton of money. I mean, it's a tough time. And I think at the global health level, that's going to require ideally more coordination about who does what and coming back to core functions. But then who else steps up? And then you look at the regions. What regional capacity is there to step up if the multilateral system cannot do what it once did? Now, one of the issues is that our regions are all configured a bit differently. So Africa, of course, is unified through the African Union, and it can spin off institutions like the relatively new African CDC, which was very timely for the pandemic. I look across at Latin America and the Caribbean, which has PAHO, which also has North America, but that's a long-standing institution predating WHO and is a good place for regional coordination for health. But the other parts of the world don't slot so neatly into that. You have different kinds of regional organizations that haven't necessarily built up a health competency. Should ASEAN, for example, be stepping into a gap now? Should ASEAN be taking on a greater role? What about the South Asian, regional cooperation organization? Or should there be a more deliberate attempt to make the WHO regions really work as more autonomous coordinators of regions in stepping up? So I think these are all live questions. I don't think it's an issue of either global or regional. It's just a recognition that the global level is not going to be funded to do as much as it did. So then how regions can help compensate for that is critical. I think for the global south generally, I mean, this is a time of opportunity really to make a mark on setting agendas and really pushing for changes in global governance. I think we've seen the really incredible benefit of having 3 major global south countries leading the G20 in 3 consecutive years. We had the India chairmanship in 2023, we had Brazil's chairmanship last year, and now South Africa. Brazil was very forward-leaning on the health agenda. South Africa's very forward-leaning. So, you know, this is probably taking the G20 into territory that it might not necessarily have thought it was going into 5 years ago. Times have changed, and times for strategizing on what are the best configurations if our multilateral system can't do what it used to do. In terms of peace and security issues, I think for quite some time now, the UN in New York has looked to regions to step up. You know, there's a coup in West Africa. They look, what will ECOWAS do? You know, there's a coup in Myanmar. They look to ASEAN and its 5-point consensus. So in many ways, because the security part of the UN has not functioned very well for quite some time, the regions have come into their own as primary actors. But we may be at that point now in global health as well. So I'm pleased that your centre is looking at how this might play out, how it might be organised. And I think we're all ears as to what the possibilities are. Thank you.
Thank you so much for the encouragement. We're going to start out exactly as you say, with just understanding who the players are, what their capacity are, and I'll come back to you for particularly from perspective of smaller nations. I know we're in India, but really we're in a region where there are many small countries. But before that, I would like to go to Ms. Ilona Kickbush, who's the founder and chair for the Global Health Center at the Graduate Institute of International and Development Studies in Geneva. And of course, she's a well-known actor and very seasoned actor, I should say, and a leader on global health diplomacy, who's worked on a variety of different issues, and particularly on the health in all policies and the intersectoral action, which is again, in the context of climate and resilience, become extremely salient. And I wanted to ask you, from your experience, firstly, if you thought that regional voices were indeed well represented in global institutions, and 2, from the perspective of Asian countries, is there a way for nations to collectively leverage their growing influence? We see that there are countries with growing influence, but can we collectively leverage that to reshape global governance in a way that actually amplifies the Asian voice, so to speak? Over to you.
Well, thank you very much. I don't know how to interpret well seasoned. I hope it means a good wine. But yes, I've been in this field for quite a long time. I think what is happening now, some analysts saw it coming. Some analysts didn't want to see it coming. And I think it's very obvious, as already Helen Clark has said, that we are experiencing the end of the post-World War order. And we're clearly seeing the end of the hegemony of what we used to call the West. The West doesn't exist anymore. It has been divided, and not only between Europe and the United States. It's a much more complex issue, also Eastern and Western Europe, many issues there. And of course, what we now call the Global South is definitely also not, just one group that all wants the same, with the exception perhaps is that they all want more influence and power. And that is legitimate, given the hegemony that has been there before. That has obviously also expressed itself in health. That's expressed itself in the health institutions. That's expressed itself through the model of development aid, through the donor model, the charity model, whatever you want to call it. And it's been highly interesting that the reduction of funds, or the total cut of funds from the United States, has led to an outpouring of critical commentary in the Old West. But interestingly enough, not in the rest of the world, and also hardly from Africa. Actually, some African presidents from Rwanda, from Ghana, said, well, you know, this is also a wake-up call to us to actually invest in our own population and to get our health systems in order. So I think the world is still trying to find how, well, it's in an in-between world, we should say, moving out of the old, not yet moving into the new. If we speak of regions, it's very difficult to actually say, what do we actually mean? You know, do we mean a continent, as is the case of Africa? Do we need a group of countries? Which group of countries belong to Asia? Which part of Asia? Obviously, geopolitically, there's also sometimes similarity of interest, like between India and China. Sometimes there's a great difference of interest, and sometimes there's the threat of war, as we are experiencing now. So obviously, regions in that sense don't have a seat in the United Nations. They can, of course, group and speak with one voice, and that doesn't always work. Now, there are formal regions, in quotes, like the European Union, but that doesn't have a voice. It can speak, but it can't vote. And it actually shows another thing, that if you are formalized, you actually have an additional problem, because even before negotiations start on some issue, and we had that with the pandemic agreement, is that you have to find a formal agreement and consensus within your formal regional group. And then to some extent, you're actually at a disadvantage while you're negotiating, because you have to stick to that consensus. So I think we also have to be careful what we actually mean when we talk about regions. Do we mean negotiating as a bloc? Do we mean, you know, certain forms of regional solidarity? Or do we mean some kind of a formal voice? It's absolutely clear that, you know, if the overall global system is weakened, that decentralization is favored. And again, Helen has already alluded to it. What seems to be the case is that the kind of agenda setting that is actually now needed to replace the old hegemony is interestingly happening in a body that was created under the old hegemony, and that is the G20. And actually, I would like to add, Helen, that, you know, before India, we had Indonesia, a country that is often undervalued when we speak about this. Before that, we had Saudi Arabia. So we have the Arab group that is also a very rich region that is aiming for influence. And you can see that on the political stage when Oman comes in to actually negotiate peace for an area where basically they don't have a direct interest. So you can also see that these power politics are changing. What's definitely changing is the whole financing model of the system, because what we've also seen with the WHO investment round, but also with issues like the Global Fund, like Gavi, etc., is that some of the countries of the Global South and also Asian countries, take particularly, again, China and India, have not subscribed to the donor model, if I can call it that. actually, when I was doing a study for the Global Fund with my colleagues, and we were talking with the Chinese colleagues why they were not, in quotes, investing more in the Global Fund, this was several years ago, they told us, and rightly so as we see, this is an outdated financing model. We don't want to contribute to it. We will take a different kind of approach. And that's, of course, where it becomes very interesting which approaches do the richer Asian countries, in this case, take in relation of a sort of regional collective solidarity of other countries in their, in quotes, region. We had it partly in COVID, the Indian approach to its neighboring countries. We, of course, have a long-standing approach from China, particularly in Africa, but also some of the neighboring countries. So we see quite different mechanisms. And we also see, of course, because the call of these countries, and if you look at the recommendations from the last 10 years or so out of the Global South and recently out of the G20, which are constantly calling for a renewal of multilateralism that gives the Global South a stronger voice. For example, in the UN Security Council, the Brazilian colleagues say to me there isn't a single body in the world that has less legitimacy than the UN Security Council, and they're probably right. This means that they have started to build alternative structures. And of course, you know, the development banks, also the infrastructure bank in Beijing, many of these other models are going to take over more and more with a different principle. Again, not the old donor model, probably more partnership-oriented. But I think, again, we mustn't underestimate, but I leave that to the Asian colleagues on the panel, that there is not one Global South, that also within regions there's significant competition. Within regions there are significant wars. And just, you know, look at Africa. There are tremendous humanitarian needs. And the question really is what kind of collective identity and what kind of collective solidarity can these regions develop, and do they even want to develop it? Because, you know, that is, of course, their own prerogative. And again, there is significant political competition, there is significant economic competition, and there are different development models in general in the various really defining countries. And there again, you know, where the difference between China and India becomes very relevant, where now, where everybody thought, you know, China is ahead, India has a generational dividend that nobody had put in their calculations when this whole thing started. So I guess my plea is to see this as a very, very dynamic field, to analyze it very, very carefully, to not address it with, and particularly if one comes from my part of the world, not to address it with too many of the old thinking and the old models. And I just, in ending, like to underline what Helen said. That's why, you know, I spent the last year visiting about 6, 7 different Asian countries. And just as somebody coming from Europe, and I won't describe the mood in Europe to you in any detail, and it is a very difficult situation with the Ukraine war and all these things, is that the moving forward, the optimism, the new models, the young people that one meets in this part of the world and the very rapid economic development is something that just shows that the old world order is over. And I think it's now time for us not to step back in terms of our responsibilities, if I mean the West, but to work in different ways, to listen very carefully, and to be good partners. Thank you.
Thank you so much. So many interesting points that you brought up, starting from what you said about the optimism and energy actually being here. And interestingly, this demand from many countries in the global south for a greater voice in multilateral institutions. So it seems like the global south is still sold on collective solidarity, working together, cooperation, much more so than the old world, it seems like. At least parts of the old world, for sure. The second interesting thing that some advice actually that I took from you is, the advantages of the dynamism and in some ways the disadvantage of the formalization, particularly in formal negotiating positions and agencies. And that's something also, to think about, I think. And finally, the agenda setting role, particularly in health, in existing platforms which maybe didn't think as much about health, like the G20, which came up both in Helen's intervention as well as in yours. And I'll come back to you on, again, your advice on what you think should be, how should these negotiating positions be evolved? Should it be based on issues and interests around those issues? Individual negotiating tactics, so to speak, as in issue-based positions? Or should it be based on collective solidarity, which is much more long-standing and perhaps institutionalized in some way? But before I ask you that, maybe I'll switch gears a little bit from the global to the local, really, to the Asian countries. And we have some very experienced panelists. And I'm going to invite Dr. Srinath Reddy from our very own India, who is, of course, a distinguished professor and the founding president of the Public Health Foundation of India. And Dr. Reddy, you have a lot of experience, both from the days of tobacco control on issue-based negotiation, and now, of course, you have deep experience of working on issues such as antimicrobial resistance and other climate-sensitive issues. What do you think, based on some of these examples, particularly the successful examples of Asian countries collaborating, and again, what kinds of institutional and governance arrangements do you think are necessary, both at the regional level, but also maybe within countries? Over to you.
Thank you. Since you began with tobacco control, let me take an example from there. Of course, it was a very contested terrain with different countries having different interests. Tobacco producing, tobacco marketing countries having different interests, and other countries which are the victims of the growing tobacco epidemic, pandemic, having other interests, definitely. And there in the initial deliberations of the International Negotiating Body, as a member of the Indian delegation, I could see that while there were many pious public protestations of commitment to public health, it was the commercial interests that began to dominate at many points in time. But there, the good thing that happened was that there were regional meetings of the different WHO CRO region countries. And before each round of the International Negotiating Body, these regional committees would meet, regional groups would meet, and then evolve a common position, which would then be articulated in the International Negotiating Body. And then at the time of the International Negotiating Body, the different regional representatives would talk to the representatives of the other regions and then try and evolve a consensus position. And that added a great deal of strength to the position of Asia, Africa, Latin America, vis-a-vis some of the contestations that came from, for example, USA, Japan, and others, who are very much committed to the tobacco industry. Ultimately, we managed to get a very strong FCTC as a result of this combined negotiating power of the countries, which could put their case very strongly. So that doesn't always happen. Tom Friedman basically described the world as, he said the world is flat now. Not entirely true. Yes, the world is flat, but nothing prevents a flat world from being tilted in favor of somebody. It can become an inclined plane, right? So that's exactly what happened, and the evangelical enthusiasm for globalization faded when the low and middle income countries started also exerting their power of their large markets, productive resources, and started competing. And suddenly now you see the enthusiasm for tariffs. So that's where all the exponents of globalization have suddenly now started in a retreat to narrow nationalism. But it doesn't have to be so. World solidarity has to prevail. Just a few days ago, we celebrated the 70th anniversary of the Bandung Conference, which gave birth to the non-aligned movement, where Africa, Latin America, and Asia came together in the post-colonization period and said, well, now we have to have our place in the world. Our voice has to be heard. And that has to now come forth, not as banding up against the West, certainly not banding up against the countries of Europe or North America, but essentially evolving a strong negotiating position and then inviting for a much more equitable world order. And that's where the new world order has to be created. And in terms of health, certainly it matters. And as far as Asia and Africa are concerned, there are certain advantages that we have. We have not only large populations, but very young populations, very productive populations. And even in the area of health, as the countries of Europe and North America are going to be seeing older populations with very little scope for replacement of their reducing workforce, including the health workforce, it is Asia and Africa which will have to produce the workforce for the world. So we will have to use that in a transactional world as our leverage as well, and have collaborations for training our health workforce, not only for use in Asia and Africa, India in particular will have that advantage, but also for the rest of the world. And thereby we will be able to say, for global solidarity, we will ensure that the whole world has a global health workforce which is ready to serve the needs of the world for a variety of disorders. So there are ways in which we can actually take up solid positions of unifying the Asian and African and Latin American voices, while at the same time not alienating ourselves from the rest of the world, and certainly showing up the solidarity as the fundamental platform on which the civilization has to proceed. And therefore, my message would be, whether in health or whether in antimicrobial resistance, whether in climate change, what we need to do is to think globally, collaborate regionally, and act nationally.
That's certainly a very powerful slogan, a mantra really, as we develop the Asian Collective. And I'm going to, one interesting thing that you just mentioned about how, in the case of tobacco control, the developing countries were actually able to leverage their market power. And maybe now, in this context, we still have some strengths, like the young workforce, the dynamism.
Minds and markets, both.
Yes. Yes. And maybe there are still some of those tools that we just need to identify and strengthen. But I did wonder if you thought countries are actually ready. Do we have the workforce, the capacity really in our workforce institutions to respond?
Well, we may not right now have it, but we need to invest in it. And that investment, again, has to be co-investment. We have seen examples how Norway, for example, invested in collaborative workforce development in Central European countries. So there is no reason why high-income countries who are going to be seeing shrinking workforce, particularly in the health area, invest collaboratively, co-invest in countries of Asia and Africa, and have a well-trained workforce produced will serve the countries within Africa and Asia, but also serve the rest of the world. And that co-investment will foster the spirit of solidarity, because then we'll realize that all of us are working for each other. So,
Point taken. And I hope that both the high-income countries will see the value in this kind of co-investment, and that the smaller nations, particularly in our region, as well as some of the, in solidarity with some of the larger nations like the India and China of the region, will be able to make this point clear and be collaborative with the high-income countries who have the resources. On the investment fronts, I'm going to come to the colleagues from the panelists in the bank. But before that, I did want to invite Dr. Indu Bhushan, who's of course the first CEO of Ayushman Bharat, one of the flagship government-financed health insurance products anywhere in the world, the largest from India, and now advisor to the Pehle Foundation. And Dr. Bhushan, I wanted to ask you what you firstly think or have identified through your work are the common health challenges for countries in this region. And also maybe reflect a little bit about, is there room or value for the regional knowledge sharing platforms, such as the one that we are developing in the form of the Asian Collective? Can it really help accelerate progress towards UHC, towards improved health system resilience, particularly for the Asian region? Dr. Bhushan.
Thank you, Neeti, and thank you for inviting me to this panel, this very eminent panel. Coming to the question about what are the common health challenges among all the countries of similar socioeconomic status as India, I see large amount of commonalities in terms of health status, health systems, and health financing. If you look at all countries which are similar to India in Asia and Africa, you would find that traditionally countries have gotten over communicable diseases, and then they now focus on non-communicable diseases. But we have the dual burden. We've not gotten over or controlled communicable diseases, but we are having an epidemic of non-communicable diseases. We are also graying before we are becoming richer. So in that sense, while it has economic implications, but also it has health implications, the kind of health system we should have for looking after our elderly. We also see large inequities, both economic inequities, but also inequities in terms of health. That is part of most countries. And in terms of health systems, we see that the capacities in health system is uniformly weak, give or take a few countries. I would say that in most countries, in terms of surveillance system, in terms of capacity to implement large and complex schemes, we need a lot more help. We also see that systems are fragmented. In most cases, primary healthcare, secondary healthcare, tertiary healthcare, public and private, they work in silos. There is a lot less integration there. And regulation of the private sector is also weak in most countries. And in terms of financing, we find that in most countries we are spending too little in health, because there are so many other demands in developing countries, and health is not seen as a priority. And in India, of course, particularly, our public investment in health is one of the lowest in the world. But more than the money, we also see that where the money is going is also very different, because our investment in primary healthcare is too little as compared to secondary and tertiary. So there is a mismatch. But also we see that donors, and particularly because I'm sharing a dais with the development partner, and also I was actually part of I was guilty as charged earlier, part of ADB. So we find that donors have their own specific likes and dislikes, and in terms of investment that has come from development assistance on health, it has distorted where the money should be going. In terms of large amount of money has gone into areas which are favorites of donors, for example, HIV/AIDS. And I'm not trying to minimize the impact of HIV/AIDS, but if you look at the burden of disease, HIV/AIDS contributes to a small proportion as compared to the proportion of money which is going there. And donors have provided money also in silos, in vertical programs, which has distorted systems, which has distorted incentive structures. They've taken away resources. So that has been a problem all across developing countries that we see. Now, the second part of the question, that whether regional approaches can work. Of course they can work, and they should work. First of all, we need to share more. And while I shared a lot of problems that we see across, but we also have success stories. We have a success story of Thailand in providing universal health coverage. We have emerging success story in India of digital public goods, public infrastructure. And we have Sri Lanka and others where primary healthcare has worked well. And sharing those information, and through forum like this, as well as Asian Collective, I think would be important. But also not only sharing lessons, but also sharing information in terms of emerging diseases, so that all countries are ready to respond to. So getting the systems more transparent in terms of surveillance and providing information. As we were talking about compact between countries, I think one major aspect of compact between countries is to also be transparent about what's happening, what kind of diseases are emerging, so that everyone can respond to them quickly. But also, there are areas where probably collective action would be important, and economies of scale would always work. And earlier, Madam Clark was talking about small countries. If small countries try to develop their own systems, all of them, probably they will be not efficient, and doing them collectively, as they've done in South Pacific through SPC and others. And similarly, in South Asia, we could have a larger variety of CDC, which can provide support and strengthen capacities and build systems that could be done. So I'll stop here.
Thank you. What I'm hearing from you is that actually there is a lot of work to be done domestically before we even get to a common negotiating position. There's a lot of work that needs to be done in terms of identifying the priorities within countries and finding pathways of working at those nationally. But even there, for the domestic priorities, perhaps there is a role for regional cooperation. And again, going back to the co-investment and what Dr. Reddy was saying, actually echoing similar thoughts in terms of not just financing and co-investment, but actually there's room, it seems, for sharing lessons and also information, the data sharing part of it, which is clearly resonates with the researchers in the room, including myself, I'm sure. But I do want to go back to this financing question, because of course it's come up several times in just this conference, and then it's also top of mind for many of us who have impacted, and we have some esteemed colleagues here that I'm going to ask. Firstly, I'm going to go to Dr. Priya Basu. She's the executive head of the Pandemic Fund and has had a long working experience with the World Bank. And I just want to, pick up from what Ilona Kickbush just said about Global Fund being outdated in terms of the financing mechanism, and wondered what you thought would be, firstly, from the old system, have there been some key successes and challenges that you've identified potentially as lessons that maybe Asian countries have in their sort of leveraging of the existing institutions have been able to do either well or not so well? And two, how have you thought about financing for the challenges of today, moving away from the outdated systems? And if you had some reflections on that, over to you.
Thank you, Nidhi, and it's great to be here. And I would totally agree with what was said earlier about the energy and the enthusiasm here. I'm coming out of the spring meetings of the IMF and the World Bank in Washington, D.C. I took a flight late on Thursday, arrived here. Wow, the energy and the optimism and hope. It's great to see. So, I just want to say, picking up on some of the points that were made earlier. So first of all, I don't know how many of you know what the Pandemic Fund is. So we're at the World Bank. We are actually a child of the G20. We were conceived under the G20 Italian presidency. We were part of the Leaders' Declaration in October 2021, where in the midst of COVID, there was, a sudden realization that there is really no multilateral financing mechanism that's exclusively dedicated to investing in helping countries prepare and prevent infectious disease outbreaks that have pandemic potential. And then Indonesia took over. I was at that time actually the World Bank's representative for the G7 and the G20, and so got very involved in this whole kind of finance health task force, which was for the first time put together at the end of 2021, because before that, even the G20, worked in silos: finance track, health track, this track, that track. Actually, there wasn't much of a health track anyway, but finance and health didn't work together. So, anyway, we worked really hard, and at record speed, the Pandemic Fund was put together. It really is a testament to multilateralism, where regions put aside their differences, countries put aside their differences and said, look, this is a global public good that we have to invest in, and that we've got to break the cycle of panic and neglect. This time round, let's once and for all kind of, invest in getting countries to that right level of preparedness. And the costs of, or the financing needed to get all low and middle income countries to the right level of preparedness are a tiny fraction of the costs of not being prepared, right? Not being prepared in terms of the lives lost, in terms of trillions of dollars of GDP lost in, COVID, through the COVID pandemic, the reversals in hard-won gains in health, in social development, in economic development. So anyway, so the Pandemic Fund came together. We were established, formally launched under the Indonesian G20 presidency in November. We have a very inclusive governance. I have to share that, we have an equal number of voting seats for our contributor countries and all the 147 countries that are eligible to receive money. So there's 9 voting seats for our contributors and 9 voting seats for all the potential beneficiaries, and then 2 for civil society and 1 for philanthropies. We've learned this governance structure came out of sort of lessons learned from other funds. We also have actually a very interesting set of contributors. So, on top of the usual suspects, key contributors to the Pandemic Fund also include Indonesia, China, India, South Africa. So they've all provided resources, and some of them also benefit from the Pandemic Fund. Now, coming to your point about kind of the regional sort of work that we're doing, I mean, I would say that, and I'm very much, and I'm going to quote this Dr. Reddy again and again, think globally, collaborate regionally, act nationally. The Pandemic Fund, works, does investments at the country level. Of course, we have to build capacity at the country level in key areas like surveillance, laboratories, testing, health workforce. You've got to sort of generate, generate these improvements at local level, community level, at subnational and national level. Communities are at the heart of dealing with pandemic prevention, preparedness, and response. Pandemics begin and end in communities. Got to build that infrastructure at the community level, and then network it up to the regional level, right? So data sharing, data collection, and data sharing and intelligence gathering and sharing is absolutely critical, but it doesn't mean anything at the regional level if you don't have the data that's coming up from the local level. So we're supporting countries individually, very much country-led, country-driven, but at the same time, we're also doing a lot of work that promotes cross-country collaboration, whether it's on collaborative surveillance, whether it's on building laboratory networks that link across countries, whether it's about surge capacity, regional workforce that can be deployed in times of crisis. And then we're also working cross-regionally, because ultimately you've got to have that global intelligence sharing if you really want to be able to prevent the next outbreak from becoming a pandemic. And then, at the regional level, there are some gaps. There are only 2 regions actually in the world that have regional CDCs. That's Africa and Europe. None of the other regions. So we're also in our next round, which we're going to announce in June, we're actually encouraging regions that don't have regional CDCs or equivalent institutions to think about, whether they want to develop those, and then we can, help build the capacity, for those. And just because we're in this region in South Asia, I would say that we've recently supported a very interesting project that covers 8 countries in South Asia: Bangladesh, Bhutan, India, Sri Lanka, Maldives, Myanmar, Nepal, and Timor-Leste. It's almost $1 billion if you take the grants that the Pandemic Fund has provided, plus the co-financing that's coming in from the World Bank, the WHO, UNICEF, and FAO, and then the co-investment, interestingly, about $370 million of co-investment that the countries themselves are bringing to the project. And this promises to be, really a game changer, because it's going to strengthen collaborative surveillance across 8 countries in the region for timely detection. It's going to build environmental and wastewater surveillance systems to detect diseases with epidemic and pandemic potential, at the borders. It's going to improve laboratories and build a diagnostic network to characterize and confirm pathogens. And it's going to develop a regional health workforce. And India is actually, there's a big knowledge sharing dimension to this. India is going to bring lessons from its epidemic-ready primary healthcare system, the efforts that have been made on that, and share those lessons with other countries in the region. So stay tuned, but I think it's going to be very, very interesting. Thank you.
Very exciting. Firstly, to learn that there are resources to address some of these priorities, that this is being done and led, in fact, by countries themselves and collectively as well, and that institutions like the World Bank recognize the value of listening to the communities, much more so perhaps now than they did before, particularly in the context of crises such as the pandemics. I did also want to sort of leave a thought based on your intervention about, this inclusive governance structure, which I think you emphasized right at the beginning of your intervention, and how important that is. And also how moments of crisis, such as the COVID-19 pandemic, can induce a level of, urgency and solidarity that perhaps then diffuses over time, and how institutions like the World Bank and through its initiatives like the Pandemic Fund can actually sustain this and institutionalize this, and maybe that's something to reflect on. But before I get to that, I'm going to invite Dr. Jae Kyun Kim, who's the health specialist from the Asian Development Bank. You've, of course, worked in the region and in many countries of the region, and as part of the ADB, very much focused on the region and financing, as some examples have already come up. But I did want to ask you if you had some specific examples of, promising examples really of regional integration based on the experience of the ADB, particularly on issues that have already come up, the workforce, for example, but also things like supply chain resilience, the diagnostic aspect of epidemics. Clearly there is a lot more funding for it, but also, the data sharing aspects on a range of other issues, some of the core health system strengthening issues, as was mentioned by Dr. Indubhushan before. On a range of these issues, what if you had some, promising examples and also some lessons that we can take away from that? Over to you.
Oh, yes, thank you very much for the question. First of all, I would like to say it's my true honor to be in with the global leaders here in the panelists. Thank you very much for that. And for the regional cooperation, I'm very glad that I could build upon the intervention from Dr. Priya Basu from the Pandemic Fund. Because in ADB, we see the regional cooperation. There's a lot of potential, but especially in the pandemic preparedness and response. Because we saw during the COVID-19 pandemic, if you roll back like around 4.5 years ago already, which is around November 2020, we call that the era of hope and despair, because that was when the first COVID-19 vaccine has been developed, and everyone was so excited they thought the pandemic will be over with the vaccines. And it wasn't just one pharma company, there was various pharma companies from all around the world actually. And projection of the production was almost enough for the whole global population. But when you see the vaccine distribution, it was a whole different story. Like a lot of the low and middle income countries couldn't reach the enough vaccine procurement. And at that point, I think the countries and the population thought, oh, maybe there should be one more layer of work should be done above the global centric initiative. Of course, we had COVAX facility, which did a great job. It was a great initiative, but it was far from enough. And looking at the vaccine procurement from bilateral level, like there was a lot of cases where country A promised to give country B vaccines, but the demand of vaccine has changes for a lot of different variants. So the country A just cancels to give vaccines to country B, which caused a lot of frustration of head of the states because it's the life of their population in the health. So we thought that if there was some kind of a regional cooperation mechanism at that time, wouldn't it be better? So in the Asian Development Bank, we have launched an initiative called ADVANCE, which stands for Asia Diagnostics Vaccine Therapeutics Network to Counter Epidemics. And that initiative is mainly to better prepare for the next pandemic. So there are some key aspects of that initiative, which is regulatory capacity building, because we saw that the capacity of the regulatory system has been one of the big barriers. And also the regional regulatory harmonization and convergence, which will enhance the accessibility of the essential medical countermeasures. And also we are seeking a mechanism for pooled procurement, which is, however, not really easy in the Asia region. As Honorable Helen Clark mentioned, there's a really good mechanism in PAHO in the Latin America region called the Revolving Fund. And also in Africa, it's very active through Africa CDC, but in Asia, there has been some attempts, but not as successful as Africa or Latin America region. So we are discussing with a lot of international partners, DMC governments, on how we could do that. And also lastly, on the local manufacturing part, it's a little bit of a controversial area when you talk about access to medicine, whether local manufacturing should be there or not. But there has been some testimonies that during COVID-19, where country had the capacity of local manufacturing, they suffered less than the country who didn't have the capacity. But in the local manufacturing, now we see that the commercial viability becomes an issue. Like a big nations where there's enough domestic market, it's okay to just consume within the one nations. But for a small nation to have a local manufacturing, they have to think about exportation as well. And that's where also the regulatory harmonization, pool procurement, local manufacturing, it all comes under the regional cooperation. So there should be a really robust regional cooperation mechanism to make this all successful and happen. In ADB, we have some regional cooperation integration platforms called RACAREC, which is for Central Asia, SASEC for South Asia, GMS for the Greater Mekong countries. So we are trying to leverage those platforms and also discuss with the partners, development partners, academia, private sectors, and the governments to enhance this. And we will really need the guidance and advice from the global leaders who are seated here, from the experts from the audience here to make this happen all together. over from me. Thank you.
Thank you so much. I think you brought a whole range of issues, really. But the thing that I'm taking notes on, particularly from the agenda as we develop for the Asian Collective, is on this cross-regional learning and potentially the lessons that already exist from the more developed regions or regional cooperation mechanisms that are more developed, such as in Latin America, such as in Africa, and potentially what lessons they might hold for us here in Asia. Before I go back to the panelists, I want to open it up now to the audience, who've of course been here and listened to many of these conversations over these 3 days of this conference, but I'm sure many years of your own experience, so do bring that. Any questions, please raise your hand, and I'm sure the mic will come to you. Let's start there. Can we have the mic? And there. Please introduce yourself and also who the question is directed to.
Hi, I'm Priyadarshini. I'm a research fellow at the Center for Social and Economic Progress, and this question is for the panel as a whole. So I have two worries in mind. One is that if everything that we want for regional cooperation, for health, in the best case scenario, if all ducks align, what aspects of the health system would still not be addressed with the best regional health systems in place? And the worst case scenario, if you're not really able to get the regional momentum going, given the current geopolitical environment, what is the worst that can happen? And I want the panelists to be very explicit about it, that where are we going to fall down with our face on the ground if we don't get this going? And in the best case scenario, if we get everything in place, countries are cooperating, we have effective regional mechanisms, new ones that, for example, the pandemic fund, but also the existing regional cooperation bodies are able to take on board a health agenda and sort of build conversations and pathways, etc. That even if you have all of that in place, there are still these 3 or 4 areas of the health system that will not get addressed, and countries have to sort of pull up. Yeah.
Thank you for the provocative question, Priyadarshini. Before we go to the panel, I think we should take a couple more. So can we have the mic there?
Hi, I am Shirish Rao. I work as a researcher at Association for Socially Applicable Research and G4 Alliance Asia Working Group. So a lot of things that we discussed over a lot of meetings in the World Health Summit, as well as a lot of topics that we discussed here. Something that remains under prioritized in this region, but this region contributes a lot to the world, is the burden of diseases that can be treated through surgery. The region contributes to more than 1/3 to 1/5 of the diseases, as well as almost 95 to 98% of the population actually lacks access to surgical care. And from the global moment that is going on for the global surgery, a lot of regional cooperation has come up in the PAHO region, the WPRO region, and the maximum has been in the sub-Saharan region. And the South Asian region actually lacks a lot of policy priority, as well as the regional push towards going it forward. So I was I just wanted to understand what are the opinions of the current the policy leaders and policymakers on this regional partnership and prioritizing something like this as a part of the regional framework going ahead.
Understand it correctly? You're specifically asking about surgical care?
Yeah, surgical system strengthening and surgical care.
Sure. Maybe that lady, the back, and then this gentleman.
Good afternoon. My name is Vanshika Kant, and I work with the Asian Infrastructure Investment Bank, and this is a question to the entire panel. So of course, AIIB is the youngest multilateral institution traditionally and starting off focused more on hard infrastructure, now expanding more to sectors such as health. One thing I've noticed is that for countries in Asia, there's more appetite for projects in transport, energy, such sectors which are seen as more revenue generating. And while AIB is also trying to unlock more opportunities and scope for, I would say, grants and to bring down its concessional rate, we see that is a barrier, because while we have a lot of projects that are essential and are high quality, but countries then say that these are not revenue generating. So what could be ways in which Asian countries can come together to kind of solve for this? Thank you.
Gentleman in the front, and then we'll go back to the panel.
Okay, thank you. My name is Abbas. I'm from Tehran University of Medical Sciences, School of Public Health. Based on our studies and experiences, that it is predicted that the next pandemic will come later and soon. All of us heard about the pandemic X. And based on the pandemic of COVID-19, there are a lot of experiences, there are a lot of lessons learned that we should learn from the future. My question is about the new and the new established and new way for controlling this kind of pandemic in the world. Based on the population, the most vulnerable and the most population prone to the COVID and every kind of pandemics is Asia. Are we ready? Are we conducted new framework for cooperation and collaboration? Are we have new financing health and others? Thank you.
Great. So 4 interesting and different questions, but the first about the best case and the worst case scenario if we don't have regional cooperation. And then a very specific one on surgical interventions and care, and this idea of countries and their priorities of revenue sharing and how financing can address that. And finally, are we prepared for pandemic X? So we start off with this big picture question and end with another one. And who among the panelists? Please go ahead, Madam Clerk.
Well, I'm almost tempted to say that the worst case scenario is pretty much what we got with COVID. The world was unprepared. There was preparedness in a number of countries in Asia which had had experience of responding, for example, the SARS threat. But when you think about the response to COVID, everyone did their own thing. New Zealand and Australia closed their borders completely. Everyone did different things. We needed regional collaboration, and actually we didn't really have it. So I think, we've almost seen what the worst case scenario is, and it got away on us, right? So the best case scenario is that a pathogen is with pandemic potential is detected, and there's very rapid action, starting with the region where it appears. That's the best case. Are we prepared for disease X? Well, you see, we go through the panic and neglect cycle with pandemics. We've been through the panic, and now here's poor Priya with the pandemic fund, which the G20 working group under now President Tharman of Singapore estimated needed upwards of $10.5 billion a year investment. How much have you ever had in total, Priya? 3 in total, not a year. So we're well into the neglect cycle. And that brings me to make another point, which is that while, as Priya says, there's been some success in getting at least some contributions from global south countries, still the bulk of it came from the global north. The governance is sort of 50-50 north-south, which doesn't represent the world's populations either. And and now we have the global north, backing away from, the previous levels of commitment to solidarity funding of this kind. And this is where, the advocates of the global public investment concept come in. And it's a bold concept, and at the moment it lacks country champions. But in effect, what it's saying is, look, the new model should move away from donor-recipient to a model a little like assessed contributions for the World Health Organization or the UN, where there's a formula weighted by country's income per capita and ability to pay, and that everyone pays in according to their means. So Liberia pays very little. The US would still pay a lot. But everyone pays in. It means that the North gets much less say. It's contributing less because others are contributing more. But the emerging economies, the global South, get a very equitable say in the funds. And then the allocation is done according to need. So there's an enormous body of discussion and literature around this now. But it needs... And the view of those promoting it is that every new fund set up should be set up on these principles. Because otherwise I think new funds are... Not only new funds like Pandemic Fund will struggle to get what they want, but Gavi is now struggling to get what it wants. The Global Fund will struggle to get what it wants. So I just put that on the table. I completely agree with what Indu said about the distortion of priorities actually with the vertical funds. And I'll just tell one story. When I first went to UNDP, a resident representative came to see me from a country with a very high burden of HIV, and a country which was assisted by PEPFAR. And when this representative went out into regional areas with this PEPFAR funding and sat with the leaders in the community, they said, we're very worried about the way this funding is operating in the community. And she said, well, why is that? And they said, well, look, if you have HIV in this community, you get food because you need food to be able to absorb the antiretrovirals. But if you don't have HIV, you don't get food, and everybody's hungry here. So our people are saying we'd be better off with HIV. And, you know, it sits you up short, doesn't it? So there has been distortion of priorities, and even with perverse consequences. And I think, as Ilona said, you know, while this withdrawal of funding has had terrific commentary in the West, I think for many, particularly in Africa, they've seen it as an opportunity to break out of really the shackles of being told, well, we'll give you money for this, but not for that. And countries are starting to look at how they integrate their health funding. I think Uganda is now in an exercise to pull together what were completely different streams of funding and activity and to integrate activities, which wasn't so possible with the diversity of funds. So, look, you know, it's a challenging time. But I think there's a lot of opportunity in these times to think through models. You know, what could be done differently, better, new approaches, as Ilona challenged us, you know, new thinking, new approaches, and build on the dynamism and innovation that's coming out of the South as well.
Ms. Kickbush?
Yes, thank you. I think, yes, the regional approaches are absolutely essential, and, you know, but they mustn't turn into what we had in Europe during the pandemic. I mean, Europe was very successful in a second step, not in the first step, but in the second step to bring all EU countries together, you know, for joint procurement, all kinds of things, distribution, etc., but they shut out the rest of the world. So I think while one is looking at regional approaches, one will always at the same time have to say, yes, we want to work with and for our region, but we shouldn't build walls around us and watch the others die while we survive. And I think, in quotes, approach or model like that would be very, very dangerous. And therefore, to, on the one hand, you know, enhance and develop regional solidarity, it has to be linked to global responsibility. And that, I believe, is one of the lessons one should be learning from the pandemic. That's one point. The other is about, you know, we want roads, we want other things. I think we do have to become better. Also, the economists have to become better in actually showing not only the economic impact of health. A lot has been talked about health investment. Health is an investment, and you get a payback of this or that, and $1 and $8 and whatever. Mostly, though, for siloed programs, I might add, because it's so much more difficult to measure the impact of, a primary healthcare center than I've vaccinated 3,000 kids or something like that. But I do think a better understanding, and it links very much to what Srinath said, a better understanding of the health industry. And the understanding, for example, you take Germany, we have more people working in the German health industry than in the car industry. And most Germans don't know that, and most German economists don't think of that. And on top of it, it's the key area for employment of women. And that even more so in Asia. We also know this from Thailand, because most community health workers are women. So to actually make people understand that an investment in this sector is an investment in a competent workforce. And as we know, when women work, children go to school. It's, we do have to shift our arguments differently and not shy away from seeing health as an industry, as an economic factor of a different type. And the head of the African CDC says, we have a 50 billion vaccine industry waiting to be created here in Africa. And that means goods, that means services, that means people, that means imports, that means exports. I think we have to show this much more clearly than we have done before. And that leads to the third factor: what should we concentrate on regionally? We should concentrate in each region on cross-border issues in the region. And they are, of course, on the one hand linked to diseases and pandemics and all of that, but they're very much linked to non-communicable disease. Do you all want to look like the American population with 60% people overweight and obese? That's a question of the food industry. That's a question of import and export and of rules and regulation. And does one country do what the other country is doing? And it relates to tobacco legislation, of course. So I think looking at those kind of factors that actually are cross-regional, or, a factor like the digital and the AI development. We spoke about it in another session. The European Union has tried to give itself regulation. You can, have different opinions about it. But, will Asia, with maybe, India and China having very different models of digital development and digital health, what will the digital health exchange, the data exchange, the data solidarity look like within the region? So I think if one says regional cooperation, it's not for the regions, to start building primary healthcare centers. That's a national responsibility. But one can learn from each other. You mentioned Thailand. And introduce models, but to be much more precise and forward-looking in what are regional issues and how do they manifest themselves economically, and how then are we part of a global economic system, because then also it becomes an issue of global trade, of supply chains, and areas for investment, for example, in insurance companies in this part of the world. Thank you.
Thank you. Dr. Reddy?
I'll try and take the first two questions. The first question itself has two components. What will be missing? I think we must differentiate between governance of health and governance for health. governance of health essentially looks at how health systems are organized, and some of those mechanisms can be coordinated by health agencies, both nationally and transnationally. But governance for health means you'll have to address the commercial, environmental, and social determinants of health. And those are things that are not necessarily going to fit into some of these regional bodies or even international bodies. And for example, when you talk about tobacco, when you talk about ultra-processed foods, you talk about access to medicines and trade in medicines. Many of these, and of course, a lot of other determinants, they're not necessarily going to be solved even through bodies which are actually set up for regional cooperation. So you'll have to really focus many other efforts on that. The second element is what can go wrong? Of course, World War III. But leave aside World War III, even regional conflicts can destabilize. Other pandemics or even near pandemics, regional outbreaks can destabilize supply chains. A lot of cooperation can go flying out. But having said that, even during those times, it need not be government-to-government collaboration or cooperation. The civil society remains a very vibrant link. The academia and the researchers, they remain a vibrant link. The technical people continue to be engaging. Even if we are having problems in South Asia, the people who are monitoring the weather patterns and the rainfall patterns are still exchanging information across the borders of India, Pakistan, Bangladesh, and Bhutan. So those links will remain. The civil society continues to engage across the borders. So it's not as though it's only governments that are responsible for these collaborative ventures. Then the second question is about surgical systems. Well, surgical systems were not really looked at in terms of the important priority after the global burden of disease, but then there have been several corrective measures taken. Dean Jameson, who along with Larry Summers actually proposed investing in health, has actually brought in the absence of surgical systems as an important element. Now there's a group from Birmingham which is leading a major effort internationally and is linked to the Global Alliance for Health Systems and Policy Research in Geneva. And the idea of actually bringing in surgical services much more important centrally into health system configuration, including primary care, not just secondary and tertiary care. Those efforts are going on. So it's a bit of a late entry, but not completely absent.
Yes.
I'll respond to first and last questions quickly.
Please go ahead.
On the first one, the role of regional cooperation and integration in health, large proportion of health interventions have to be done at national level, actually at sub-national level and community level. So the role of regional cooperation, of course, very important, is I would say marginal for large countries like India, but very important for small countries because they don't have economies of scale. In that sense, they have to rely more on collective action. And if it doesn't happen, probably impact of that will be differential. In some countries, probably not much impact or marginal impact. In other countries, large impact. But there are some things that, there are win-win situations. No one is losing and probably everyone is going to gain. And all of you know SMTP, right? Simple Mail Transfer Protocol. So all email applications follow SMTP. And that's why when we send in email from here, we can send it to the US, New Zealand, Africa, everyone, and receive emails from all over the world. And we are developing EHRs right now, and all of, in different countries, we are following different kind of protocols. Can we harmonize those so that we move a lot? Can our EHRs move with us from India to the US and within US to different hospitals or any other place? So I think we are at the cusp where digital health is becoming daily part of daily lives, and having standards which are common all over the world would be important, and everyone is going to be benefiting from that. Similarly, what Jacob was saying about harmonizing all the regulatory requirements would probably help everyone. So those are things which are probably low-hanging fruits where no one is losing and probably everyone is going to be winning.
Thank you. Dr.
On-
Basu?
Last question on
Sorry.
Vanshika. It has been, I joined ADB in 97 and my first job was to go to Sri Lanka and convince the government to take a loan on health. And despite my 3 days of discussions, they didn't take the loan on health because they thought that, that's something we can do. We don't need money for that. We need money for roads, which are much more expensive. And but what I've seen is that over time, 20 years, I saw that as countries progress, their priorities change and they want to take loan for softer sectors. And towards the end of my career in ADB, I was Director General for East Asia. And I fell out of my chair when China asked for loan for working on elderly care. Because that was the first time they were looking for something which is so soft and where probably, because as countries have more money, they can do roads and trains and everything else themselves. They're looking for knowledge, they're looking for ideas, they're looking for international experience, and they would come to you. And therefore, you would find that health sector there will be great demand from health sector from upper middle income countries and countries which are have done quite well in terms of infrastructure already.
Very important point. Thank you. Dr. Basu?
Yeah, maybe just building on that point that was made. So, in terms of the grants that we're providing, they're actually, we're blending them with the concessional loans of the World Bank, of the ADB, and so on. And we're finding that that's a game changer. The blending of the grant and the loan makes it a lot more palatable to countries. And that was actually a concept, and now we've seen proof of concept because there's tremendous demand. I mean, I'll give you an example. A country like Guyana, it wanted to invest in pandemic prevention, preparedness, and response. My colleagues on the other side at the World Bank were trying to convince the government to take on an IDA credit. Guyana is a high-income country, but they're eligible for IDA. So there was this conversation going on, and Guyana was saying no, 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 and then the pandemic fund came along, and we blended our grant with the IDA credit, and it became appealing. So we're seeing a lot of that. A lot of countries that wouldn't have taken a pure concessional loan to invest in this agenda are incentivized to do so if there's a little bit of a sweetener. Just to the question around, are we ready? Are we prepared? No. Should we be? Yes. There's real urgency. There are a lot of studies, one that I was just reading the other day, that says there's more than a 50% chance of another COVID-like pandemic happening in the next 20 to 25 years. And with climate change, conflict, migration, changing biodiversity, land degradation, water shortages, this risk is even heightened, more than ever. But I think, we are living in a world of uncertainty. We're living in a world where there's growing pressure on development, on traditional development financing. All countries are looking inwards. I love the idea of every country providing some resources, however small. I was at a meeting with Jean Kaseya the other day, the head of the Africa CDC, who promised me that he'll get 20 African countries to commit even a small amount of money to the pandemic fund. Let's see. But while that's happening, and as we move to this global public investment type of model, which would really be ideal, we're being innovative. We have to think outside of the box. And what we're doing is we are working in a catalytic manner. So what we're saying is every dollar of grant money that we award, coming back to Vanshika's question, every dollar of grant money that we award, we're asking the existing international institutions who are our partners on this, the MDBs and so on, to bring their own co-financing. And we're telling the governments who are receiving our money, we're telling them, as long as you're not debt distressed, if you're debt distressed, you're not expected to do anything. But as long as, if you have the capacity, you've got to bring your own money. You've got to put your own skin in the game. You bring your co-investment. And that's how we've managed to achieve a leverage ratio of 1:7 For every dollar we award, we have mobilized $7 additional for the project, and we hope to build on that. And we're thinking of other ways to be innovative. Maybe at some point we'll issue pandemic bonds, we'll go to the capital markets, but let's see. But I think all of us, we're not living in the same world as we were a few years ago. We've got to think about multiplying, scarce donor money and trying to make, the most of it on the ground.
Thank you so much. I think we've run out of time, but I hope that those of you who still have questions will find the panelists. But I really do want to appreciate the range of discussions and the panelists that we've had. And really the one big takeaway that I have here is, in these times, we all need to be agile, dynamic, and innovative. And really, there is this continuum from national, regional, global that we have to keep going up and down in a dynamic way. There's no more, very rigid, hierarchical, or sort of, dark, thick lines of separation between these, these at all levels for all of our activities, whether we're engaging in, domestic health system strengthening, research, or we're engaging in negotiations. So thank you so much for that rich discussion, and hope we can continue this conversation at this and other forums. Thank you very much.
Great discussion. Hopefully we can continue to come back to you as a little bit of time. So, nice to meet you. Yes, yes. I don't know that week's going to suit me, unfortunately, because you changed the date, didn't you?
Oh, no, the symposium is in the 11th of July, if I'm not mistaken.
No, that's right. I was supposed to be in Morocco.
Oh,
I haven't come back to you.
No worries at all.
Down one, back
Sure.
one way or the other, because I'd like to. Yeah.
I promise you, it's not going to be intense like. Oh, thanks. Please on your continue. Oh, yes. Thank you so much.
But these institutions have in their the case in the world, they work together.